I have a question. Any specific precaution you would suggest when we give ECT to elderly people?
Particular assess, there has to be a checklist that can be done to assess whether risk factors that were established in these studies, thyroid hypothyroidism, thyroid disorders, then hypertension, type 2 diabetes, and past history of any other CVS. These histories can, these checklist, if we apply, this can help us to prevent unwanted.
Any blood parameter like cholesterol?
That was also done in this, but they, in our study didn't show any
Significance. Okay. So thank you very much. Thank you. Thank you. Very good presentation.
Thank you.
You kept up the time. Congratulations. Second paper.
Second presentation is about development of standard operating procedure for tranquilization of older adults attending emergency psychiatry services. This is Dr. Samiksha Das, Dr. Vijay Kumar, Dr. P.T. Shivakumar, Dr. Preeti Sinha, Shentil Reddy, and Dr. Krishna Prasad from the Department of Psychiatry.
Please tell your name.
Dr. Samiksha Das.
Samiksha Das. Okay. Your time. Are you ready now?
I need the mic, sir.
Yeah. Please. Let me know.
I need the mic, sir. Yes.
Yes. Time starts now.
Good morning, everyone. I'm Dr. Samiksha Das, and today I'll be presenting my paper on development of standard operating procedures for tranquilization of older adults attending emergency psychiatric services. So these are the authors. So coming to, and there is an increase in older adult population globally, and this necessitates focus on geriatric mental health. And the most common reason for emergency consultation, what we found out, is severe agitation or aggression in these people. And rapid tranquilization is an intervention that can calm down these patients and reduce the risk of harm to self or others without causing sedation, so that they can take part in further assessment and cooperate in the management. So there is a lack of proper guideline or SOP for tranquilization in elderly, and this has led to indiscriminate use of drugs and adverse effects in the elderly. So coming to my study, it had two components. The first component was a descriptive study, which is a cross-section and retrospective file review. It was done mainly to see the current practices of prescribing drugs for tranquilization in elderly, case files of older adults admitted to emergency unit and who were administered oral and parenteral drug for tranquilization were reviewed over a period of 1 month, and equal number of files were reviewed retrospectively. Coming to the formulation of SOP, that was done in 3 steps. The step 1 was review of literature, from which an interview guide and a survey questionnaires were prepared. This guide and survey questionnaire were used to do focus group discussions and online surveys, which involved resident doctors of Department of Psychiatry. The online surveys were distributed by Google Forms, and audio recordings after FDGs were taken after consent and transcribed. Step 3 was expert consensus by Delphi method. 20 experts were contacted globally via electronic mail, out of which 12 responded. And the content analysis was done using Atlas D to generate themes and sub-themes. So this is the file review we could get. In the month of May, we could get 5 patients who had been tranquilized using pharmacological agents. I added 6 more to make it 11 in number. So we can see that the most commonly agents used are lorazepam, Q-tipin, haloperidol, IM. Sometimes clonazepam was used, and sometimes a combination of haloperidol and lorazepam was used. There was improvement noted in all of these agents, which suggests the efficacy of these agents. Adverse effects noticed was sedation. IP care was suggested in all of the cases, almost all of the cases, which suggests how serious the condition was. So coming to this review of literature, we included guidelines, systematic reviews, RCTs, observational and retrospective studies published in the last 20 years. The search engine used was PubMed and Google Scholar. There is definitely a dearth of literature when it concerns tranquilization of elderly. And we could, the literature highlighted was the challenges in tranquilization of elderly. In antipsychotics, when we use antipsychotics in older adults, there is a definite increased chance of EPS, cerebrovascular adverse event, all cause mortality in dementia and QT prolongation. In benzodiazepines, we can see disinhibitory or paradoxical reactions in elderly, respiratory depression, prolonged sedation, falls, and deliriums. One primary thing was noted in all the literature was oral therapy. To start with oral therapy, as it has less adverse effects, longer therapeutic duration, slower onset of action, and but it requires patient cooperation. So lowest possible dose and allow adequate timing. This is the focus group discussion on online surveys what we did. So what are the salient points we noticed that the residents feel that that tranquilization needs to achieve sedation, which is actually not the case. It was an infrequent practice, and antipsychotic benzodiazepines and combination was used, and when needed, they switched to parenteral different class or combination. This is the expert consensus form that we shared with the experts. And what we found out that the most preferred agents were Q-tipin, olanzapine, and lorazepam. They instructed limit use of combination of agents, and lorazepam as not preferred first line of tranquilization, and Q-tipin preferred in cases of Parkinson's disease and Lewy body dementia. With all these steps, we could come up to an algorithm for rapid tranquilization of elderly patients. So to start with, whenever we get a patient, older adults with more than 60 years with agitation or aggression, the first step will be to assess the agitation level. This can be done by a brief scale that is like Richmond Agitation Sedation Scale. What it will do is we can quantify the agitation and we can establish the baseline of agitation. The second step is to do an initial medical review. For the purpose is to rule out delirium and to rule out reversible causes of agitation and to review medical history and to check for any contraindication of medication, especially those related to cardiovascular or respiratory health and any potential drug interactions. And also monitor vital signs. Then, first step should always be an agitated adult is to go for non-pharmacological intervention, which is either environmental modification. If the place is too noisy, you calm down you quieten the place, or a verbal de-escalation should be tried. And if these things are not working, you can start a pharmacological intervention. And the first thing is oral medication. And the oral medication can be given are lorazepam 0.5 to 1 milligram, olanzapine 2.5 milligram, Q-tipin 25 to 50 milligram. Later, we can also use haloperidol 2.5 and promethazine. Promethazine is kept lower in the list because it has anticholinergic property and can cause delirium in people with dementia. And you monitor for 45 to 60 minutes. As you know, in older adults, the clearance will be a bit slower, sometimes renal is compromised. So we need to give enough time for the drug to act so that we do not give drug stacking and accumulation of drugs. If the first round does not work, we can go for another oral medication, either from the same class or a different class, and then again wait for 45 to 60 minutes. If there are 2 failed attempts of oral medication, then we can go to parenteral medication. Another thing you have to notice, if the patient is very agitated, very combative, it is very difficult to control him, there is a high risk to self or others. We can quantify it as RESS +4, and if the patient is not cooperative for oral medication, we can go for parenteral medication directly. And the parenteral medication are IM lorazepam, IM haloperidol, IM olanzapine, IM promethazine, combination therapies. Combination therapies are kept lower in the list as it can cause adverse effects, and our expert also are of the opinion that it should be used limited in older adults. IV lorazepam 0.5 to 1 milligram. IV can be used, but it will cause sedation, which will not serve the purpose of tranquilization, and sometimes it can lead to sedation and respiratory depression. And then again, you have to wait for 30 to 60 minutes for the drug to act, not go on, keep giving. Then if it is not working the first round, you can go for the second round. Another thing to see is if the patient, you are suspecting him to have Lewy body dementia or Parkinson's disease, the options are Q-tipin, per oral, and lorazepam, either per oral or IM. while all this is going on,
significance to presence or absence of psychotic symptoms, which need to change when and might be not be generalizable to the other treatment settings. These are the future directions.
So thank you very much. Good presentation. So doubts and questions, please. Yes.
That was well presented. How was the sample size calculated?
Ma'am, it was an exploratory study, so we did not calculate sample size. We took consecutive samples for around 6 months for all the elderly patients of delirium that we were seeing in the CL basis.
So you mentioned the study design as descriptive case control study. That is why I asked that question, because your objective was to find out the prevalence. For that you require a cross-sectional study, not a case control study.
I think I mentioned.
That was what you showed, a descriptive case control study. That was why I asked that question.
Sorry.
Here? Yeah.
Thank you for your very interesting presentation. I had a question about the characteristics of the patients who you get referred to with delirium. In a consultation liaison setting, I'm assuming that patients who are more disruptive or have more florid symptoms will automatically get referred to psychiatry, whereas those with delirium who, say, for example, hypoactive delirium won't. So you have a sort of sampling bias here. How would you sort of base your study findings considering this bias? Thank you.
Okay. Thank you, ma'am, for your question. Yes, I do agree that in a general consultation liaison setting, that is how the scenario is, the more agitated patients get referred. But for this scenario, it was like I was doing a CL psychiatry fellowship at this time, and I was getting posted in these departments. So I was able to screen patients irrespective of their hypoactive or hyperactive status, and we had almost 60-40 distribution of hypoactive and hyperactive delirium. So that way we were not having sampling bias, but yeah, in any other CL setup, I think that bias will creep in. Yeah. Thank you.
Anybody else?
Can I? Yeah. No, can we presume that all patients who might have delirium were screened by someone, and the whole sample included only people with delirium during the 6-month period?
Yes. Yes.
Okay, then it should be mentioned as a strength.
Yeah.
Yes, I agree with you.
Yeah. Thank you.
So thank you. I invite the fourth paper, Lessons for the Young from the Oldest to Old, Understanding Cognitive and Physical Dimensions of Successful Aging.
Good morning, respected teachers and my dear friends. Greetings from the Center for Brain Research where I work. My name is Dr. Thomas, and I will be discussing about some of the work which we have done in understanding the lessons that the oldest old teaches. So by oldest old, you mean people who are more than 85 years of age. And we have very few of them, unfortunately, in the Indian scenario, and we hope they will increase. So healthy aging is defined by WHO as the process of developing and maintaining functional ability that enables well-being in older age. So it's mainly the functional ability that is more important, and that it should enable well-being. And there are strategies to understand healthy aging. This includes looking at aging cohorts in detail, looking at elderly who had successful aging, that is the super agers who have better cognition compared to their younger counterparts, and then looking at blue zones. So there are different blue zones across the world. There's a lot of attention in that particular areas as well. Now from 2021 to 2030, this is known as the decade of healthy aging, and it's very fortunate that we have this particular kind of session here. So if you look at the classification, this is the UK-based classification, where 65 to 74 years is the young old, 75 to 84 is the old, and more than 85 years are considered as the oldest old, 85 years and above. So the oldest old live much longer than the average life expectancy of 71.3 years in India. And they represent an ideal population to study the healthy aging. Now the aim of our study was to identify the prevalence of oldest old in the rural and urban cohorts. So I will be telling you something about the kind of work we do and how we recruited as part of methodology to identify cognitively and physically successful agers and to understand characters that differentiate cognitively and physically successful, typical, as well as those who are vulnerable when they age. So the methodology, so at the Center for Brain Research, Indian Institute of Science, we run 2 large cohorts on aging. That is, they are healthy individuals, non-dependent individuals, and they are recruited after the age of 45. So we have the urban cohort, which is known as the Tata Longitudinal Study of Aging, which started in 2015. And then we have another rural cohort, which was also initiated by the initiatives of NIMHANS at the Srinivaspura Taluka of Kolar district, which is known as the Srinivaspura Aging, Neurosciences and Cognition Study. So we have an urban study, which includes 1,000 individuals, 45 years and above, and a rural cohort, which involves 10,000 individuals, whom we follow up every 2 years, and the urban cohort, we follow them up on an annual basis. So the sample size for the rural cohort is 10,000, and for the urban, it is 1,000. And we do whole set of assessments. We look at the medical history, look at the biochemical blood biomarkers. Apart from the blood biochemistry, we look at the cognition by Hindi mental status examination, Addenbrook's cognitive examination, as well as the cognito battery, physical evaluation, clinical dementia rating, looking at the lifestyle factors, anxiety and depression as well. And we look at the behavioral history as well. So in this particular study, we try to look at the number of oldest old in both the cohorts. In TLSA, that is the urban cohort, we had 23 people who were more 85 years or above, and SANSCOG, we had 80 people. So if you actually see the proportion in terms of the population, it is only 0.015%. And for a rural, it was even less, 0.009%. So that is the kind of numbers we have. And total number of oldest old in our cohort was more than 100, just 103. We looked at cognition as well as physical strength. And the people, this was very important because all the people who are cognitively successful aging don't have physical successful aging, and vice versa. Those who are physically successful may not have the cognitively successful aging. So we tried to differentiate that. Based on HMSE, we identified 3 groups. People who are vulnerable, that is 27 people. People who had HMSE between 25 to 30 as typical ages, and people who had consistent HMSE of 31, that's a full score as successful ages. So we had 3 groups. And physical strength also, we looked at the hand grip strength as the proxy for physical strength. And therein we identified there are 21 successful ages compared to 47 typical and 22 vulnerable ages. Now these are the results. So I'll try to give a glimpse of the result in a comprehensive manner. If you look at the BMI, the successful ages, the BMI was in the range of 23. That means they had a better or higher BMI, and this was significantly different between the groups. If you look at the groups based on cognitive functions, it is the, if you look at it's the males who are more successful. And if you look at the education factors, that is also very important in the successful age group. Smoking was also identified to be a significant factor in the successful ages versus the other groups. More importantly, social networking. And that is through the Cohen Social Network Index. It was identified that they had successful ages had better cognitively successful ages had better social networking. Also, if you look at the physical activity, that was also significantly important, statistically significant. The reason is cognitive functions is dependent on the physical, is associated with physical activity levels. But physical activity is not exactly a direct measure or associated with cognitive functions. We looked at the total cholesterol, LDL, and vitamin B12 levels. There was significant difference in the successful ages compared to the vulnerable and typical age groups. and also the systolic BP. So actually systolic BP was more in successful ages, and there have been studies which have shown that in elderly, the BP threshold is different, and it's wrong to actually make them hypotensive based on the guidelines, wherein there's a strict guidelines to reduce the BP. BP control should be more in the middle ages rather than the late life. And then frequency distribution, if I were to tell, of cognitive and physical ages. People who are cognitively successful and physically successful, there were only 3 people in our entire cohort. So that is something very important. But if you look at vulnerable, there were 7 people, both cognitively and physically vulnerable. And typical ages constituted maximum proportion in our particular cohort. So this is some interesting findings which we have got. So just to conclude, physical aging is not physical strength is not associated with any clinical parameter except from the body mass index. And cognitive health is associated with wide range of parameters, including physical health, metabolic health, social and lifestyle factors, which I described before. And it is seen that several factors that were found to be associated with cognitive aging were listed as potential dementia risk factors with the Lancet Commissions of 2024, which came this month, and it is directly showing that many of the midlife vascular risk factors are predictors of dementia. And we found that these risk factors were significantly less in people who were successfully aging, especially with cognitively successfully aging group. And this emphasizes the validity of dementia risk factors to predict cognitive function in a cohort of dementia-free old adults too. So with this, the future directions are actually to do more research in the low and middle income countries on dementia and geriatric neuropsychiatric disorders. That is a very urgent need. We have to also understand geriatric syndromes and frailty in more detail. And if you actually look at all the factors, it is primordial and primary prevention that is more important in the context of India. So we had tried to look at it. We had actually had a publication very recently because of the World Alzheimer's Month on aging and dementia in India, and the directions we need to take for comprehensive research in this particular area. I also asked ChatGPT what would be the future of dementia, and DALI actually gave me a good picture, and it shows that there is yoga, there is social networking, there is more of interaction, and I think that is the way forward, and we have to again stick back to the concept of prevention is better than cure. I thank you for your patient listening, and I'm open for questions.
Thank you, sir. Doubts, questions? Yes, sir.
Excellent work and excellent presentation.
Thank you, sir.
I was puzzled at the physical activity. Looks like the fit people or the not vulnerable people were less active than the at-risk people.
Okay. So yeah, that's a very important factor. Now the physical activity rating is something which is also important. Many a time we use the historical kind of evidence. We ask them how physically active they are. There is a physical activity questionnaire which we also use. But the physical activity questionnaire looks at physical activity at early life, midlife, and late life. So it's more important to actually understand the current physical activity. So for Indian standards, the physical activity differs from somebody who is a manual laborer to somebody who is doing some more of a tertiary job. So there has to be questions tailored for that. That could be one of the reasons. And another reason is that our group didn't have a big sample size. So we cannot make big inferences out of this small sample size. So we tried to kind of look at it.
Thank you. I have one follow-up question.
Yes, sir.
So you looked at BMI, and you looked at the BMI as a one-time snapshot. Perhaps a change in BMI would be more meaningful, and since you have waves of data, maybe that's something to look at.
Absolutely right, sir. So this is a cross-sectional study, and it brings its own limitations. Now we have to look at the cognitive trajectories and the physical health trajectories of these two people across time. And when we do that, so our next work is on the successful aging actually, where we are trying to look at the cognitive determinants as well as physical determinants of maintaining a healthy trajectory across time series. So thank you, sir.
That was a good study, as sir said. 2 questions.
Yes, ma'am.
How was this cohort of 10,000 and 1,000 assimilated? One.
Yes.
Second, what was the statistical test that you used to compare?
Yeah. Very important questions, ma'am. So the cohorts for the Tata longitudinal study of aging, it was more of a convenience kind of sampling because it was a pilot study. It was urban and it was recruited by more of word of mouth as well as awareness initiatives. So we used to go to residents associations and senior citizen forums, Lions, Rotaries, clubs, and we tell them about this particular study which is happening. So this gave us an idea that, okay, this 1,000 sample is not very representative of the entire population. So Bangalore is like people in this hall. We are from different parts of the country or the world. And this is what is representation of Bangalore. So if you actually do a study in Bangalore, you may get the worldwide high and medium income group kind of cross-sectional picture rather than low and middle income kind of people. So we were actually, unfortunately, excluding the rural, urban poor. So with that in mind, we thought that a rural study would help. And that's when this served as a pilot for the rural. Now the recruitment in rural happened through multiple stages. The Srinivaspura Taluka was identified because it's about 100 kilometers from Bangalore. So why 100 kilometers? Because these people are brought to CBR and their imaging is done. So for the logistic purposes, we did that, and the blood is also collected from there. And we identified Srinivas Taluka with the help of the community medicine team at NIMHANS and the geriatric psychiatry team at NIMHANS. There was also an active liaison with the primary healthcare centers there. And they used to help us in identifying the different villages in Srinivaspura. And that's how the center was stationed at Srinivaspura. So if you actually tell me how was the sample size calculated, there was no clear indication as based on a strategy of previous kind of literature about the effect size or anything. We actually looked at it based on how the population ages. And when we looked at the other different longitudinal studies across the world, for example, the TILDA, that's the Ireland longitudinal study of aging, or the ELSA, or the Nicola. So there, they also followed a similar strategy. And Framingham was something which we considered as the base. So that's the reason we choose one particular place in Srinivaspura.
I have a question too. Yeah, I have a question. Because in India, we believe that religious and spiritual activities enhance the healthy aging. Was there an attempt to find out what kind of religious, spiritual activities, even the slide showed that message.
Yes.
Did you make an attempt, or are you planning to include that as one of the parameters to enhance the healthy aging?
Fully agree, sir. I think that's a very important concept. So actually, the target of all these studies is to make India a blue zone country. Everybody should live long, live healthy, and have a prosperous life. For that, we looked at the blue zones in India. And when we did that, we found that all the blue zones, that is people who are centenarians, 100 and above, many of them live in the north as well as not in northeast or south. It's actually the belt in the Himalayan region. And we try to explore the reason. The reason is it is predominantly of vegetarian diet, spiritual, and it also correlates with the density of the temples. So this is something which has its own controversy and requires more research into it. But what we say that more than religion, I think the spiritual discipline way of life and will actually reduce the risk of vascular and metabolic risk factors. That is what is more important than the other aspects.
So thank you.
Yeah.
Thank you very much.
Thank you, sir.
Last paper, I invite a comparative study of prevalence of behavioral and psychological symptoms in dementia and caregiver stress amongst dementia patients living in home care or in residential care.
Can I start, sir? A very good morning to everyone. As we all know that BPSDs are observed
Speak into the mic.
BPSDs are observed across all the stages of dementia. Around 80 to 90% of people with dementia have at least one of the BPSDs causing high caregiver distress. Majority of patients in India are cared at home by immediate family members, either due to the personal choice or due to very few dedicated residential and respite care services in our country. There are limitations to the treatment of dementia, and progressive nature of the disease makes it more difficult. Dementia training, care and support system are at still developing stage in our country, and caregiving is the most important aspect of dementia management and outcome. Although caregiver distress can be multifactorial, the type of caregiving setting, that is home care or residential care, can play a crucial role. Home caregivers with lack of training and support often are exposed to more severe BPSDs and higher distress, whereas it is possible that patients living in long-term residential care may get better appreciation of BPSDs and their management by trained caregivers as compared to home caregivers. With this in our mind, we wanted to study the frequency and severity of BPSDs in home care versus residential care, and to clarify the differences of BPSDs and caregiver distress amongst these two groups. We also wanted to explore whether the type of caregiving setting could be an independent risk factor for severity of symptoms and caregiver distress. We did a comparative cross-sectional observational and exploratory type of a study with 62 patients, 30 home care, 32 residential care patients with the age of 60 or more with primary diagnosis of Alzheimer's dementia. For home care group, patients provided care in home by family members who are already on treatment for dementia and their primary caregivers who spend minimum of 4 to 6 hours of time in caregiving for at least 6 months. And for residential care group, we selected patients living in residential care for minimum of 6 months and their formal caregivers who spend most time with patients, located at Shamshabad, Hyderabad. We excluded patients with Alzheimer's dementia, patients with previous and present comorbid psychiatric illnesses, and non-consenting patients. Diagnosis was based on DSM-4 TR criteria. ACE3 was administered to confirm the diagnosis. Written informed consent was taken, and ethics committee approval was taken. We use tools as CDR, Clinical Dementia Rating Scale, which has global rating of 1 for mild, 2 for moderate, and 3 for severe dementia. Barthel Index of Activities of Living was used to measure the level of dependence on caregivers. NPI inventory to study BPSDs, which has 12 subdomains of behavior functioning. The 12 items were registered as present, not present during past 4 weeks for frequency, severity, and caregiver distress. We used established cutoff item score as it was used in earlier studies. Item score frequency into severity score of 4 or more to indicate a clinically significant symptoms, and caregiver distress cutoff was taken as 3 or more. Statistical analysis was done by SPSS 23 version. Continuous variables were described as mean and standard deviation, and categorical as number and percentage. A comparison used chi-square test. Linear regression was conducted with continuous caregiver distress score as a dependent variable and NPI item score as independent variable. We dichotomize item score into more than 4 and less than 4 to identify a clinically significant symptoms, and caregiver distress scores into more than 3 and less than 3 to identify moderate to severe level of caregiver distress. We observed that in home care group, mean age was observed to be 68.9. 60% were females and 40% were male, whereas in residential care group, mean age was observed to be 73, out of which 53% were male and around 47% were females. In both the groups, on an average, patients were belonging to education level of degree. As per CDR score, we observed that majority of patients in home care group were belonging to mild dementia category, that is 86.7%, whereas in residential care group, majority of patients were belonging to moderate dementia category, that is 62.5%. The mean BIADL score in home care was observed to be 11.7% and 9% in residential care respectively. But as a combined moderate to severe level of dependence was observed to be slightly higher in home care patient, that is 57%, that is, and residential care group, it was 40%. We observed some of the symptoms like irritability, apathy, agitation, anxiety, aberrant motor behavior, it were highly prevalent in home care group, whereas apathy, anxiety, agitation, followed by irritability were also highly prevalent in the residential care group. While studying the item score, that is frequency into severity, we found that statistically significant difference for apathy, depression, aberrant motor behavior, and night behaviors in home care group, whereas statistically significant values were also observed for distress in home care group for delusions and depression. We tried to compare clinically significant item score, that is item score more, with moderate to severe caregiver distress score of more than 3 or more. We observed statistically significant values in home care group for apathy, delusion, depression, and depression. We also observed that delusion and depression had statistically significant value to produce moderate to severe caregiver distress, whereas we did not observe any significant values to be causing distress amongst residential care groups. The linear regression analysis taking caregiver distress as a dependent score and NPI item score as independent variable, the R-square values for majority of items were found to be significant in both the groups, especially for delusion, depression, disinhibition, aberrant motor behaviors, and agitation. Irritability score of R-square value 0.59 did not highly predict the distress in home care, whereas agitation score in residential care group also did not highly predict distress in residential care group. We also observed clinically significant symptoms across various stages of dementia. We observed that patients belonging to home care group, there was high prevalence of clinically significant symptoms in patients belonging to mild dementia category, whereas in residential care group, it was more observed in moderate dementia category. But overall, in residential care, clinically significant symptoms were observed in less number of patients across all stages of dementia. We also compared distress along the different stages of dementia. We observed distress caused due to some of the items like night behavior, apathy, depression, and hallucination and irritability to be high amongst home care group, also belonging to mild dementia category, whereas the similar difference was noted in residential care, which was more in moderate dementia category. But overall, it is clearly evident that residential care group, less number of carers across all stages of dementia had distress. Overall, home care patient had high prevalence of BPSDs as compared to residential. Delusions, depression, night behaviors, aberrant motor behavior, apathy were significantly high in home care group. Overall prevalence of caregiver distress was also observed to be more in home care patients, especially significant with depression and delusion. No significant distress was observed in residential care group. The distress perceived by individual clinically significant symptom varied across two groups, that is with type of caregiving. Distress observed due to apathy was observed to be equal in both the groups irrespective of stages of the dementia. The dependence level of activities of daily living were found to be more in home care patient as compared to residential care. Despite severity of dementia, it could be explained as there is more understanding and supporting of independence of patient by formal caregiving in structured environment of residential care, whereas family or home caregivers may tend to minimize their independence to their loved ones. Hence, there is need to encourage supporting independence by just minimum assistance so that it improves the quality of life of patient. Home care patient with more symptoms and more distress belong to mild dementia category, whereas residential care patient belong to moderate dementia category. This can be explained as mostly in Indian setting or family members, they put their maximum efforts to manage patients at home in initial stages of disease, either due to their individual choice, financial reasons, emotional attachment, or as a feeling of sense of obliged responsibility towards them. So without training support in home caregivers, symptom severity is likely to increase, can lead to more distress and depression. With demands of continuous caregiving, these family members are more at risk of poor outcomes. Caregiver factors can also trigger some of the BPSDs. Hence, a comprehensive intervention and training of caregivers in both formal and informal setting can break this vicious circle. To conclude, I would like to say both the groups, home care and residential care, were comparable. Home care group patients had more exposure to clinically significant symptoms leading to more distress. The prediction of caregiver distress based on symptom score varied by individual symptom, caregiver type and severity of dementia. Formal caregivers in residential care group had exposure to moderate dementia patients, while home caregiver had mild stage of dementia. Our study highlighted that comprehensive training and caregiver support and better access to resource should be established since the initial stages of dementia for better outcome. Type of caregiving was observed to be contributing to BPSD and distress in our study. We had some limitations, and these are the future directions for our study. Thank you.
I have a question to ask. Why you selected the home group with mild dementia and the residential group with the moderate dementia? Because they are not comparable.
We did not select it particularly, sir. It was observed that the patients we selected for home care group were belonging to mild dementia category.
On the other hand, I would have suggested to select the comparative groups. Home care is a mild, similarly residential care mild, or vice versa. Otherwise, no, that's an important variable
True, sir.
which determines the psychological and behavioral disturbances. Anyway, yes.
Did we look at the medication usage in both these groups?
We did not do
so,
that.
So maybe
Yeah.
the residential usage, folks may be using more medications and may have less symptoms. Maybe that's one of the
Possibly,
reasons.
ma'am, but in this study, we did not try to study the effect of medications, which we have in our future implication studies.
Maybe you could control that
Yeah,
for
yeah,
your
that,
study.
yeah.
Yes. The second follow-up question was, do we have the education level of the caregivers, like in the residential group and then the home care group? Because if they are educated and know how to take care of patients, maybe they might do a better, could have done a better job.
No, education level of caregiver was not studied, but we tried to compare in terms of whether they have basic understanding about the caregiving or not. Where in residential care, from which we selected the patient, they had basic training how to manage the dementia symptoms and yeah.
Thank you. Very, very well done. And we see the same kind of spread and prevalence back in US as well.
Thank you.
Mike, please.
In any sort of a setup, okay, we think that many of it is because of the disease condition and their inability to do things. Abuse, either neglect or physical or psychological, considered for one of the reasons for, and then looked at it?
So, abuse can result as a result of poor understanding of caregiver about the BPSDs, and there also if they yeah, it can be one of the cause also, and because they have less time to interact with the patient because of the other responsibilities, whereas it can be observed, it was observed in some of the studies, it was observed lesser in residential care patient, where patient did not had a lot of
will you make the
other
final remarks?
responsibilities and just they were providing the formal caregiving only.
Thank you, thank you. Thanks to all presentations. We had 5 good presentations, and we thank all people who had worked and presented their research here. We are very happy that we have lots of people to comment and ask questions. So this was indeed a very gratifying session. It's a great beginning for IAGMH conference. Thank you all.
Indeed, sir. Thank you, presenters, and thank you, chairpersons. Now we have a small felicitation for the chairpersons. I request Dr. S.C. Tiwari, sir, to come on the stage and felicitate our chairpersons for the first session.
I want to ask the organizers, was there any screening of the papers to be included in this prize competition? Can anybody on the organizers comment, or just accepted all the 5 papers which came and allowed to present?
So, sir, we get Thank you all the participants and thank you chairpersons. Our next session is Srimati Shweta Tiwari Memorial Young Researcher Award, which is an award for young researchers comprising of a medal, certificate and a cash prize. The chairpersons for this award are Dr. Shrikala Bharat, former professor of psychiatry in NIMHANS, and Dr. T.S.S. Rao, professor and former head of psychiatry of JSS Medical College, Mysuru. We welcome you, sir and ma'am.
Dr. Shrikala Bharat, a pioneer of geriatric psychiatry at NIMHANS, is a senior psychiatrist from NIMHANS who was one of the founders of the geriatric clinic. She has a keen interest in capacity building, in psychiatric training, and empowering the youth in psychosocial competence. She has also worked in Australia as a consultant psychiatrist and is now an inspirational figure as a private practitioner. We welcome you, ma'am.
Dr. T.S.S. Rao, currently professor as JSS Medical College, actually needs no introduction. Sir has been the past Honorary General Secretary of Indian Psychiatric Society and past President of Indian Psychiatric Society Karnataka Branch and South Zone. He's the former editor of Indian Journal of Psychiatry and current editor of Journal of Psychosexual Health. Sir has published many articles and research papers and has been recipient of prestigious awards, notably Marfashia Award by IPS, Dampatya Vaidya Shastra, and Dr. Shiv Gautam Oration Award of IAGMH. It's an honor to have you both here, sir and ma'am. We now request chairpersons to take over the session.
Good morning to everyone. I think this is really, after the hearing of the 5 research papers by young people, now we are moving towards actually rewarding them for the research efforts which they take, which has been initiated by our professor and founder of IAGMH, Dr. Tiwari. And this is Shweta Tiwari's, in the memory of Shweta Tiwari. And it usually addresses somebody who has done something different and novel in the area of geriatric psychiatry. So now I request, I think there's only one paper. Were the other papers submitted and then removed, or you selected only one paper? You got only one paper, and that paper will be presented. And the title of the paper is Major Depressive Disorder Among Elderly Who Are COVID-19 Survivors and Its Correlation with Inflammatory Markers, Sashank Sinha, ending with Nisha Manipande.
A very good morning. First of all, I would thank the organizers for giving me opportunity to present my paper. I am Dr. Sashank and I am presenting, I am Assistant Professor in Department of Geriatric Mental Health at King George Medical University, Lucknow. And my guide for this research paper was Dr. Shailen Mohan Tripathi, and co-guides were Dr. Suryakant Tripathi, Dr. Jyoti Bajpayee, and Dr. Nisha Mani Pandey from KGMU. Severe acute respiratory syndrome and Middle East respiratory syndrome outbreaks in past have led to high prevalence of emergent psychiatric conditions. And it has been seen that elderly were among the most vulnerable group to COVID-19 due to various reasons such as decreased physical reserve, poor psychological support, and emotional health conditions. The elderly population exhibits a higher propensity for severe COVID-19 illness and a greater vulnerability to potential persistent health consequences according to the literature available. And the reasons, few of the various reasons include direct impact of neuroinvasion as well as secondary to dysregulation to the immune system, inflammation, and psychological stressors. COVID-19, we all know, and there abundant literature is available that COVID-19 has been associated with hyperinflammatory response, and depression has been reported at high levels in patients with acute COVID-19 using basic screening tools in hospitalized patients in most of the researches. So using just a basic screening tool and not using a structured tool and assessing for depression in the patient when they are hospitalized, both can be misrepresent the true prevalence. Some data have suggested that the degree of inflammation in COVID-19 is correlated with the extent of depressive symptoms, but this has not been replicated. So it remains to be established whether cytokines play a casual role in depressive illness in COVID-19 or whether they simply represent epiphenomenon without major significance. Considering the high burden of years of life lived with disability associated with a major depressive disorder, it is imperative to study the potential risk factors involved with major depressive disorder in older adults recovered from COVID-19. So, the studying the relationship between COVID-19 associated inflammatory markers and depression can help us understand the pathogenesis of post-COVID depression. So, with this in mind, a study was planned with the aim of to study the association between depression and inflammatory markers among the COVID-19 recovered elderlies. The primary objective was to explore the association between the level of inflammatory markers at time of admission for COVID-19 infection and major depressive disorder among elderly recovered from COVID-19. And the secondary objective was to see whether there was any correlation between severity of COVID-19 infection and severity of major depressive disorder. For the study was institutional ethics, permission was taken from the Institutional Ethical Committee, King George Medical University. Before doing screening for the patients, and it was a hospital-based study with cross-sectional nature, and the elderly who visited, who had been earlier as hospitalized at COVID-19 facility for contracting SARS-CoV virus during the second wave, and who had visited KGMU OPD for duration, within the duration of 6 months, were evaluated for presence of depression. Sample was calculated based on a previous Indian study and taking the MDD prevalence as 9.3%. The sample was selected using purposive sampling technique. The inclusion criteria for the study was patients who were aged 60 years and above and who had contracted the infection during the second wave, and those who had at least 5 years of formal education and had given written informed consent. Exclusion criteria was the current or past history of neuropsychiatric illness or other than the current episode of major depressive disorder. Substance abuse use other than nicotine such patients were excluded, and any patient with any known chronic medical comorbidities including uncontrolled hypertension and diabetes mellitus were excluded. The patients who were having hypertension and diabetes and was in controlled status, they were included. Medically serious patients and uncooperative patients were excluded. So the patients visiting the COVID-19 after discharge from the hospital and who visited the KGMU hospital were screened for eligibility, and the socio-demographic profile and was assessed. Medical records assessed for severity of COVID-19 and level of inflammatory markers at time of COVID-19 admission for COVID-19 admission. So if the medical records or lab values were unavailable, so they were excluded. Charlson Comorbidity Index was used to exclude medical comorbidities. Addenbrooke Cognitive Examination, Hindi version, was used to rule out any cognitive illness, and the cutoff score was used as less than 71. Patient was diagnosed on the basis of DSM-5 criteria for depression, and if there were any past history of depressive episode or psychiatric illness, they were excluded. So the out of 245 patients 3 patients were uncooperative, 17 patients were having formal education less than 5 years. These were 17 patients. 29 patients were ruled out because of medical comorbidities. 8 patients were ruled out because of serious or uncontrolled hypertension or type 2 diabetes mellitus. If person elderly who were having substance use disorder other than nicotine, they were 11. Some of the patients were not having their medical records, so such patients were excluded, and around 14 patients were excluded because they were having cognitive Edinburgh cognitive score exam they were having score less than 71. So after this, the patient were evaluated on the basis of DSM-5 criteria for presence of major depressive disorder, and 86 patients were found among the 130 patients who were included in the study. 86 patients were found who were not having depression, and only 44 patients were having depression. The 44 patients who were having depression were assessed for severity of on the basis of HAM-D severity rating scale, and data was used. So presenting the socio-demographic data for comparison of the comparison was done between the elderly with and without depression, and the variables age, gender, marital status, habitat, education, occupation, and family system was compared using chi-square test, and the religion was compared using the Fisher exact test. And out of the total 130 elderly patients, 44 patients were having depression and 86 patients were not having depression. So the proportion of depression in this study was 33.8%. Majority of the patients included in the study were male. They belong to the age group of 60 to 70 years, had education lower than graduation, and were from an urban Hindu community. The number of married elderly was more than widows or widowers. On the COVID-19 severity was compared in the elderly with and without depression, and the chi-square test was used, and almost equal proportion was found. So while comparing the inflammatory markers among the elderly with and without depression, it was found that the CRP and interleukin-6 levels were significant in the elderly with depression. On finding the correlation, MDD presence was found. It was found that CRP and interleukin-6 was correlated to MDD presence. On doing the test for association for severity of COVID severity and severity of major depressive disorder, general linear model was applied, and it was found that the COVID severity and depression severity was not depression severity was independent of COVID severity. So in this study, the majority of the prevalent portion of the patient was 33.8%. In earlier literature, it was the prevalence of depression ranged from 21 to 45%, and they depend upon the which screening instrument was used. In the previous literature, it was shown that it was referred that the higher COVID severity was associated with higher depression severity, but in this study, as we didn't found any correlation, and it again proves that the non-linear relationship between the severity of depression and COVID, and there might be other factors which may be influencing the severity of depression, like a coping mechanism and support. So this is one of the few studies few of the Indian studies which evaluated COVID-19 depression in elderly, and the study one strength was that we used HAM-D rating scale and DSM-5 criteria, but the limitations of the study was that there was a chance of recollection bias, and the second thing is that the role of psychosocial factors was not evaluated. Thank you.
We can have quick questions, one or two. I think it should be only two.
You have not excluded cases with tobacco.
No, ma'am,
intake, which
not
is-
excluded cases
Yes,
of tobacco
so this
use.
seems to be a major confounding factor, because it has been seen, there are enough studies to show that patients who have been taking substance abuse, including tobacco, are at a very high risk for COVID-19.
Yes, yes, ma'am.
Your comments on this?
I agree to your point that even in nicotine withdrawal, their nicotine would have been unavailable during the during that time, and it would have led to depression, and nicotine withdrawal is associated with depression. So, but the thing is ki, if I would have, most of the people are using tobacco, if I would have excluded even tobacco, then I would have not got the sample. I accept it as a limitation. Yes.
But you also found that COVID was not related to the severity of the depression. That was one among your conclusions towards the end, if I remember.
Yes.
And I was not sure when the depressive symptoms were assessed after the COVID was over, in the follow-up.
Within the 6-month period following their discharge, when they returned to the hospital for follow-up, then it was there.
Okay, and you didn't do homocysteine,
No, ma'am, homocysteine.
which is very commonly done in people, in elderly with depression.
Yes, ma'am.
All right. One more?
I think, thank you very much. Personally and on behalf of the other co-chairperson with me, we thank the organizers for giving this wonderful opportunity. Thank you very, very much.
Thank you.
Thank you for the presentation. I may request the chairpersons to stay back on stage for felicitation. I request Dr. Prabha S. Chandra, our Dean Behavior Sciences and in-charge director, to felicitate the chairpersons of today's session.
We often speak of the elderly as keepers of wisdom, experience, and resilience, the treasures earned over a lifetime. Yet, even the wisest minds are not immune to the weight of mental health challenges. While old age is a testament to endurance, it also calls for our attention and care, especially when it comes to their emotional well-being. Today, we gather to honor that wisdom, but also ensure that no one in their later lives feel forgotten or unseen.
A very good morning and heartiest welcome to the 20th Annual National Conference of Indian Association of Geriatric Mental Health, Geron 2024, conducted by the Department of Psychiatry NIMHANS and Indian Association of Geriatric Mental Health on the theme Geriatric Mental Health in India, Past, Present and Future. We have also gathered here today to commemorate a remarkable milestone, 25 years of exceptional service by the geriatric clinic at NIMHANS. For a quarter of a century, this clinic has been a beacon of hope and healing, profoundly shaping the mental health landscape for our elderly, and we honor its unwavering commitment to enhancing their well-being.
For the inauguration ceremony, and for this I need you all to put your hands together, I would like to invite on the stage our guests of honor. Please join us in welcoming Padma Shri Dr. C.R. Chandrasekhar, Dr. Prabha Chandra, Director in Charge, NIMHANS, Dr. Vivek Benegal, Head of the Department of Psychiatry, NIMHANS, President IAGMH, Dr. Gautam Saha, Vice President, Dr. Alka Subramaniam, Honorary General Secretary, Dr. Nilanjana Paul, Honorary Treasurer, Dr. S.P. Gupta, Honorary Editor, Dr. Sandeep Grover, the Organizing Chairperson, Dr. P.T. Shivkumar, and Organizing Secretary, Dr. Preeti Sinha. Thank you all. I now call upon Dr. Anupama for the invocation.
Pranamamyaham Shri Gauri Sutam. Pranamamyaham Shri Gauri Sutam. Phanitalpavasudeva bhaktam satatam pranamamyaham Shri Gauri Sutam. Phanitalpavasudeva bhaktam satatam pranamamyaham Shri Gauri Sutam. Gananatha mamara brinda sevitam. Gananatha mamara brinda sevitam. Panihara bhushitam. Panihara bhushitam. Munivara vanditam pranamamyaham Shri Gauri Sutam. Phanitalpa vasudeva bhaktam satatam pranamamyaham Shri Gauri Sutam. Dhrutacharumodakam gajamukham shritakaramitagarvabhanjanam natalokasamtoshadayakam shritabhaktapalakam siddhivinayakam pranamamyaham Shri Gauri Sutam. Thank you.
Thank you, Anupama, for giving us such a melodious start to the conference. I now request Dr. P.T. Shivkumar, the Organizing Chairperson of Geron 2024 and Head of the Geriatric Psychiatric Unit NIMHANS, to welcome the gathering.
Good morning, everyone. At the outset, it's a very important moment for the entire team of Geriatric Clinic and Services Department of Psychiatry, as well as the IAGMH team. We are actually having the two milestones, 25th year of Geriatric Psychiatry Services and the 20th annual conference, National Conference of Indian Association of Geriatric Mental Health. It's an honor to welcome you all for this gathering and for this important occasion. I would like to welcome all the dignitaries on the dais, Professor Prabhachandra, our Dean and Director in charge, and Professor C.R. Chandrasekhar, Badmashri Professor C.R. Chandrasekhar. He is our mentor and advisor for the Biomanas Sanjeevani initiative and an inspiration for all of us. And so he has been the guiding force for our public outreach engagements. And the dignitaries from IAGMH, Dr. Gautam Saha, IAGMH President, and Vice President Alka Subramaniam, as well as Secretary, Honorary Secretary Nilanjana Pal, and Treasurer S.P. Gupta, Dr. S.P. Gupta, and Editor Sandeep Grover, and my head of the department, Dr. Vivek Benegal, and all my team, including my organizing secretary for the conference, Dr. Preeti Sinha. So we have lots of people today who have responded to our invitation and come here, the very senior faculty, and the founder president of IAGMH, Dr. Tiwari sir, as well as Dr. Prasad, former presidents, Dr. Prasad Rao sir, and Dr. T.S.S. Rao, Dr. Indra Sharma, Dr. K. Shaji. So my teacher, Dr. Stikla Bharat, and Dr. Matthew Verghese is still on the way, and he's just returned early morning from US. So I hope he'll be there by the time the program would get over. And I think we owe a lot to our founders and teachers. Dr. Matthew Verghese and Dr. Stikla Bharat started this geriatric clinic, in fact revived the clinic in 1999. And from there on, it has gone from strength to strength, and today we are having the 25th year. And I think all organizations have a similar kind of trajectory. I think IAGMH again had a similar trajectory where it was founded in, say 20 years back, and then it is again gaining from strength to strength. So today we have a lot of people who, today's conference, we had themed it as Geriatric Mental Health, Past, Present and Future. We are looking at the next 2 decades. I think we are in a milestone where senior citizens are getting attention, I think including the recent announcement by the Government of India that all individuals above 70 are going to get health insurance cover. So that is kind of encouraging that attention what is being given to senior citizens. So we hope the geriatric services also, not only in demands, across the institutes will gain a lot of importance in the future. And it has to gain from strength to strength. And yesterday in a pre-conference workshop, we had representation from almost 15 to 20 institutes where young faculty who are aspiring to start geriatric clinic in their own place, facing a lot of challenges. And some of them have already started, and some of them are in the process to start. So we hope that organizations like this, as well as from our team, and demands being the active advocacy in mental health, we also will be able to use our say advocacy to promote this cause. And we also would like to invite all the faculty who have come across the country, also international. So we have faculty from USA, Australia, and one of the faculty joining online from UK. And so they have all spared their time and then come, and it's almost 50 faculty for various sessions. So I would like to thank all of them and welcome all of them for this important event. And we have a lot of, within our own team, from the participation, it is not just psychiatrists. We have representation from multidisciplinary team, including psychology, clinical psychology, psychiatric social work, nursing, and some of the nursing students, young nursing students from nursing college of SDS college, and faculty from there have also come. So we have also arranged actually a lot of people stalls where the students as well as delegates can get a kind of exposure to the activities and the collaborations, both in terms of outreach and clinical services as well as research, what we are doing, so that can again give an idea of how this service is working and what trajectory we have to take for geriatric mental health as a whole. And HODs, faculties from other departments of NIMHANS, I'm welcoming all of them. And there are several partner organizations. It will be difficult to name everybody. Many of them are there having the stalls. Some of them have been supporting us in various activities, outreach and research activities. So these are national as well as local organizations, HelpAge India, Nightingale's Medical Trust, Dementia India Alliance. So as well as various service organizations which have also participated, like Atulya, Antara. So I welcome everybody for this program. And I would also like to acknowledge all the support we have got from people to organize this event, and also Aran Murthy Foundation for us to give support for this event. And so we look forward to 2 days. Actually, we started yesterday with a pre-conference workshop. There are 5 pre-conference workshops which were held, and all of them were well attended, covering themes from, say, cognitive behavioral therapy to neuropsychological assessment, nursing, geriatric mental health nursing, promoting geriatric mental health care and training and research. So these were some of the areas where we have covered. Even digital use in elderly, how this is also something which is happening. I'm seeing my father always hooked on to the digital use. So I also welcome him, take this opportunity to welcome him for this program. And there are workshops on the second day, where again we are having neuroimaging as well as non-invasive brain stimulation. And we have comprehensive geriatric assessment as well as say delirium is another important area. And the BPSD, behavioral psychological symptoms of dementia. So the conference has a lot of events in terms of awards and orations. Those things also are held. So it's a very rich program what we have tried to put in for these 2 days. I would invite everybody to enjoy and then participate actively, and then help us to network and collaborate and take forward this geriatric mental health in future. And I also would like to mention today that we have got a generous contributions and philanthropic support from many donors. There have been support from Rotary Club, there have been support from individual donors. We have support from caregivers who have actually taken this mission to train geriatric physicians. Mr. Alok Kothari is here, and again he has really helped us to kind of support this training of physician and psychiatrists. Dr. C.R. Chandrasekhar again is another important philanthropic contribution he has made for the cause of dementia, and he has also contributed everything to the Institute of NIMHANS, and he has pledged everything, and he has always been serving people throughout. And in that line, we are also happy to announce that Dr. Srikala Bharat, my teacher, again she is also making a huge contribution, and an endowment is being set up for an outreach service, both in terms of old age homes as well as home assisted visits by our treating team, both nurses or psychologists and also even psychiatrists, to go and provide outreach service. So Dr. Srikala Bharat has pledged a contribution, and I would like to take this opportunity to thank Madam and acknowledge this huge generous contribution. And both CRC sir's contribution and Madam's contribution will help in sustaining these things. And I hope I have not missed out anybody. I would like to welcome all our team who have been working very hard for this program, and all the participants who have presented in various awards. I welcome you one and all. Thank you very much.
Thank you, sir. I request all the dignitaries on the dais to kindly water the plant for inauguration, symbolizing growth, renewal, and a commitment to sustainability.
Can I ask our founder president, Professor S.C. Tiwari, and our past presidents, Dr. G. Prasad Rao, Dr. T.S.S. Rao, and senior colleague like Dr. Srikala Bharat, Murgesh Vaishnav, Dr. Saji, please join with us. I don't know whether our secretary, IPS secretary Amrit is there or not. Please come.
Thank you, everyone. Moving on to the next part of the program. Founders of new ventures begin with passion and a vision to make a lasting impact. Today, we gather to celebrate their achievements and their contributions and support for the field of geriatric psychiatry. It is also the time to honor esteemed psychiatrists and pioneers of psychiatry who changed the course of geriatric psychiatry in our country at NIMHANS, recognizing their dedication and transformative contributions to the field. I request our Director in Charge and Dean Behavior Sciences, Dr. Prabha S. Chandra ma'am, to felicitate the guest of honor, Dr. C.R. Chandrasekhar sir. Dr. C.R. Chandrasekhar, fondly known as CRC and celebrated as the people's psychiatrist, has left an indelible mark on the Indian psychiatry through his remarkable work for the community. Being a prolific writer, he has published more than 300 books which have helped communities gain knowledge of mental health and has contributed significantly in reducing mental health stigma. He established Samadhana and Nemmadi counseling centers which have been offering free counseling services for people in distress for the last 13 years. Sir has also generously contributed financially as part of his philanthropy work to NIMHANS, and we are grateful for all his contributions. It's a pleasure to honor you, sir.
Only 3 psychiatrists in the country have got this 4th highest civilian award from Government of India. The first psychiatrist is first lady psychiatrist, Dr. Sharda Menon. And she was in the first batch of DPM course of NIMHANS. Second person is Dr. B.N. Gangadhar, who is at present the chairman of National Health Commission. 2 years back, he was awarded with this honor And I'm very grateful to Nimans. Because of Nimans, I entered psychiatry, became psychiatrist, took part in all the programs. We brought psychiatry out of mental hospital. Psychiatry, we took psychiatry to even primary health centers. More than 400 districts have mental program. Karnataka, all the 31 districts of Karnataka have district health program. So I'm very, very happy to share this with all the dignitaries and participants of this conference. Thank you very much.
Matthew is not there, no? Matthew is not come, has not come.
Okay, sir.
Matthew has not come, no? Matthew is not there, no? No, we can skip next.
Yes, sir, yes.
We can mention that we'll be felicitated later.
Yes, sir.
He's on the
I
way.
now Hello. Okay. I now request our head of the department psychiatry, Dr. Vivek Benegal, to felicitate the founder of geriatrics clinic at NIMHANS, Dr. Shrikala Bharat.
Matthew is on the way, he's on the way.
The Department of Psychiatry in NIMHANS had envisioned the need for specialized mental health care for older adults 2 decades back. This was the time when the general geriatric care was not well recognized in India. Professor Matthew Verghese and Professor Shrikala Bharat initiated the specialty clinic for older adults in the year 1999 as geriatric clinic and services. Under their able leadership, the geriatric clinic at NIMHANS has grown over the past 2 decades, achieving excellence in clinical care, training, and research in the field of geriatric mental health. The geriatric clinic that began as a once-weekly outpatient clinic every Saturday afternoon has now grown into a full-fledged multidisciplinary unit, the geriatric psychiatry unit with thrice-weekly outpatient services and 24 beds of inpatient. And like PT sir also mentioned in the speech, Shrikala ma'am has generously donated for the outreach programs to reach the insides of our community. Let's have a big hand for her, please. We would also be felicitating Dr. Matthew Verghese, but as of now, he's on his way, and we shall do it in the subsequent time.
I would now request Dr. Alka Subramaniam to felicitate a founder of Indian Association for Geriatric Mental Health, Dr. S.C. Tiwari, sir. Sir has been a former professor and head of Department of Geriatric Mental Health, KGMU, Lucknow.
Thank you all. I now request Dr. Gautam Saha to kindly felicitate Mr. Alok Kothari. Alok Kothari, sir, is the chairman of Kothari Charitable Trust. Over the last 25 years, Alok, sir, has helped build 4 large companies from the very start. He has been a founding executive of Netscope, which is a worldwide leader in cloud and data security. Prior to Netscope, Alok, sir, has served on the CEO staff and a founder of India operations for companies of various companies. Sir has also been an evangelist of emerging technologies and helped develop and grow the market for these technologies in India. The Kothari Charitable Trust Foundation is a family-funded trust and has the mission to bring and purpose, grace, and care to the life of an elderly. Other mission is to make professional education available to bright students in underprivileged families. The foundation also runs a home for elderly in Amravati. Sir's association with the geriatric clinic at NIMHANS is through Dr. Preeti Sinha, wherein he is funding, where he has funded the Dementia Echo project. The Dementia Echo project focuses on training the general physicians in psychiatry, especially with respect to the elderly. Thank you, sir. We are very grateful for your contribution. Next is book release.
I now request our guest of honor, Padma Shri Dr. C.R. Chandrasekhar, former senior professor of psychiatry, NIMHANS, and founder Samadhana Counseling Center, to release the manual home-based psychosocial support care program for families of persons with dementia, as prepared by Dr. Sherin Yahonan and Dr. E. Arvind Raj and Dr. A. Tirumurthy. I now request Dr. Jahnavi Kedare ma'am to announce the winners of various awards at Geron 2023.
It gives me great pleasure in calling the winners of the last year's awards for the papers presented in Geron 2023 at Mysore to come here and receive the awards, please. I start with the IAGMH Annual Award, third prize. Catatonia among elderly, a retrospective study from an inpatient setting from a tertiary care center. I invite Dr. Rajalakshmi to receive the award. Dr. Rajalakshmi, Dr. Sandeep Grover, and Dr. Subho Chakrabarti are the co-authors. I request Dr. Gautam Saha, Dr. Alka Subramanyam, and Dr. Prabhachandra Madam to give the award to Rajalakshmi. The second prize was won by Dr. Chandrima Naskar. I invite Dr. Chandrima Naskar to the dais to receive the award. A comparative study of electroconvulsive therapy among the elderly and adult patients in depressive disorders. Co-authors are Dr. Sandeep Grover, Dr. Subho Chakrabarti, and Dr. Asim Mehra. Chandrima. Give the check. So this award consisted of a medal, a certificate, and a check of 15,000 rupees. The third award had a check of 10,000 rupees, and now the first award. I invite Dr. Apurva to receive the award, Clinical Profile and Pharmacological Treatment Approach of Psychosis in Geriatric Population. Co-authors were Dr. Preeti Sinha and Dr. P.T. Sivkumar. This award consists of a medal, certificate, and a check of rupees 25,000. Congratulations to the winners of IAGMH Annual Award 2023. Coming to Srimati Shweta Tiwari Memorial Award, I call upon Dr. Vidya. All right, I call Dr. Rajalakshmi again. Her check was not given at that time. Please come again to receive it. Give it to Dr. Sa. I call upon Dr. Vidya, if she is there. Otherwise, Dr. Nisha Pandey or Dr. G. Prasad Rao can come up to the stage and receive the award, Srimati Shweta Tiwari Memorial Award, Psycho-Spiritual Development for Caregivers of Mentally Ill Elderly, Experiences from North and South India. The other co-authors were Dr. M. Madida, Dr. Rakesh Tripathi, and Dr. S.C. Tiwari, sir. This award consists of a medal, a certificate, and a check of rupees 10,000. Congratulations once again to the winners of the awards. Okay, PT. Come. Now we give the oration award. So I'll tell them. It gives me immense pleasure to announce the prestigious Dr. Shiva Goam Oration Award for Geron 2024, and it goes to Dr. P.T. Sivakumar. Congratulations, Dr. P.T. Sivakumar. A befitting award to win in the year when the IAGMH is being organized over here and when geriatric services are completing 25 years for all the work that Dr. P.T. Sivakumar has The award consists of, as you can see, a medal, a certificate, and a check of rupees 10,000. Congratulations, Dr. P.T. Sivakumar. Over to you, Anupama.
Thank you, ma'am. Congratulations to all the winners. I now request Dr. Gautam Saha, President IAGMH, to come on stage and give the presidential address.
Good morning, ladies and gentlemen, dignitaries on the dais, Padma Shri, Professor C.R. Chandrasekhar ji, the Director of NIMHANS, Professor Prabha Chandra, our own Head of the Department of Psychiatry NIMHANS, Dr. Vivek Benegal, Professor Vivek Benegal, and the Vice President, Dr. Alka Subramaniam, General Secretary, Dr. Nilanjana Pal, Treasurer, Dr. S.K. Gupta, Editors, Dr. Sandeep Grover, Organizing Chairman, dear Dr. Shiva, and also Organizing Secretary, Dr. Preeti. And of the dais, definitely, I should mention first our father figure of Indian geriatric psychiatry, Dr. S.C. Tiwari, the founder president of Indian Association for Geriatric Mental Health, and the past president I have seen here, Dr. G. Prasad Rao, Dr. T.S.S. Rao, Dr. Indira Sharma was there, Madam is, Acha, Dr. Saji, and also the senior member Sikala Bharat, Dr. Murgesh Vaishnav, and also Dr. Majid Bhai, Dr. Khirad Mishra, Dr. Ruma Bhattacharya. And there are lots of senior members and junior colleagues and friends. It is really great journey as a president of IIGMH last 2 years. There are lots of work we have done. Most importantly, the two things are very important. Number one is renewal of our registrations. And as far as GST is concerned, we have attained both these. Definitely Dr. S.C. Tiwari, Dr. S.K. Gupta, Mr. Alok, all are there. And it is very easy for me to work because of my Vice President, Dr. Alka Subramaniam, Dynamic Secretary, Dr. Nilanjana Pal, and whole the AC group and all the members. You have supported me like anything. You know, today's world, the population of geriatric population is increasing like anything. Not only because of the life expectancy, but because of, definitely one of the things important in 1930s, 40s, it is life expectancy was 30, right now it is 69 plus. So there are lots of geriatric population, so care is very important. When we got the freedom, our aim was to take care of the children. We are more concerned about the vaccinations. We are more concerned about the child health. We are more concerned about the neonatal health. But right now, it is equally important to take care of the geriatric people. And so we are more concerned, the importance of our organizations also improved. And as Dr. Shiva mentioned, that Government of India also declare their health budget also, those who are above 70, they separately, granted 5 lakhs rupees for their treatment, excluding their family expenses. That is a great step ahead. And I don't know what to say more, but the thing is that my next president will be Dr. Alka Subramaniam. I know that one of the most competent person, and under her leadership, the organization will reach a newer height. And I have no confusion, and I am very much confident that IGMH will reach in the next 2 years in a great, great way. They will work and will be really proud of our organization. Only thing, 2 things is important I have seen in my tenure. Number one, our membership should be increased because we should have a good membership drive. I mean, it is not that quantity. I always think the quality is very important. So people should join. I request all of the members and all of the delegates present here, please try to be a member of our society and convince people also to become a member of our society, because if our organization grows, we can do more works. And regarding the journal, Sandeep will definitely told, Sandeep told yesterday in our meeting that we need more articles. So I request everyone, especially the junior friends, please submit your articles for the journals for the benefit of our organization. And with this, I think the next is installation of the new president. And I request Professor Alka Subramaniam to come forward. And after this, she will be the president of IGMH. Thank you.
You're not letting go. You're giving me the delegate badge instead. He's giving me the delegate badge instead. इतना precious है. Thank you.
Sorry, one thing I should want to mention, that you all know that Arjikar cases in Calcutta. So our slogan is, we want justice for that Abhaya case. So for this, before giving my charge, I request all of you for 1 minute silence and stand up please for this case to make sure that our support is that issue. Thank you, please. Thank you so much. And one thing also I want to announce that is why our executive committee and all the members have decided that today there will be supposed to, we will organize a gala dinner, but it will be just simple dinner, not gala dinner, nothing else. That is for that memory of Abhaya. Thank you. Thank you so much.
Thank you, sir, and congratulations, ma'am. We now welcome Dr. Prabha Chandra, our chief guest of the event, in charge Director NIMHANS, to kindly address the gathering.
Good morning to everybody. First of all, on behalf of Dr. Pratima Murthy, Director NIMHANS, I welcome all of you to NIMHANS for this very important 20th conference of the Indian Association of Geriatric Mental Health. Welcome to Professor C.R. Chandrasekhar, my teacher, my mentor, an inspiration to all of us. It's a privilege to see him, and every time you meet him, he has something new to offer to all of us. Madam President, let me have the privilege of being the first person to call you Madam President. The past President, Dr. Gautam Saha, Dr. Sandeep Grover, Dr. Nilanjana Paul, Dr. Gupta, Dr. P.T. Sivkumar, Dr. Vivek Benegal, my colleague, and of course, Dr. Preeti Sinha, my neighbor near my office, next to my office, the person whom I go to when I want to talk. And of course, all the stalwarts in geriatric mental health, Professor Tiwari, the founder of this organization, and all other seniors who have come here, all the Matthew Verghese has always come to at the right time. You're supposed to be in front. Yeah. He's just come back from NIH with the latest treatment for dementia. So. I would also like to welcome all the faculty from various organizations, from various institutions who have come here, many students, many NGOs, many philanthropic organizations, because like you heard from everybody, I don't think geriatric mental health is possible without a collaborative effort, without a multidisciplinary team effort, and without people who are elderly. And it's good to see a lot of us with gray hair over here in the audience and on the dais, because nothing about us without us. So it's important for us for the people to be party to everything that is decided about them. And I think the elderly really value when they are consulted on research projects, on initiatives, on care, because they need to have a say. I was just looking at today's award papers, and it's such a range of issues that are being discussed, from blood pressure elevation during ECT in the elderly, to how do you tranquilize older adults in emergency, to how delirium looks like, what is successful aging, and of course about problems in the caregiver stress and problems in home care and residential care. This basically shows us the range and gamut of problems. So there's no one discipline that can actually approach geriatric mental health. We really need to approach it in all different ways. NIMHANS, of course, has been at the forefront of geriatric mental health. I still remember Professor K.N. Srinivas, one of us very senior professor, Dr. C.R. Chandrasekhar's colleague, who started the geriatric clinic kind of service many, many years ago, actually when I was a student. And I remember thinking at that point, because you know how when you're 25 or 26, you really don't think that you're ever going to grow old, or there's something called old. And I was thinking, what is the reason why he's starting this service? And I realized that it was a great forethought and wisdom that this service was started. It went through a bit of a lull. Subsequently, Dr. Matthew Verghese, Dr. Shrikala Bharat actually revived it. And we are marking the 25th anniversary of the geriatric clinic, and it's really very, very heartening to see the great progress that has been made. While the geriatric mental health service is quite old, actually the faculty of the geriatric mental health service is among the youngest in the department, which I think is a very nice thing to see, because there are new ideas, and as you might have seen in the stalls outside, we actually have, literally from the bench to the bedside, work happening at NIMHANS. Today is another important day for NIMHANS, which PT has forgotten. And that is that 12 years back, 2012. Today was the day when we became the Institute of National Importance. So it's a very, very important day for all of us. And you've chosen a very right day for this. I think, so like I mentioned, I think we literally have from the bench to the bedside. We have the Enigma project, which is a multi-country consortium, and you'll hear more about the findings from that. We have the Center for, that's an NIH-funded project. Like I said, Dr. Matthew Verghese has just come back from the meeting, the Enigma meeting, and he will probably tell us more about what was discussed. We have the Center for Brain and Mind, which actually looks at cohorts of people with dementia and trying to understand various biomarkers, deep phenotyping, which is a philanthropic project by Rohini Nilekani and her family. And similarly, there is the Kolar Observatory, there is the Karnataka Brain Health Initiative. So there are a range of projects which are actually looking at this very seriously, including the Department of Neuropathology. Our Dean Neurosciences, Dr. Yasha, is here. And I know that the Brain Bank actually invites people to donate their brains so that they can understand aging and dementias better. So I think there's that end of the spectrum. And then you have the other end of the spectrum, which is public education, which is very important. And Dr. P.T. Sivkumar has been, and his colleagues have been running the Vayomanasa Sanjeevi, which is a weekly program, right? And I know that my parents actually really look forward to it. And it's done in various languages. It's an online presence. It covers a range of topics which elderly want, from management of finances to management of sleep, to relationship issues. I think there's a whole range of things which are discussed, which are again very important and reach so many people. So I think Dr. Preeti has been running the NIMHANS Digital Academy training program on geriatric mental health, like you heard with the donation, a generous donation of Mr. Kothari. So I think we really need a range of activities, and I'm sure under your presidency, we will be seeing more and more of this, including public education. I think that's something which is very important because people struggle. Everybody cannot come to a clinic. Elderly people don't have access. If you look at Bangalore, reaching from point A to point B is a nightmare, even for younger, able people, and it's a further nightmare for the elderly. So how do we reach people in their homes is something I think we really need to think about very carefully. So, improving home care, training, and I think that is the need. And I'm sure the society with NIMHANS will be able to develop some models, because one of the problems has been, from what I have spoken to many family caregivers, that the quality of care is of concern. Elder abuse is not uncommon even from the so-called caregivers. I mean, though they're supposed to be caring, it's not necessarily happening. So I think these are some things that, we need to really pay attention to, really certification, quality care, updates, clinical supervision of these carers, I think is a very, very important aspect that maybe the association can take on with some, with your able guidance. I know that the program is going to be really rich and successful. I look forward to hearing more about what all was discussed. I'm going to end with a poem which has been written by my father. So my father writes poetry in Tamil, but this one I have translated into English, and it's called My Age 85. He said, "They say today my age 5 past 80, this only by the grace of Almighty. This passed with much struggle, which I did face, but it's entirely due to His grace. I had all needs and necessary comforts, which happened without much of my efforts. Not born with a silver spoon, I think, was an indirect boon. This gave me strength to stand on my own, left in the chosen path to shine. Now on this day onwards, to prepare to reach my life summit, since I have reached my life base camp, waiting for the final flicker of life lamp, know not when the act will end and leave the life drama stage. Like the bird, I will finally fly away, leaving the cage. The Gita said that births and deaths are many because the soul has no birth or death any. So don't just stand in the God-given garden counting only trees, but pluck the mangoes and eat to your content and be free. Until the gardener calls you, prepare to flee. I invite the end at any time. Know not when it will knock at my door, since nothing for me in this life is there to accomplish anymore. And this he wrote on December 24, 2015, when he was 85, and now he is 95 and waiting for his 95th birthday. And still writing poetry, and still advising P.T. Sivkumar every other day on the programs he should be broadcasting. So I think that is a sort of a, is a model of healthy aging and what we really want to see. But having said that, I think, as a caregiver of elderly parents, we struggle with many things, including periods of extreme despondency, particularly related to things like hyponatremia, delirium. It happens very often. And I know when it happens, all this positivity goes away in him, and he struggles. So I think these are things we should remember, that while we think that some people are coping very well, it may actually be that there's a lot of fluctuation, and how we as mental health professionals, as carers ourselves, these are things which are very close to all our hearts. How are we going to, go ahead and do things for our society, which right now needs all of us to work in unison with each other. So on that note, congratulations to each one of you for having achieved so much. And I look forward to all the progress that is going to be made, both by the association as well as NIMHANS in this area. Thank you very much.
Thank you, ma'am. It is always inspiring to hear you. Now I request Honorary General Secretary IAGMH, Dr. Nilanjana Paul. Okay. So, sorry. We'll move on to the next program, which is Felicitation of Dr. Matthew Verghese by Dr. C.R. Chandrasekhar, sir. The Department of Psychiatry in the National Institute of Mental Health and Neurosciences had envisioned the need for specialized mental health care for older adults two decades back. Professor Matthew Verghese and Professor Shrikala Bharat initiated the specialty clinic for older adults in the year 1999 as geriatric clinic and services. We would like to honor Sir's commitment and Sir's continued guidance for the geriatric clinic and services at NIMHANS. Thank you, sir.
Thank you, sir. So, yes, we would now like to felicitate our collaborators with Geriatric Clinic and Outreach Services who have been instrumental in taking geriatric care to the community door to door. I request Dr. C.R. Chandrasekhar to kindly hand over the mementos to the various organizations who have been associated as a token of appreciation for their commitment in dementia care and partnering in care for persons with dementia. I invite the head from Nightingale's Medical Trust. Please put your hand together for them. For Dementia India Alliance, and HelpAge India. So thank you all. I now request Honorary General Secretary Dr. Nilanjana Paul to give the vote of thanks.
Namaskar. It is an honor and a pleasure to be here today among the dignitaries on the dais and to see a full hall of youngsters as well as those who are not so young, to be here discussing about different aspects of caring for the elderly. We all know that this has been, the population is aging, we are living longer, but at the same time it means that we are having to face different challenges which cannot be tackled at all by only doctors. It needs others from the whole of the community. I'm sorry, I will not be naming everyone, but we are really grateful that all of you have come. We are grateful to the NIMHANS team, to Dr. Siya Chandrasekhar, to everyone here. And please stay for the academic feast that will be there in the next 2 days. It includes things that will be applicable for professionals as well as for people who are directly involved in caring for the elderly. Thank you all for being here, and let us have a good conference.
Thank you, ma'am. I now request all of you to kindly stand for the national anthem.
शुभ नामे जागे, तव शुभ आशीष मांगे, गाहे तव जय गाथा। जन गण मंगलदायक जय हे भारत भाग्य विधाता। जय हे, जय हे, जय हे, जय 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 हे।
Long live IGMH. And NIMHANS.
Thank you all. We now proceed for a 10-minute tea break, and let's try to stick to the time limit as we are running a little behind. Yes, sir. Yes, sir. So kindly assemble back in 10 minutes.
social workers,
mental health regulated.
it will ultimately be given to people who are There's too many people who are saying I don't want to make any major changes. I just want to know does it basically face value? Now that I've caught you.
In fact, Dr. Aniruddha Dev will be another of the expert reviewers. আমাদের বইটার জন্য। Yes, but he's also a like literary person. সেজন্য
কবি মানুষ সেই জন্য কবি না লেখক মানুষ সেই জন্য
কে আছেন তো? এটা খুব সুন্দর করে বইটা দেখতে
বই কি ইনগ্রেড হয়নি?
All right. You can you can open that first slide and keep it open.
Okay. Next one yours, na? Okay. Okay.
You got the membership form?
घुस में क्या ना के दाने दो मैं की बोमोटे दाना घुस में ಇದನ್ನ ಹಾಕಿನಿ ಏನು ಹಾಕ್ಬೇಕಿತ್ತು ಹಾಂ ಅದನ್ನೇ ಹಾಕಿನಿ ಚೆಕ್ ಮಾಡಿದೆ ಪಿ ಪಿ ಡಿ ಎಲ್ಲ ಕರೆಕ್ಟಾಗಿದೆ ಆಯ್ತು ಚೆಕ್ ಇನಾಗ್ರೇಷನ್ ಮಾಡಿಲ್ಲ ಅವರು
പേജ് എടുക്കുകയാണെങ്കിൽ പിന്നെ ഇത് രണ്ടാമത്തെ പേജിലേക്ക് പോയാൽ രണ്ടാമത്തെ പേജ് എത്ര വരെ കിട്ടും? അപ്പോൾ ഒരു പകുതി കൂടി ഞാൻ എഴുതിയാൽ പോരെ? സെക്കൻഡ് പേജിൽ ഇത് കൊടുത്തു കഴിഞ്ഞാൽ ബാക്കി IPRന്റെ പോരാണ്ട് വരും.
അത് Distortion is not important, continuation is important. Valentine Day में सब रोज देते हैं, लेकिन पूरा साल कौन मेंटेन करता है? वजन लॉस करते हैं।
Welcome back, everybody. We now move to our next event, the presidential address by Dr. Alka Subramaniam. For the same, I request our chairpersons, Dr. Gautam Saha, consultant neuropsychiatrist at Kolkata, and Dr. S.C. Tiwari, former professor and head of the Department of Geriatric Mental Health, KGMUC Lucknow, to kindly come on the stage.
welcome to post-tea session, which is going to be a memorable one, an important one, because the second lady has taken over as president of Indian Association of Geriatric Mental Health after Professor Indira Sharma. It's indeed a great moment. The way I'm looking at geriatric mental health, a crusade which we started around 2 decades ago has flourished to such an extent that's really remarkable. And I thank you all. I appreciate you all for showing such an active participation. Now we have a very dynamic lady who has been associated with geriatric mental health since its inception, and she has contributed immensely to the growth of geriatric mental health in India. As a chairperson of the award committee, as a general secretary, she has done a wonderful task. Now she is going to take this association much, much ahead as president of Indian Association for Geriatric Mental Health. I request Dr. Alka Subramaniam to come and enlighten the audience with a presidential address. Thank you.
Welcome to Dr. Alka Subramaniam, who is not only the second lady, president of Indian Association of Geriatric Mental Health, she is also second young president of Indian Association of for Geriatric Medicine. IGM is the second president है, first to मैं था, second. Okay, please.
At the outset, it's an honor to have both of you chairing this session. And it isn't working? All right, thank you. Is this more audible? As I take on this onerous task, I would like to begin with much gratitude for giving me this responsibility. And I have many people to thank, because they say that the people you meet in the walk up are the same ones you're going to meet in your walk down. It, of course, always starts with family. My parents are too frail to be here today. And my in-laws, too, could not be here, but I'm really grateful for them. It's not very easy to be a working woman and take on responsibilities, but I've managed to do that. I have my better half, who sometimes turns into my better 3/4 here today. And and thank you for continuing to be my best friend despite the marriage. And we have shared an equal partnership, which is, again, I'm very grateful for. And we are caretakers now to 3 senior citizens, 2 of who are octogenarians, almost nonagenarians. And of course, the outcome of that is our beautiful daughter and our pet, who is both our strength, weakness, and inspiration daily. I have a huge extended family, as does Anand, my husband, of aunts, uncles, cousins, and we have very, very strong family ties, being from the Indian subcontinent. I'm not taking all their names. And in that extended family, we have a lot of friends who have become like family, few of whom are here today. Amrit, Ruma, some who, being my friends, of course, have absconded. Nisha, Devdatta, but I suppose sometime they'll come back. And I really thank them for making me the person I am, besides the psychiatrist that I am. My gurus, my teachers from school, from college, from medical college, who in their own way chipped and chiseled to ingrain a work ethos in me that I think has become what I am as I stand before you. And of course, my journey in psychiatry began with Sion Hospital and my OPD 21 family, of whom we have Soumya, thank you, and Avinash, who again, being my friend, has disappeared, but yes, he had come. I went on to Somaya Hospital for a very short time, but that OPD 18 also became my family, and a very dear friend I got from that, Dr. Bindu. Thank you to also my mentors in that family. And of course, finally but not the least, my current family, which has become very huge considering that I've been part of OPD 13 for the past 20 years. I'm extremely grateful to Dr. Kamath, sir, for coming to bless me today. And he takes on a dual role, because in his presence I sense the late Dr. Pinto, who was my mentor and guide. Much of the reason that I'm in geriatrics today. Sorry if I'm getting emotional. And of course, with him, I have Dr. Janvi Kedare, who represents a lot of the other faculty. And we have worked outside OPD 13 in many, many other fields besides IAGMH, and worked side by side, though she's a few years senior to me. I cannot forget my students. Sakib and Tejas are here today, thank you, who through their research, through their work, through their interactions, I think keep at least the brain a little young, even if the body and the hair start growing a little older. So thank you for that, and thank you for those lovely relationships that we have developed over the years. And finally, the edifice before you that we see today, that is a legacy that is being handed to me. It started with Professor Tiwari. We call him Bhishma Pitama, and we go back to him every time we have a crisis or some guidance that we need. Dr. Shaji was our second president and also part of the founding committee of the IAGMH. Sir has navigated through being a very hands-on caregiver to someone who's evolved into a bigger role, which I'll be talking about a little later, but he's always continued his association in a very humble and silent way with IAGMH. We have the late Dr. Charles Pinto, who was, as I said, my mentor and guide. Professor Shiv Gautam, who could not be here today, but has an oration in his memory, in his living memory in our organization. Indira ma'am, who was the first lady president, and I remember in her tenure, we learned a lot about documentation and archiving, which I think we required at that time. We have Professor T.S.S. Rao. Another mentor whom we are missing sorely today is Professor Ajit Awasthi. He has an oration to deliver on Monday, and the travel would have been too much. We have Dr. G. Prasad Rao, who brought certain add-on values to IAGMH in his tenure, and a lot more collaboration. Then, of course, the dynamic Dr. Gautam Saha, my very dear friend and predecessor, and me being the 10th. And this, yes, a round of applause to them, please. And this would not have been possible without the support of extremely efficient and able secretaries who are icons in their own might and right. We had Dr. Venugopal Jhavar, who was the first secretary, Dr. Purav Mida, who served for 2 tenures, Dr. Manasvi Gautam, who served with his father too. That was me with Madam. Dr. Janvi Kedare, Dr. O.P. Singh, Dr. Majid, who despite COVID managed to get so much done during that period in IAGMH. Then of course, Dr. Nilanjana Paul, who has straightened out and made us have an active office and quarters. And now is Dr. P.T. Shiv Kumar. And this, my ladies and gentlemen, is the foundation that has made IIGMH go on for 20 years with the vision it had started off. Not to forget at all. And I think these two gentlemen in particular actually deserve a complete round of applause. I think we're the only organization to have a treasurer since the inception. Dr. S.P. Gupta on your left. For 20 years, he has handled our treasury. Through thickness and ill health, yet he said, no, I will manage. Don't worry, I will manage. And there's something very remarkable that he has done, which I will again highlight a little later. And Dr. Sandeep Grover, who will soon take on a hopefully much higher role. He's our editor. And again, a very dear friend. Like I was telling people, we both started our careers at around the same time. And he has resurrected the journal because there was a point of lull when we had to really hugely change everything, and that's the time when I became secretary and he became editor. So thank you. These are our foundations on which we grow strong, and because it's such a small family of dedicated people, we hope to continue that the baton that it passes on is again to the people who come in, work, and are interested, so the continuum is maintained. It honestly, to us, this medal, this change of position, is something which is important, but yet we know that the people who are going to work are going to continue working. So when PT asked me, what is your address going to be on? Something scientific, something to talk about. And I said, no, actually, I think it's important that we reflect on what is and what we have done and what we should be doing, which also concurs with our theme of the past, present, and the future. So if you look at the elder in India today, you see our population statistics. We, of course, have only the 2011 census because the next one was during COVID. We have a declining growth rate, but an increasing life expectancy. And the India Aging Report in 2023 showed that we are going to have 347 million elder by 2050, of which a mammoth 22% are going to be in Kerala, which is why Sir has a lot to share, which he will in the next 2 days. And when you look at that in terms of a geo population, it means that we are going to have a population almost reaching that of Mexico or Russia. And the 80+ population is equal to the total population of a country like Belgium, Greece, or Cuba. The reason I'm telling you this is because when we do our planning, we can't do micro-planning. We can't be planning for small endeavors. We are going to be talking about a population which is magnanimous. It's huge. And the multidisciplinary tasks then becomes all the more magnified. So when we look at a state-wise distribution, 10 states in the next few years, and this was again by the India Aging Report, Kerala and Tamil Nadu leading, but 10 other states are going to be bearing the brunt of this aging, if I may say so. Because do you think we are elder ready? In pockets. It's very patchy. It's not a uniform thing. When we look at the dimensions which are a problem, this is from the longitudinal aging study, and we had a beautiful presentation in the award papers for the second arm of that. You see the highest restriction is in ADL. Very high burden of comorbidity ranging from 7 to 52% in Kerala. 22% facing poverty, and some who don't have any income. Zero income, which is why the Ayushman Bharat scheme of endowing 5 lakhs becomes so very, very important at this point in time. Point is, how do we implement it? All these things are good on paper. We have a lack of expertise. Everybody has some or the other form of disability and chronic illness, and as high as 20% of mental health. issues. So the biggest challenges we get from helplines are calls for things simple as related to finances, legal and pension. And most of our planning does not cover this at all because we are talking about medical mental health issues, right? And that's where I think a little bit of change in mindset has to occur, not because we want to step into the social domain, but because the social domain impacts the medical domain. And when we talk about elder mental health, particularly in India, it has to be a multidisciplinary approach. So we began, so you would recognize your signature on this. This is our first draft of the Constitution, and we began with elements of geriatric care, which is a known thing, and you're going to hear this over the next 2 days. So patient-centered outcomes working towards prevention, ADLs, advanced directives, quality of life, capacity, so on and so forth, cognitive assessment. We started off with a membership of 118, and today we have about 660 members. So that may seem small when we look at organizations across India in terms of psychiatry, but for a dedicated organization, like Gautam has said repeatedly, quality becomes as important as quantity. And for those of you who want to register, we have a stall outside the IGMH stall, and you can pick up registration forms and do the formalities right now. So we have life members, almost 500, life members, about 150, and other members, and yet we are raring to go. What have we really achieved in this past 2 decades? It was thanks to the endeavors of Professor Tiwari that we managed to get the first DM in India. Actually, his department is the first dedicated geriatric psychiatry unit pan-India, and it continues despite the 2 decades and all the hurdles that have faced it. The national policy for older persons is what we had worked on and contributed to way back in 2012. Multiple research awards, as you have seen. Sandeep has spearheaded multicentric studies here. We have affiliations with the International Psychogeriatric Association. We have created a travel fellowship for young career psychiatrists, and last 2-3 years, Janvi has been looking after the awards and the travel fellowships. And we hope to streamline that a bit more. And also, if possible, have some sort of a liaison with international geriatric organizations so that our young career psychiatrists, the DM, PDFs, once they pass out, can also have a little bit of experience there. The advocacy programs have been started much at the behest of our erstwhile secretary, Dr. Nilanjana Paul. And since the past 1.5 years, every Geron, every midterm CME, we have some public health initiative and awareness. We've also linked up with Viomanas Sanjeevani, and we have some collaborative programs with IAGMH and the NIMHANS team. There's been a quarterly academic meet for students to present cases and to discuss on important topics as well as recent advances. We've collaborated with NIMHANS to publish a book on insights for healthy aging, which will be available in 8 languages, and hopefully by next 6 months or 8 months, at least part 1 should be done. And very importantly, we have had, every organization I have realized has had issues with registration. Now GST is mandated, and filing of income tax returns. Thanks to Professor Tiwari and his team and Dr. Gupta, we are actually on par, and I think they deserve a round of applause for this, because when I stand on this dais and take over, that's half of my headache gone, because we are starting with a clean slate, absolutely. But yet there are gaps. There are gaps which are glaring gaps. And the major constraints we have found in the last 2 decades is lack of specialized and trained manpower. Geriatrics is not really yet a very popular specialty. Most people move towards addiction and child and adolescent yet. And there's no dedicated healthcare infrastructure. So even those who take it up, like PT said yesterday in the workshops, They are struggling. How do I start my own setup? How do I go about it? How do I manage as an independent person? So this is the dream that we have, that we want to achieve at a sub-center, PHC, district, and tertiary care level. But like I said, the gap is huge, and we're going to take a while to bridge that gap. So what is the roadmap ahead for us? What are we planning to do? In my mind, I categorize it into what I think is the triple A: administrative affairs, academic enhancement, and advocacy, and a huge thrust and work on advocacy. So in the administrative department, we need to continue our registration. We need to have specific checks for our audit. We've always been transparent, and we promise you we will continue being so. Our constitution has changed a bit, but it needs, again, a relook because of the advances in science as well as in the way that we function, including digital meetings and things like that. So we will be re-looking at that in the next couple of years. We will hope to revamp and put up many of our archives on our website. Indira ma'am has suggested that proceedings of all conferences can also be recorded, and we will really make an endeavor to do that and explore the possibility of having an interactive website. From the academic point of view, we hope to have a consortium where we can standardize curricula, not only for MD, DM, PDF, but also for allied health professionals, because it becomes very important that we empower training of the trainers. If we have standardized modules and standardized templates across the country, then all our members who are working in this field can use the same template, and thereby we are increasing the quality of care overall and the overall standard of care, whether it's at a home level, whether it's at a tertiary care level, it doesn't matter. And we are really going to endeavor to do this, and PT is right here, and he knows we have discussed this multiple times. The next is, of course, I think we lack an Indian textbook of geriatric psychiatry, and this personally I feel is very important. I have discussed this with the office bearers as well, and they are in agreement that we will start working on that and see how we can get it published. In addition, we need SOPs for old age homes, for advanced directives, templates which will be there. For example, how to run the old age home. We had a paper today on parental care and acute patients, acute elderly patients. So things like this, which would be uniform at a national level and easy for anyone to implement wherever they are. And of course, I was hoping Sandeep announced this, but I'm doing it on his behalf, that there is going to be a CME series in the journal, which will start soon, and hopefully that will also help promote the interest in geriatric mental health. I cannot talk enough of advocacy and the need for it, because I think after so many years myself in this field, I've realized that we cannot sit in our clinics and expect elder individuals to come and see us. It's time to actually go back out into the community and meet them over there. So KGMU has a robust community program, so does NIMHANS, and we have started 2 community-based service, door-to-door screening, to try and find out what the issues are and help them at their own places, for which we will probably need collaboration with a lot of NGOs who are already informally working, and some even formally working in this area. Professor Shaji sir has started a state resource center for older people. He's the director there. It's an endeavor with the Kerala University of Health Sciences and the Department of Social Justice, and we hope through their initiative, something like what we have, the Center for Brain Research. These are nodal centers we are looking at who are going to set the templates as to how other nodal centers, or at least centers which would probably be directly in contact with them, are reporting to them, how they can proceed ahead so that we can help the networks and the social as well as the medical network for the elder individuals. Tiwari sir has said that he will help us again in strengthening the government policies. And as we know, we have had a national policy for older persons, recommendation by the Planning Commission, the Maintenance and Welfare Act, and the National Program for Healthcare of the Elderly, which actually cuts across Ayush, public-private partnerships, as well as medical education. And though everything is beautifully put on paper, what is lacking is implementation. So a simple thing like a particular, not even a district, maybe even a smaller taluka, should have ramps, should have access to healthcare. These are the templates we hope to actually define and disseminate so that it can be worked on with local municipalities and local governments to really change the quality of life at a larger scale. They are simple measures, but we hope to have them. The other thing that we have to think about is digital advocacy, collaboration, and marketing. It's amazing to look at the economics of what we are going to be headed towards, and projections by 2030 is about $42 billion industry where we need trained and skilled personnel, job opportunities, and of course, digital apps. And look at this, we already have this whole plethora of wearable apps as well as digital services, some of which are caregiver-based services, on-demand doctors, concierge service, acuity apps, telemedicine, so on and so forth. And fortunately, we have inroads to IIT through Janvi now, and we hope that we can work on doing something collaborative and multi-centric through this. But of course, there are miles to go before we sleep. When I started, I said, thank God we have 2 years. And now I'm wondering, oh my God, we have only 2 years? But we hope that the team is able to perform. And I do assure you, we will be giving you an interim report next Geron and the one after that to see that what of these parameters we have reached. It is indeed an honor. I think it's a personal blessing that we have Professor Chandrasekhar sir here, Padma Shri, to bless us and start this. Sir has been a huge force behind the community mental health program at NIMHANS. And on this, the 25th year of the geriatric clinic at NIMHANS, the 20th year of IAGMH, the 10th year of the Journal of Geriatric Mental Health, and as the 10th president, I would again like to, in gratitude, say thank you. And I do promise that you will hear more from us. Thank you so much.
Thank you, Alkaji, the 10th President of the Indian Association for Geriatric Mental Health. It has been a very enlightening talk, perhaps very stimulating also for youngsters to develop this branch, this subject to a higher and higher levels. Generally, the presidential address is not open for questions. We thank Alkaji for such a talk, and I hand over the mic to my colleague, Dr. Gautam.
Thank you, sir. It was an excellent presentation. In fact, Dr. Alka covered almost history of IGMH with the future direction. And it was really, I think it should be archived and it should be uploaded in our website also. Maybe in the journal, one article can be written on this. And thank you, Professor Alka Subramaniam, for being our president, and also Dr. Anand, the better part of the, better half of the Alka, and for being with us today. He is a renowned retinal surgeon, as I know, and thank you for being with us and supporting Alka to be That is why we get Alka as a president of our organization. Thank you to you also on behalf of IGMS family. Thank you. So we want to conclude this session here only. Thank you.
Thank you, ma'am, for that insightful presentation. I would like to call Dr. Matthew Verghese, sir, to come and felicitate our speaker and chairpersons.
Please, I request Dr. Anand to be here only, please.
Now, moving on to our next session. This session is to mark 25 years of geriatric psychiatry at NIMHANS and beyond that. We request our chairpersons, Dr. G. Prasad Rao sir, former president AGMH and former president Indian Psychiatric Society, senior consultant psychiatrist from Asha Hospital, Hyderabad, to chair the session. And I also request Dr. Mohini H., Professor of Nursing and Principal of SDS Nursing College and Observer from Karnataka State Nursing Council to chair the session.
It's really a happy moment for me. I am talking in my alma mater. I'm talking in a place where I had my first education in psychiatry. Srikala was with me at that time when I was doing my residency. Lot of fond memories, and it's always, it is good to recollect what has happened, because that is not only history, but it is most importantly who have laid the path for the department here in geriatric psychiatry and the growth of geriatric psychiatry, both academically and in terms of service. But it is probably for the future, as aptly in this theme of this conference, past, present, and future. So this is my pleasure. As I was going through, there will be 3 speakers in this session. But before that, NIMHANS, or the National Institute of Mental Health and Neuroscience, as we fondly call as NIMHANS, probably was one of the first few institutes which had focused on the geriatric psychiatry. Of course, the other alma mater of mine, the KGMU, has really a model geriatric mental health center, as started by none other than Professor S.V. Tiwari. And I have had the opportunity to work there for some time. So today, it's my pleasure to invite first Professor Dr. Srikala Bharati to come. May I invite Dr. Srikala Bharat, Dr. Matthew Varghese, who is my classmate, and it's always a pleasure to invite and be with him. And then P.T. Shivkumar, who is the bright light right now working for the next, as already commented in the morning, he's the youngest person among the faculty here, and he has a lot work already under his arm, and is going to do much more service, both academically and to the patients. I fondly come back to him whenever I have any issues. He always comes with some answers. So let me start requesting Professor Srikala Bharat. Matthew first? Okay. So I think there's a little change as given my name, but Matthew is a man of few words, and sometimes he doesn't show emotions as well. And we both joined together in this institute, and he has contributed significantly. I again remember for the first dementia conference, myself, Dr. Shaji, and Matthew were in Washington, D.C. for the ARDSA Congress at Washington, D.C. So Matthew, you're going to talk something about the past and with a projection to the future. Okay.
Thank you very much, Prasad. Prasad is my classmate. We joined together in 1981 at NIMHANS. So my job here is to talk about the whole story of geriatric mental health in India. That's how my talk comes first, and then Srikala goes afterwards, about what we did at NIMHANS. So it's really nice that the IAGMH could find the session where we could have a look at history and see where we have come. You heard the president talking about how the Geriatric Mental Health Association has finished about 10 years. But there is an older history, and I'll just go over that in the next 10 minutes. PTA said we had to be quick, so I'll try and be as quick as possible. So I won't go through this. This is something all of you can see, but basically to underline what the president said, that we will have the world's largest aging population by 2050. And our increase in population will be rather steep, because we'll go up from few numbers to large numbers in 50 years. And this is all part of the World Aging Report, which you can see if you look at it. By the way, the World Aging Report was also written by one of the, co-authored by one of the NIMHANS alumni, who was responsible for the SAGE, the longitudinal aging study. It's Somnath Chatterjee. He was part of the WHO's report on the aging and health. So, 2011, we had a census of 8.6% of the population, which is about 104 million. But already now, it's estimated that we are above this 177 million that we have projected. And why is it important? Because of rapid population aging, we will have a large dependency ratio and changing family structures in our country and migration into the cities, nuclear families, and medical illnesses will actually compound our problem. So the need for geriatric services is because 45% of the elderly suffer from chronic illnesses. I mean, this is shown by the Lassie study, that we had probably the world's largest population in terms of diabetes, hypertension, and other NCDs. And together with these NCDs, there'll be, most older people will have 2 or 3 physical illnesses, and together with that, there'll also be a mental illness. And we all know that if we have a physical illness, our chances of having a mental illness like depression and anxiety goes up by about 3 or 4 times. So the prevalence goes up to about 30 to 50%. And depression and anxiety, as we showed in the National Mental Health Survey, is pretty common in the older population. It's about 7% or so, both depression and anxiety and other so-called minor mental illnesses, or the common mental disorders are concerned. And dementia is a whole huge population. This says 3% because this is what our report said, but according to the Lassie data, we are probably reaching up to about 7%, and that's also what the 1066 data showed, that our dementia population is possibly in the region of about 7% of the population. And so we are talking about a population of over 6 million people. And we have not really taken care of things like subsyndromal issues, which is depression and anxiety. So for this talk, I have basically divided into 3 parts: the early years, the later years, and the future. So basically, we are right about halfway into the future. This is from 2020 onwards. So I've taken a 20-year period because that is where geriatric mental health started. So way back, the starting was really with the ICMR task force in geriatric mental health, where the task force looked at studying problems of the elderly in a geriatric clinic. And the person who did this was Professor Venkaburao, who can possibly be denoted as the father of geriatric psychiatry in India. I mean, we never sort of acknowledge him like that, but I mean, probably I can say that he's probably the father of geriatric psychiatry in India, because he's the one who started this project. And the project actually showed that there were a lot of people who had depression. Dementia wasn't so much. There were a lot of psychosis in the older people. But depression is something that he spoke about and talked about afterwards. Then in 1998, there was HelpAge India seminar, which is still relevant, and I think Alka and the other committee members should look at this. Basically, there are 4 regional meetings, and many things were suggested at this HelpAge India seminar. And as Alka said, a lot of these things have still to happen. Then there were other reports of the ICMR, workshop on research and health priorities for geriatric medicine and aging. This is again 99. Now, 99 is a very significant year because this is the year that the national policies for older persons were promulgated. And this is the year that Professor Tiwari and us, we started the geriatric psychiatric services in Lucknow and at NIMHANS in Bangalore. Though the geriatric psychiatric services, as you heard Dr. Prabha saying, it started way back in 1990 and then it went through a lull because Dr. K. Srinivas had left. So the International Year of Older Persons really, the UN declaration of the International Year of Older Persons really gave a kind of impetus. So we know that policies and programs are important and recognition from bodies like the WHO and UN are really important for this impetus. So I mentioned that preliminary explorations recognized that there were mental health problems in the elderly. The epidemiology of mental disorders in the community was mainly studied both in the rural areas and also in the community by Dr. Venko Rao. And as I mentioned, there was depression, psychosis. Suicide is something that he said was there. And he showed at this point in time itself the association with physical illnesses, which is something that WHO and other people only recognized much later. Dementia was not as common. And the other stalwarts who are all not there, unfortunately, are Dr. Ramchandran and Sharda Menon in Chennai, Venkavra in Madurai, Nandi from Calcutta, and of course, Dr. Tiwari, who's right here. These are the people who did all the early studies. So people said in the 80s, 90s, oh, there is no dementia in India. But till the dementia studies came along in 96, and so there were a whole bunch of studies done in Cochin by S. Shahji, in Chennai by Sharda Menon and other colleagues. In Delhi, this is the Indo-US study by Balabgarh by Mary Ganguly and others. Charles Pinto and Vas in Mumbai. And then again, later on, Dr. Rajkumar in Chennai. These are the studies that said that there is dementia. Maybe 1%, maybe 2%, maybe 3% in Kerala, but there is dementia. The other breakthrough that happened was the Alzheimer's Disease International Conference at Cochin in 1998, where Shahji, myself, Trikala, many of us were there, and we formed what is called the 1066 Dementia Research Network. And that, I think, gave a big impetus to dementia research in India, right from 2000 onwards. And this is the first ADI conference, first international conference really, that is held in a developing country. And this is really the push by one of my dear friends who's no more, Dr. Jacob Roy, who really started the ARDSI in India. We went on in these initial years to developing Indian instruments to assess cognition and ADL and other aspects of cognition. So there was the Hindi Mental State Examination, the Everyday Ability Scale for India, the 1066 instruments. The ACE was sort of standardized. ACE was sort of adapted by Mathuranath and others for the study in Trivandrum. And then later on came the NIMHANS battery for the elderly. So basically, they talked about adapting education and culture fair instruments because you needed these assessments to really make any kind of studies. So again, I mentioned the birth of the geriatric mental health centers started in Madurai, Bangalore by Keynes. Of the Indian Psychiatric Society and also the IAGMH. And of course later on the journal, the RTC I mentioned, and then other societies which are there which looked at aging and then made dementia and depression part of their circle was the Gerontological Society of India. And the other fillip that which brought about treatment for people who had old age problems was the availability of dementia drugs way back in 2000. First, rivastigmine is available, and then in 2002, donepezil came in. And then we had many second generation antipsychotics and the SSRIs, which again sort of gave a large impetus to treatment of these patients in our country. Then of course later on we had more recently the clinical practice guidelines which was made for the Indian Psychiatric Society by SHIVA GOAM and others. And many of us were part of that enterprise looking at the clinical practice guidelines for geriatric mental health. Now, obviously, to develop centers like the ones in Lucknow and Bangalore is very important, because we need centers of excellence like this. Just like we have aging centers in Delhi and in Chennai, we need centers of excellence in geriatric mental health to basically deliver not just clinical care, but also to do specialized training and critical research in this whole area. We need to be, as Alka said, deliver the complete range of personalized geriatric mental health services, for not just for the treatment of illnesses and palliation, but also for prevention of disorders. And we need to really make the personnel available by training courses, and we need to do much more in terms of promoting public health initiatives, because we know there is initiatives for prevention of mental disorder, especially dementia now, because 40 to 50% of dementias in our country could possibly be prevented by preventive strategies. So also for depression and suicide. But we need to really take it out there to the public and advocate that these are things that are available. This is something that Shikla will, I think, focus more on, but basically the geriatric clinic and services will have multidisciplinary approaches, which is something that she will talk about. Other things that happened in the years 2000 to 2020, through those 2 decades, was many policies, programs, and legislations for the elderly that came in the country, and that's a very good thing. And Alka mentioned this. Many geriatric clinics came up, over 200 memory clinics. The good thing is that the Medical Council mandated that every medical college should have a geriatric clinic. So at least for inspection, there will be a geriatric clinic that is there. But many places, it's kind of started off and it's picked up. And there are many more young faculty who are getting interested in this whole issue of geriatric mental health. We had more training programs for health professionals. There are manuals that are made by the ministry for geriatric health and also for geriatric mental health. The other thing that happened is the ADI publications for World Alzheimer's Month, which you will see. The Dementia India report, which some of us fashioned. Dementia India strategy and Dementia India in 2020. And the other thing which again gives a big fillip for geriatric mental health is the Lassie Longitudinal Aging Study of India, which started way back in 1718, but we had the first wave and report come out in 2021. In later years, again, policies, some of it Alka's mentioned. National Policy for Senior Citizens, 99 and 2011. National Mental Health Policy in 14, which makes a mention of geriatrics. National Health Policy. These important 3 legislations, both the maintenance and welfare of parents and senior citizens, which is very important for care of the elders. But the Persons with Disability Act and the Mental Health Care Act also has a lot to talk about people with dementia and people who cannot care for themselves. The NPHC is a national program which is launched in 2011, but it's still sort of taking off. Elderly are also handled in the national program for the non-communicable diseases, mental health program, and now we have this what we call as a WHO decade of healthy aging, which is 2020 to 2030. These are the different programs for the elderly that were launched in India. NPHC I already mentioned. There's also a program called the Integrated Program for Senior Citizens, which is now launched in many of the geriatric medicine departments in more than 15 regional geriatric centers. And of course, we heard the Ayushman Bharat initiative, which is again very welcome for the elderly. Many research initiatives. I mentioned the WHO SAGE, of which Somnath Chatterjee was one of the, we had the aging report from that, waves 0 to 3. The 1066 studies. The DST and DBT gave a lot of money for cognition and aging, and many of us were sort of, received those fundings, and we could do a lot of work that went on. So you had the cognitive neuroscience studies, the ADBS, the eye support program, the LASI, there's a dementia science program which was launched by the DBT a few years ago, and it's being anchored by Suvarna Aladi and others from NIMHANS, together with others. And there's the ADI STRIDE, which basically looked at dementia care all over the world. So LASI is going through second and third waves. The second wave of the LASI data is over. Second wave of the LASI main study is going to happen this year. LASI wave 3 is coming up from next year onwards. There are a lot of cohort studies like the SANSCOG, the TLSA, ADBS, DBT Aadhaar. Indian finger trials are going on. And there is an Indian enigma. This is the global action plan on aging. We have almost reached 2025, and many more things have to happen. We still don't have in India a national dementia strategy, and that's something that we're trying to push for. All of you have seen this global network for age-friendly cities and communities, and age-friendly Kerala has happened, age-friendly Karnataka has happened, but age-friendly other states are yet to happen. That's age-friendly Karnataka. There is a launch. You can see Shivkumar up there, and he's been quite prominent in that, in making it come to Karnataka. This is a decade of the aging. Again, not going to go through this. And BMS, again, a big initiative from NIMHANS and team from here for advocacy and for public awareness. This is the last two slides of mine. So when you plan for the future, just for, I think we have a lot of policies, programs, and legislation, and we need to really push them to see that is happening. Create a lot of public awareness and education about disorders and talk about prevention of disorders. We need to create access for healthcare in the community, both especially home-based programs and telepsychiatry programs. A lot of training has to happen with geriatric health workers, doctors, nurses, health workers, and so on. And there are some initiatives that have happened, like the ECHO and the IPS Indians and the Tele-Manas programs. Prevention is a big deal, and I think needs to be done. And we need to have a lot of research on epidemiology, risk factors, service delivery, prevention, and caregiver issues. I'm not going to cover this. It's the same thing. Basically, it's talking about using the existing systems for dealing with and challenging healthcare. I will stop here. Thank you very much.
Thank you, Matthew. Thank you for a real bird-eye view over the last 4 decades and peeping into the future, what's going to happen in the current. Thank you. Now I would invite Srikala to talk about the geriatric clinic in NIMHANS from 2010 to 2016. That's what she said she's intended to talk.
I think most of you, good afternoon to everybody. Sorry we are delaying the lunch. And when you have a photograph, you usually widen it to see the smaller pixels. And that's what we are going to do now, because I think Matthew has covered the whole of India. So widen it, zoom it, and come down to NIMHANS and look around you. So I'm going to talk about, because this is the 25th year of geriatric, we started it as geriatric clinic and services. What happened in those first 25 years of starting, because NIMHANS already has a history of a geriatric service starting and for some reason winding up. So how did we sort of manage that and continue to survive for the next 25 years, and we hope that it is eternal thereafter. Okay. So this is our NIMHANS. If you come in February, you can see this with all the tabubias in bloom. And this is late Professor K. N. Srinivas, who started the geriatric services on a Tuesday afternoon of Unit 2 in 1980s, ran for a year and a half. I think Dr. Chaturvedi was also with him. You were also with him. And then it sort of folded, I think, when Dr. K. N. Srinivas retired. One of his senior residents tried to continue that, but somehow did not get the attention of the people at that time, and it sort of folded. And then in 1999, I think Unit 3 and Unit 5, Matthew and I got together and we said, we need to somehow revive this because that should be our future. And we started in September or October of 1999. We started with the permission of the head of the Department of Psychiatry, who supported us a lot. We started it on Saturday afternoon in the first floor of the outpatient of Department of Psychiatry. It will start at 2 o'clock and go on till, there are times when we have gone on till 8 o'clock. Usually it will close down at 6 o'clock. And the feeding was mainly from the various departments. It's mainly from anybody who walked in and the GDMO felt had a neuropsychiatric condition and would refer to the junior resident who's from Unit 3, who also represented the geriatric unit, or from psychiatry, other units, neurology, neurosurgery, and we have a center for well-being in BTM layout, which is about 4 kilometers here, and they would also refer cases to us. And other people started referring people to us. So I think Matthew, so since it was a very, very skeletal unit, the number of faculty who were involved were also quite minimal. And these are all people who are seeing on the blue. Is all over time we evolved. It was mainly Matthew, myself, Shiva Kumar, Santosh Loganathan, who was posted in the unit. Some of them we had to because they were posted in the unit 3 or 5. I think Preeti Sinha and Ajit Dahale still are with us, and KP, that is Krishna Prasad, is also with us, who has joined, but Santosh has moved on to family psychiatry. So we did a lot of, and then we had a lot of liaison with other people. I think the person who first willingly came to us was Dr. Joy Vijayan, excellent neurologist. Subsequently, we are always thankful to Professor S.R. Chandra, who really made a lot of difference to our multidisciplinary, collaborative liaisoning work, and also Professor Mathuranath, who has done a large epidemiological study near Trivandrum. And then neuropsychology, I think I'm not sure whether Keshav Kumar is here. He was always there during both for an assessment and also for intervention. And Tirumurthy, even today, he leads many of the activities as a social worker, and especially in the elderly, in any aspects of elderly, a social worker and the inputs of the social worker is very, very important. And he's a professor of social work, and he is very, very, very much interested in old age issues. And the collaborations were a lot. So as I said, for our clinical services, it was mainly social work, neuropsychology, psychiatry, neurology. For our lab investigations, neuropathology, radiology, chemistry. And for our interventions, it was mainly yoga services, speech pathology, and molecular genetics lab, thanks to Sanjeev Jain and Meera Purushottam. And we did a lot of outreach work with Girish Rao from the Department of Epidemiology. And we had a Girish Rao from the Department of Epidemiology and Center for Public Health. And we had a lot of outside collaborations, both for outreach, referrals, and research and training. So one of them is mainly, Matthew has mentioned, Artsy with the Jacob Roy, and other senior citizen forum. I would say that between 1999 to 2007, we managed to survive to a large extent. And in 2008, we got our first set of, there were junior residents, senior residents, faculty were very, very committed. Matthew had the 1066, I had the psychiatric mobility in elderly, So with the project officers, we were managing. But once our research budgets became more regular and we had PhD students, actually the clinic took a very, very different sort of color. We had our first PhD students, Bhavani Shankar and Lakshmi Narayan. In 2008, thereafter you can see that our ability to grow, in fact, both the detailed workup and the follow-up almost tripled and then went up 6 times. And that is really, really remarkable. It sort of enabled us to say, yes, we are able to provide the services which this city and the suburbs of the city needs. Again, we were also able to look at the data over 3 years, and we found that 67% of the people who came to us were ill, and many of them had dementia, came because of memory disturbances, and a small proportion, about a quarter of them or more than quarter of them, had depression. So this is only a hospital-based one. It has nothing to do with the community. And they all knew that in NIMHANS it was mainly people with memory disturbances go, people with depression go. And these are the wonderful people who supported us. I think we constantly say Matthew and Shrikala. It is not that. These were the people who helped us. I think I should remember Prafula, Shilpa, Lakshmi Narayan, all the others, the PhD students and the project officers who did enormous amount of work to help us run this clinic very successfully, because we have never had anybody saying, being disgruntled, saying that I did a wrong thing. Of course, it was always crowded. I can say that NIMHANS is always crowded. But if seen, they'll be very, very satisfied. And we started having inpatients. And the amount of outreach work they did was phenomenal, along with the help of Girish Rao from the Department of Center for Public Health. I think we did it in almost every place. Name it, we would have been there. Every park in Bangalore. I think we were the first one in Bangalore to set up instruments for the elderly so that they could exercise their arms and legs and everything very, very early. And after that, many people have copied that. But we set it up in Krishna Rao Park, and then it became a model to BDNP to sort of copy. Very many places. Okay. And we not only did clinical services, we also did a lot of training. The training was of the JRs who were doing MD in psychiatry. At that time, we also had DPM. So both the types of people, and the other, MPhil in clinical psychology and psychiatric social work, mainly neuropsychology. And then we also had, and nursing people were also posted. Then the PhD scholars, mainly if their area was one of interest in geriatric mental health. We had the project officers who later became actually PhD scholars. Then we started the PDF in 2014. Sharanya Dhanashekaran was our first PDF. And then we did a lot of physicians training in CGHS on invitation. We also had observership. And then career training through collaborations with ARTSI and also with Nightingale's Medical Trust. I think, so we constantly did a lot of training with the people who are within intramural and extramural. Research was always from day one, from 2003, I think we were a lot into research. I think Matthew has already talked about this has been published, and now they are trying to make it into a tool with the copyright of NIMHANS. It has been submitted. I think it is much more to do with the admin to sort of bring it out. NIMHANS neuropsychiatric battery for the elderly. Okay, and Keshav also has a computer-assisted cognitive retraining for the elderly. And then one of our first, when we had the first MRI, fMRI, it was a new tool for us. So almost all our projects got written up only for the neuro radio imaging of the people with memory disturbances. And we got quite a few DST, ICMR, telomere. all those projects we got and we were able to do it. A part of that continuation is the Enigma project of Dr. John P. John. Then we had, for the intervention, we had a yoga-based intervention for the elderly and other non-invasive intervention for the elderly, and also in depression and in minimal cognitive impairment. They are not very, I won't say that without doubt that they are very helpful, but there is some indication, especially in MCI. Okay. I think the publications have been quite a few. I'm just talking about 2016. After that, I think it became a unit, because in 2016, 15-16, we started putting up applications to the government of India to say that we need to become a unit and we need DM. So quite a few highlights. So I don't think in 2020 we were involved, but Matthew has been part and parcel of the LASI and also the WHO ICD 11-1, and the unit has won the Vayo Shrestha Samman Award in 2016. This is one of our first publications, so we are very proud of that. Thank you for being a patient.
Thank you, Srikala. I think that's a very nice journey which you showed to us in NIMHANS, starting from a single once a week clinic to being the leaders in this country in a way. This department is becoming leaders in geropsychiatry. Now, finally, I would give 4 minutes or 5 minutes to Shivkumar to peep into the future, because every one of us are getting hypoglycemic maybe. Sorry, Shivkumar.
Yes, sir.
I'm sure you can do that in 5 minutes.
As to what my job was to look at the current status and look at the future. So I think that this history we have already heard about how it has grown from a weekly clinic to as a special unit, and we always have the gratitude for our teachers and founders. And this 25 years of growth, what we have now, what has happened with the kind of evolution from a special clinic to geriatric psychiatry unit? Primarily, the context was the demand in terms of increase in services. A weekly, one-day clinic, half-a-day clinic was not sufficient, as Dr. Shikla Madam was telling. We used to go up to 7 o'clock or 8 o'clock, and patients would come and wait from 6 o'clock in the morning, because they would come as usual to the OPD in the morning, and then they'll wait till the evening. So, and we also, because we have to have a special unit, we need to have a dedicated human resources. And one way of doing that was having a training courses, because that's the mandate of the institution, academic institutions. And Dr. Tiwari paved the way by getting the first approval for the first DM. And that gave the impetus for us also to kind of start the DM course here. And that actually helped us to manage the unit. And now there is a kind of the focus is on multidisciplinary training courses. The one model what we have taken is it's not just only the psychiatrists. We also have fellowship courses for persons from psychology, clinical psychology or social work background in the geriatric specialization, and also for nursing, geriatric mental health nursing. So truly a multidisciplinary kind of training and human resource development is one of the important tasks we have achieved. And also the collaboration, we have, whatever we had developed, we have strengthened more with the government and non-governmental organizations, and still it is an ongoing process. All our partners whom we acknowledge today, we have been working very actively with them. So there's a resource, still I would say it's much less in terms of what we have for the need. And what is the kind of need? It's not just the numbers, it's the kind of intensive actually work what is required. More of non-pharmacological interventions, outreach interventions, institutional care. So there's a lot of need is there, and the human resources still something like we have been advocating to improve it. So the vision, as we have discussed earlier, is to truly establish a center of excellence in geriatric mental health care by implementing clinical services, training, research, and advocacy of global standards in the field of aging and mental health. I think we have a track record of 25 years. It is something for us to be proud, but I think we still have a long way to go. And NIMHANS establishes standards across the specialities. I think we have to grow in terms of geriatric psychiatry. I would say still we have a long way to go to claim that standards and achieve much more progress. And we will be working on that, the younger team now, we are into it. So the OPD services are there, emergency services are there, and the specialization in terms of neuromodulation, telegeriatric psychiatry, again, the recent developments, COVID again gave a lot of impetus to telegeriatric psychiatry. A lot of people did, and here also it is there. The strengthening of the team has expanded the psychosocial support services. I'm happy to share that with a lot of advocacy. Now, the Department of Clinical Psychology has agreed for a full-time faculty. Till now it has been part-time, and also the students are likely to getting posted in the for the training of geriatric psychiatry. As a new specialty, there is always a demand and competition. Something has to be adjusted for the training to kind of have in our particular specialty. Everybody competes for it. Similarly, for the nursing, again, MSc nursing students are going to have 1.5 months of postings. This is something, again, a new development. So the training, not only for the people who are undergoing fellowship, those who are having a general training mental health courses, they also will get more exposure in geriatric psychiatry. With the collaboration with the Legal Service Authority, we were able to start a free legal services clinic for senior citizens, which is again functioning, and a lot of people have this kind of challenges, and they are able to get some support. And support in old age homes is again something which we have made a more formal collaborations and have been able to provide. Both the registration, the footfalls for the new patients and follow-ups have been growing. The dip was due to COVID. The last 5 years I've shown. And again, admissions, again, with the specialized unit being dedicated resources available, we almost have an equivalent admissions or to the adult psychiatry unit. A lot of our patients have medical comorbidities. They come from long distances. That's why the inpatient also is more, because the evaluation and the Ayushman Bharat insurance actually helps a comprehensive evaluation of dementia, particularly for people who have early onset and rapid progression. We're able to do it. The psychosocial support services, still there is a lot of scope to grow. I think we need a lot of human resources support for these things. We are looking at option of how to increase this. There's a lot of challenge in terms of language compatibility, availability of time. Patients, even when we want to give also patients coming and taking such services is a challenge. So that's why we need to have a home-based approach, or a tele approach has to be there. If you look at the population, most of them are 60 to 69 and 70 to 79, but we still have people on centenarians, 90 plus also getting services. So that's important. And some of the younger people, again, people with dementia of any age are provided service in our unit. So even less than 60, we have a considerable, sizable number of population. And if you actually see the male, female, more male actually have been coming. Again, there is a gap in terms of female population actually seeking help. That's again, there's some kind of neglect is possible, and people who are coming to service and getting that inputs. Depression and dementia are the main chunk of disorders where we do, and there's also chronic psychosis and bipolar, late onset bipolar again is there. So in terms of training, I think the DM and the fellowship already has been talked about. Fellowship in psychosocial care for elderly and fellowship in geriatric mental health nursing. These are the courses which are currently going on, along with PDF in psychiatry, geriatric psychiatry. So these things have given exposure to hands-on training, and this has helped us to collaborate and extend more outreach initiatives. It has also kind of led to more research and publications. I'm not kind of giving you all the statistics in this for want of time. And several initiatives, CSR supported initiatives and philanthropic supported initiatives, training of caregivers, training of doctors, awareness programs, volunteering. So these are some online support group, again with the collaboration with Dementia India Alliance. These are some of the initiatives, outreach initiatives. There are major cohort studies. Some are trans-diagnostic cohorts, looking at the high-risk issues, biomarkers. Some of them are long-term cohort studies, NIH-funded studies, including integrative medicine. This is something like Entra, which is a project. And many of these things, there are stalls. I would invite people to go and have a look at it. We'll have more engagement with the teams. You can know about what is happening. And NIMHANS is also trying to collaborate with other centers. In the future, we'll try to have consortium. And one of the, I think, collaborations, Lassie Dad, Dr. Matthew is instrumental for it. And I think we are the only psychiatry department who is part of this collaboration, where there are 20 centers of mainly geriatric physicians. And this is contributed to the prevalence and the incidence which is going to come up the data, as well as this is going to be a most important data for all of us to use for advocacy for dementia. And echo training already talked about. I think another most important project, which I'll be talking in the next talk, is about public health approach. I will spend more time during the next talk. And Vayomanasa Sanjeevani, again, is something very, very important for us, from the range of things like public awareness to training of volunteers and the books, what we have already talked about. In multiple languages, Kannada, Tamil, it is already happening. And during the COVID time, we also had an active engagement program online, and a lot of internship for students from psychology, social work, nursing. Many of them, they attend internship through this initiative. And so the capacity building is another important task what we are doing. The book, what we already talked about, some of the copies are available. People can refer. It's freely downloadable from NIMHANS website and VMS, Vayomanasa Sanjeevani website. So the HelpAge, with HelpAge India, we are launching this Sarthak initiative, again, trying to see as to how with mobile clinic, what they are having for general health care, how mental health can be integrated. And for institutional care, we have an MOU with Nightingale's Medical Trust, where destitutes we are providing the care. And these are a lot of capacity building programs, and we have been going very active in the field. So as Dr. Shikla Bharat highlighted, we were awarded in 2016 for the National Award for Vayoshrestha Best Institution for Aging-Related Research in India. This was one of the important moments where the government recognized us, and then that led to support from the state government and more collaborations. And the state government of Karnataka also awarded in 2017 as the best institution for services for senior citizens. We got some 6 lakhs award money, and we used that award money to develop electronic record system. And that gave the impetus. Dr. Preeti Sinha is here. She was the instrumental person to develop further. And as I said, Dr. C.R. Chandrasekhar, he donated 1 crore for the geriatric mental health, particularly for dementia. And again, that is a corpus. And Shikla Madam also has announced a similar contribution. This is going to help us in developing the outreach program where home-based services we are trying to provide. Nevertheless, with all these developments, still there are challenges. There is a lot of demand and increased complexity. Medical comorbidity is a big challenge for us. Being a mental health institution, don't have a general physician background. We are fortunate to have a visiting physician. Again, collaboration with geriatric physicians, we are trying to strengthen this part of it. Complex psychosocial issues, need for caregiver interventions, all these things we are working on it, and it is a time-intensive and human resource-intensive issues. So what is in future? We are working on a specialized dementia care unit, 12 beds. It's going to be ready in the next 6 months. Already the building is almost ready. This is going to be a new infrastructure what we are going to use for further service. And a Center for Dementia Care Training and Research. We got some funding. Actually, because of COVID, some challenges, it couldn't be sustained. It couldn't come through a center. But we have been proposing to the government now, and also the other CSR partners. We are trying to get a big funding for this center in our outreach campus in Sakalvara. And we want to expand the support groups more in person as well as online. And licensed psychiatry. Again, something, since we don't have general medicine, we are trying to collaborate with nearby hospitals and take it forward. We're also planning to collaborate with PGH Chandigarh and AIMS for sending our students there, our trainees there. I think the DM people should have better exposure into CLPs. So I'll be reaching out to Sandeep And daycare center, again, we are working on preparing a daycare center. This is a new building which is coming up as part of a specialty block. This is one floor. The ground floor is going to be the dementia special unit. And lastly, I think the focus is on a clinical registry and a case management based approach. In clinical registry, we are talking about forming a consortium and see as to how we all can collaborate and try to kind of get a less intensive kind of whatever routine care what we are doing, even that the outcomes and experience what we are gaining. I think if we all come together, the contribution for the knowledge and for learning can be very great. So that is something. And all our services has to become elderly friendly and age friendly, which still is a challenge in our setting. We are all in not a very ideal situation. So we are working on it. And electronic records is another thing. We are going to start for inpatient services and emergency services also. And this is also going to help us in kind of documenting better. And we look forward to eventful another 2 decades. We are looking for suggestions and we're looking for partnership and we're looking for guidance from our mentors. And I take this opportunity to thank my whole team and all of you for the support and encouragement. And my father is here, so I'm always thanking my parents and all my family for the support. Thank you. Thank you.
Thank you, Shivakumar. Thank you, Matthew, and thank you, Shrikala. You three, past, immediate past, and the current and future, have projected what has happened in NIMHANS, but I think here there are literally few hundreds of people of multi-specialty and psychiatrists. Probably this is the models which we should use for developing geropsychiatric center across this country. Only thing I think we didn't touch about the private centers, but that would come in some one session, as I know. We have a session for that. Thank you very much for giving a real good vision, not only for what you have done, but what you are going to do in the future. And I'm sure the government of India has also is taking quite a lot of inputs from the research going from here and the past research across the country on the geropsychiatry. And myself and my co-chair would like to thank the organizers for giving the opportunity.
Thank you, thank you speakers and chairpersons for the wonderful session and wonderful insights into the geriatric clinic functioning. I would now like to call upon Dr. Rajkumar Lenin, Professor and Head, Department of Psychiatry, RIMS Imphal, to felicitate the speakers, Dr. Matthew Verghese, Dr. Shrikala Bharat, and Dr. P.T. Shivakumar.
Come in the front.
I would now like to request Dr. Mrugesh Vaishnav, a former President Indian Psychiatric Society and Senior Consultant Psychiatrist Ahmedabad, to felicitate our chairpersons, Dr. G. Prasad Rao sir and Dr. Mohini ma'am. Now we'll break for lunch and simultaneously 45 minutes of lunch, and there are parallel poster sessions going on in the first floor. Lunch is arranged there as well. So you can have lunch and have a look at the posters there. Thank you.
Good afternoon, everyone. Please settle down soon. We'll be starting the session now. Please ask other guests and colleagues to please join soon. Thank you. So now we then we have to invite the chairperson, both of them, and then we will tell Chandrasekhar sir to give the opening remarks. Okay, and then I will you tell I will introduce both the chairperson. You tell Chandrasekhar. Okay, I will tell Chandrasekhar sir to give the opening remark. Then he will give. Then after that, Jagdish sir will introduce PT sir, and we will hand over to this one.
Okay, so I'll give the first para. Good afternoon, esteemed colleagues and guests. Welcome to this special session on the Geron conference dedicated to the Professor SHIVA GOAM Oration Award in Geriatric Mental Health. I am Alvin and this is Priyanka. We are honored to be the MCs for this distinguished event. Today, we celebrate not only advancements in geriatric mental health, but also remarkable individuals who have made outstanding contributions to this crucial field. The Professor SHIVA GOAM Oration Award is a testament to these exceptional achievements.
I would now like to welcome our esteemed chairpersons for this session. Padma Shri Dr. C. R. Chandrasekhar sir, former senior professor of psychiatry at NIMHANS, Bengaluru, on stage. We welcome you, sir. And we are equally privileged to have Dr. A. Jagdish with us. He is the managing director and consultant psychiatrist at Abhaya Hospital, Bangalore. His expertise and dedication to mental health care have been exemplary, and we are looking forward for his insights. We welcome you both, sir. Can we have a round of applause? Now I would like CRC sir to please give opening remarks for this session.
Yeah, then after that, Jagdish sir will introduce the speaker.
ನಮಸ್ಕಾರ ನಮಸ್ಕಾರ ಊಟ ಮಾಡಿದ್ರಲ್ಲ ಡಿಡ್ ಹ್ಯಾಡ್ ಫುಡ್ ಸೊ ಪಬ್ಲಿಕ್ health issues regarding geriatric psychiatry. I am 76 years young. I tell people, don't ask how old are you. Even if they ask how old are you have to say, I am 70 years young, 85 years young, 90 years young. Before Dr. Shivakumar present his paper, Dr. Shiva Gautam was my classmate. Dr. Shiva Gautam was my classmate. His entire family and my family were close friends. So I'm very happy and proud to say this session. Dr. Shiva Gautam's name, the oration award is going to Dr. Shivakumar. It's a double dhamaka. Double dhamaka. One aspect I would like to bring to your notice. When we talk about public health, because so many issues are there, financial issues, security issues, health issues, mental health issues, then fear of death, fear of dying. Then you also worry about where we will go after death. Whether we will go to heaven, see Rambe Urushi dancing, or we will go to hell because we might have committed many mistakes, we might have committed many blunders in life. Whether we have rebirth again. Because Karma Siddhanta, we Indians believe in Karma Siddhanta. Do good work, God will bless you. Our Atma will reach Paramatma. If you don't do good work, then I have to accept the punishment by taking various forms of rebirth. I may be born as a animal, I may be born as an insect, I may be born as a man, or again, whether I will be born in lower caste, higher caste, upper class, lower class. So all these issues bother us. One concept of Vanaprastha, I think the Indian Association for Geriatric Mental Health should take it up in a big way. All of us know there are 4 ashramas. 4 ashramas. Brahmacharya, the first ashram, goes up to 25. Next, Grihastha from 25 to 50. Get married, have children, earn money, earn status, earn whatever you want to earn. Become a bhogi. All pleasures of life you enjoy. Then after 50 or 60, Vanaprastha. The exact meaning of Vanaprastha is way to the forest, way to the forest. Now we don't have any forest at all to go to forest. But the concept of Vanaprastha, very, 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 very needed for promotion of mental health among elderly people, and also not to cry, not to become unhappy, not to worry, but enjoy the old age. Can we tell the main concept of Vanaprastha? Anybody? What is Vanaprastha? From attachment to detachment. From attachment to detachment. You get attached to your family, get attached to your money, get attached to your property, get attached to anything you earn and use for your bhoga. So after 50, all those sages, all those scriptures, sort of Veda, Upanishad, even Charaka Shishwata, they all talk about the sense of detachment we have to develop. That means reduce your desire, reduce your greed, reduce your needs. Gautam Buddha told the source of human misery is only one thing, desire. Excess desire or greed. Even now, at the age of 90, people want to become CM of Karnataka. At 95, people want to become Prime Minister of India or start a new company and earn in crores or have 10 sites, 14 sites, 20 houses. That makes people to suffer in old age. So the concept of attachment to detachment and reduce our needs to minimum. Your food needs, the food served, do we need all the items? Go to a marriage party, 50 items will be served. Go to a five-star hotel, 70 items will be served. So reducing food needs, reducing needs of cloth, reducing all our needs, make our life simple. So can we spread the concept of simple life, simple living, and tell our children, tell our grandchildren, tell all young people, take care of yourself. I will get detached. Even let me accept death when it comes. All of us know date of birth because we were told when we were born. We celebrate our birthdays. Do we know our date of death? I don't know. Death may strike at any time. Though we know death is inevitable, but all of us do not want to die. We want to become Chiranjeevis, at least live for 100 years. So one theme for promotion of mental health in elderly people, wherever I go and address senior citizens, I tell this. Today we are, tomorrow we don't know whether we'll be there or not. So, moha kami madi, the passions, the attachments, we have to reduce and then try to live with minimum needs. And also cut down your expectation. What my son should do to me, what my daughter-in-law, how she should respect me, how grandchildren should love me. We have a concept of a droplet of water on lotus leaf. Lotus leaf is there, a drop of water is there. It is there on the leaf, but still detached. So with this concept of Vanaprastha, I was looking into the Google. They have given all the details of what I'm telling. Or if you open Google and then read the Vanaprastha, which can be applicable to our life. That's the best way to improve mental health of elderly people. After 50, we should prepare ourselves from 50 onwards. 60, we enter into old age. These 10 years, mentally prepare yourself to detach yourself from money matters, from various pleasures of life, and preparation for old age. And then accept the limitations of whether social connectedness or money matters or various desires we entertain during 25 to 50. You have to get to fulfill as much desire as possible and then stop. After 60, no desire, no greed, no high ambitions, and prepare for the final day when we take leave. You have come here to this world as tenants. We are not owners of earth. We are not owners of land. We are not owners of all the items we purchase. So this concept will help. And also now in the last 10 years, we are seeing how elderly people are being isolated. Elderly people are left to themselves. Joint families have gone away. Nuclear families are becoming further smaller. And elderly people are totally neglected. And we have to request the administrators or the government or other philanthropists to help the middle class, lower middle class, even rich class senior people are not cared for. And the health problems. You may lose your companion, but all the companion diseases will not leave us. People come and say, I take one fistful of rice, another fistful of tablets. And the tablets increase, 20, 25, 30 tablets that we take. I don't have money to go to hospital. I don't have money to buy the drugs. So I have to change the way of life. I think Dr. Shivakumar is going to talk about the public health. In public health, one is at 3 levels: primary prevention, secondary prevention, and tertiary prevention. So let us hear to Dr. Shivakumar's presentation. And many of us have entered 60s, 70s, and even beyond that, and prepare people in the community to accept old age as an enjoyable age group, and also request the society to respect the elderly people. Even that is going down. People do not want to respect the elders and think that they are burden to the family, burden to the society. Again, this concept has to be changed through institutions and also through public education. Thank you very much.
Now we will start the session. Good afternoon. Welcome to today's program. I request Dr. Professor P.T. Shivakumar to come out to the dais, and he is the person who is going to deliver the talk. today I would like to just mention few things. As Dr. CRC, we are very honored to have you, sir, here today. There are only 3 psychiatrists who has got Padma Shri, Dr. Sharda Menon, and we are blessed to have Dr. BNG and Dr. CRC with us, both are from our alumnus and my teacher. So thank you for your wise words, sir. Now, coming to the Dr. SHIVA GOAM Award. Dr. SHIVA GOAM Award is one has been introduced in the, today we celebrate not only advancements in geriatric mental health, but also the remarkable individuals who have made outstanding contributions to this crucial field. The Professor SHIVA GOAM Award, Oration Award, is a testament to these exceptional achievements. Professor SHIVA GOAM is well known among our community, one of the senior most psychiatrists, alumnus of this institute. He is the one who has initiated this prestigious award of IAGMH. Dr. SHIVA GOAM is a distinguished psychiatrist practicing in Jaipur. He was the director and professor of psychiatry at the Gautam Institute of Human Behavior and Alternative Medicine, Jaipur. Formerly, he served as additional principal at Savai Mansingh Medical College, Jaipur, as a member secretary of the state Rajasthan Mental Health Authority. Apart from that, he did his MBBS from SMS Medical College and MD from NIMHANS, MNAMS, and he has done MNAMS also. More than that, I would like to tell his contribution to our association is immense. And rightly today, we have initiated an oration in his memory. He has hosted many conferences, and he is a past president of Geriatric Association of India. Apart from that, he was also a past president of IPS. Then he was actively involved with clinical practice guidelines in psychiatry. He has contributed in all spheres of psychiatry. Today, we are very honored to have an oration in his name. And who is the person who is going to speak? It's none other than Dr. P.T. Shivkumar. P.T. Shivkumar is professor and head of department of professor of psychiatry, heading the Department of Geriatric Psychiatry, a unit of at NIMHANS. He has affiliations to Joint Secretary of Indian Association Geriatric Mental Health, technical advisor to Dementia India Alliance, nodal officer to Vayomanasa Sanjeevini, and other than that, he has published more than 100 peer-reviewed publications. Research interest is in the area of healthy aging. That's what is more required. Late life depression, Alzheimer's dementia, and MCI, mild cognitive impairment. Apart from this, people should know today, those who have come from outside Bangalore, Vayomanasa Sanjeevini is an ongoing program. Every week they will have a webinar where hundreds of people will come to discuss about mental health issues related to aging. Today, so far, he has completed 200 weeks continuous program. It's not a small achievement. 200 weeks, that means around 4 years continuously is doing the program. He invites speakers from all spheres of life, psychiatrists, psychologists, volunteers, counselors, and it's a comprehensive care to the people who are aging and having a problem, and they all come on that platform, share their experience, seek help, and they deliver help to psychiatry through telepsychiatry. It's not a small achievement. That's the brainchild of Dr. P.T. Shivkumar, and today we are honored to have him to deliver this oration of Dr. SHIVA GOAM, and it's over to Dr. P.T. Shivkumar.
Thank you very much, sir. I'm very honored to have this session chaired by Dr. C.R. Chandrasekhar, who is our inspiration for all the public health services and outreach services what we do, and also Dr. Jagdish, whom I have a lot of respect and value. I always look forward to him as one of the other inspiration who has been in various, say, active role in the IPS Karnataka as well as at the national level, and is very close and somebody whom I look upon. Thank you very much, sir, for the kind words. And my teachers, I owe everything to my teachers and my institute and my parents. Now, I think this is kind of a repetition, so I spoke just before the lunch. This is about geriatric psychiatry unit, and I'm really thankful to IAGMH for selecting me for this oration and for awarding me this oration, prestigious SHIVA GOAM oration. And it's an honor for me, and also for all the work what I have done. When I say I have done, it is never an individual. It is always the unit and the institute. What opportunities I got with Dr. Matthew Verghese and Dr. Srikala Bharat, and then our team and which, as Shikla Madam was telling, there's so many researchers, so many collaborations what we have done, not only within institute and also outside the institute with several organizations, and that's what we're talking about. And now why I chose this topic of public health aspects of geriatric mental health care, I think having been in this field for nearly 20 years now, I think what excites me is something like a simple thing what we can do. If we have to make really a transformation, it is not in the tertiary care institution. If we can have a meaningful change that can happen primarily at the public health level. So I have a strong conviction on this. Even though I am in a tertiary care institute, I value a lot on promoting awareness, as our Professor C.R. Chandrasekhar has done a lot. I think when we have a lot of materials, a lot of insights, but people who are using it should be able to utilize it, even small thing if they're able to utilize it, that is very important. And how we can diagnose early and treat early and ensure that they are going to have a continuous treatment. That is something like which is a very important thing. And geriatric population as such, there are lots of challenges which we have to do. And in terms of public health, whether our elderly are getting service in general for geriatrics, that itself is a big challenge. If you see the hospital population, majority of the people in the hospitals, whether it's the primary care level or secondary care or tertiary care level or senior citizens with a lot of medical comorbidity. When it comes to mental health, again, this is something the attention given in the public health programs are quite less. So when we're talking of public health aspects of geriatric mental health care, it has to be a holistic thing. I wanted to highlight about some of the case scenarios which strikes me. Some time back, a few months back, I had a patient, an elderly person with dementia, was brought from interior village in my birthplace, Dharmapuri, somewhere remote village from near Harur, where my father had worked earlier. And this person, when she brought for the consultation, I asked, why did you come here? Having come nearly 200 kilometers without any awareness, illiterate. And I was surprised to see that there was a first consultation. She has not sought consultation from any general doctor, not approached the primary healthcare physician. She has come, and okay, why is the reason she is coming? Somebody has referred NIMHANS is the best place to come. So you go there, somebody has got better, she has come. It is by referral by one other person who was beneficiary of the service from NIMHANS. She has come. Okay, is she a person who is rich enough to afford this? She has sold her goat and other, she has bought some loan of 20,000 and then she has brought and then got investigated. Very poor person. So how our system should work? Ideally, this person should have got a consultation at the primary healthcare level. Maybe there's a medical college in Dharmapuri that should have handled, if at all there is a referral, all the facilities are available. And only if it is required, they have to come. And this story is not something which is unique for me. I think all of us working in different medical college and institutes, we will have this. People from all over the place come to us from West Bengal to Kanyakumari or Kashmir. They come with hope. And when it comes for degenerative conditions like dementia, sometimes even established dementia which has been going on for years, just few days back, currently we have admitted one patient, has come from Kharagpur, 1,700 kilometers in ambulance. The patient cannot be boarded in the flight. The family had come as a recce visit and then they've tried. So what I'm trying to highlight is, these are case stories, but these are not something unusual or uncommon. We are picking up the problems quite late. And people like, here we have colleagues from HelpAge India, they go to all villages, mental health, mobile medical units, and people like other NGOs who are working in the field, or the public health system. We need to actually gear up to pick up problems there, and that's what is the focus of my presentation. It's not moving. It's not moving. Yeah. Okay. It's not moving. No. I think there is something made that I don't want. They don't want me to present. I want only to talk. I can do that. So. See, slide is not moving. Okay, so it's not coming. Display is not coming there. Display is not coming. So I think already we have heard a lot about statistics. I'm not going to bore you again. I think we all know the burden is a challenge, not just in numbers. It is also, Ali change ಮಾಡ್ತೀರಾ ಇಲ್ಲ? There's some problem. So it is not just the numbers, it is about the impact. We already talked about the dementia prevalence, depression prevalence. We also need to know these are not something like a minor health conditions, minor mental health problems. They also cause a lot of morbidity and also contribute to increased risk for mortality. So I think we have now enough data to advocate. I think what was missing maybe in the 20 years back was a very good data in terms of what is the level of burden at the Indian level. So that is now, I think that has been filled by studies like Lassie and Lassie Dad, where we have a representative population. Almost 1/3 of the population have significant depressive symptoms, and also National Mental Health Survey. Again, is another important contribution, not just by NIMHANS, it's led by NIMHANS. My colleague Dr. Girish is there. He has threatened me that if I don't speak about it, he will target me later. So National Mental Health Survey is there, and National Mental Health Survey second is going on. And there is enough data for us to now advocate. I think as public health, there's a lot of things to do about advocacy. We have to convince the policy makers, and we have to convince the importance of mental health to the decision makers to get more resources and to start more services. And that there is enough data across the state level, across the country level, what is there. And what is important to notice, only 10% of them actually get diagnosed and treated. That too in geriatric population, it is very, very less percentage actually get diagnosed and treated. Most of them don't have. And this is going to increase, which is inevitable. It's going to double in the next, say, nearly 20 years. It's going to double. So, and every 3 seconds, somebody in the globe is developing dementia. It's a very alarming figure, but it is true. I think there's enough population-based studies, and it is also a cost. The cost of care, again, in our context, the studies which have been done from NIMHANS actually showed the cost was much lesser compared to what is projected in the Western setting, because the formal care settings were less available at that point of time. If you actually look now, the kind of cost implications what the family members have, indirect cost is something which is very huge. People have to give up the work, or people have to hire a caregiver or institutional care. It's good that services are available, but whether it is available for people who cannot afford, that's a big challenge. There are some areas where some of the NGOs have come up, Nightingale's Medical Trust, they have come up with some of the facilities for destitutes where we are collaborating and doing things. Now there is a possibility of, we are also trying to have some systems for rehabilitation of people who have dementia, at least for a more comprehensive care. We are trying to set up a facility in Sakalvara. With all these things, dementia is recognized as a public health priority, not only by us, by World Health Organization. And also depression, again, is another major public health problem across the population. Now, we all talked about prevalence, treatment gap, and burden and impact. This applies to mental health issues across the lifespan, but more so in elderly population. And the key issues of low awareness, stigma, and something which is very important for elderly is ageism, where the person themselves or the family or the society thinks it is okay for normal for aging to have depression. If they don't feel like interacting, if they're not positive, it's okay. So it doesn't get recognized. As well as if memory problems are there, again, it is considered normal for aging, unless till the problems advance to a level, they don't seek consultation. And elder abuse and neglect, both are something very, very striking, and which requires, and many times when we face situations of elder abuse and neglect, if you actually go into it and study in detail, there are many times it is helplessness is also an important reason. I don't know, people might have come across in the media. Recently, somebody was tied up in a forest. One of the lady was tied up in a forest, and in I think Gangapur here in Karnataka, there was a person, elderly woman died, and then it was very, the body was damaged by a lot of animals, and then it became a news. But if you go to that place, a lot of people are kind of, destitutes are left there for them to kind of, whatever they get, it's a charity. There's no organized system that is happening in terms of support care. I think long-term care at a public health level is a very, very important topic which we need to address. And the support systems, what we say as the strength of the family system, is a challenge, because with whenever there's a development, there is always going to be challenge. It is not that we don't want to care, but the compulsions of people, how much they can give time and how much resources they have, it's a big challenge. And what we need is not just only tertiary care. We need to, if we have to manage this, we need to promote mental health and well-being and prevent mental health conditions. If possible, delay it. If at all there is a problem, there has to be early diagnosis intervention. And it is not enough to just have acute care intervention. We need to have improvement in access to treatment for rehabilitation also, which is in fact mandated by Mental Health Act. If you look at the Mental Health Act, it says all the services, including rehabilitation services, is a right of the person with mental illness. But how many of us can say that such service is available for a person who is elderly, who is having this problem, and who cannot afford the care? I think the government is now trying to give insurance which is only for acute care. Long-term care insurance again is something which is a solution. Possibly it may come up sometime later. Right now it left to the hands of NGOs who are able to provide whatever possible they can have. The challenge is about effective and sustainable intervention. We can't adopt the Western model. We need to have resources and innovative models to strengthen the family system. But for people who cannot manage there, we also need to have a backup plan of providing support system in institutions. You can't say that institutional care is not required. In fact, recently one of the High Court judgments in Tamil Nadu had said you have to follow the Maintenance Act and start within 6 months you have to start an old age home in every district, run directly by government. You can't say you can give it to NGOs and then, okay, we will not directly get involved. I think Kerala is one state where it's an example that government is having long-term care facilities as well as dementia care facility, and they have a lot of models. Saji is here. I know they have done a lot of initiatives. In Karnataka, we have been advocating a lot. And when we took public health as issue and public health approach, the most important requirement is self-care, people to recognize the problem and seek help and support themselves, peer support. Again, we work with a lot of senior citizen forums. Vayomanas Sanjeevani is another initiative why we spread awareness. People can refer each other, people can support and network, social engagement, social isolation has to be prevented. So all these things helps. And task sharing approach. I think the pioneer of that is Dr. C.R. Chandrasekhar and our Mohan Isaac and the models of Bellary model, where the mental health care being provided at the primary health care level, what is now evolved into district mental health program and national mental health program is an example for task sharing approach. And this has to be taken further at the level of ASHA workers, health workers, and even long-term care workers. And we have been doing this whatever extent possible with whatever resources for training of volunteers and lay counselors. I think we work with the lay counselors who have been trained in Samadhana Counseling Center and various other forums. And technology, use of technology and telepsychiatry is another thing where we can reach to people. And this is also something very important. In all these things, we need to see as to how we can integrate not only mental health, general health care, psychosocial issues, including integrative medicine. We work closely with integrative medicine, yoga, Ayurveda. So because the needs of the person has to be met, and you need to promote well-being. Whatever is available, you try your best. And it has to be a person-centered care. And as already emphasized a lot about social care and long-term care, these are something which is required. And what does WHO recommends? This is the recommendation. I think you can't kind of go away from this model, pyramid model, where self-care, informal community care is most important required, and tertiary care is something which we need to emphasize. But as of now, if you look at the investment, the maximum investment is happening at the tertiary care level. At the primary health care level, the biggest challenge in India is the health systems are not connected. We don't have a referral pathway. We don't have a connected public health system. And so people are, they can seek the super specialists, but some of them who really require will not get service in the primary health care level. So another, improve the functional ability and improve the well-being. It is not, healthy aging is not only for people who are super healthy. It is about providing appropriate support. Even a person with disability, you can achieve a better healthy aging by providing appropriate support systems. And that is the framework, public health framework for healthy aging. Integrated care for older people is something which can achieve this. And I think the 4 action areas are very relevant for mental health professionals as well as others. I think combating ageism, which I already talked about, and age-friendly environment, we need to change our attitudes, and all the initiatives and outreach initiatives, what we do is to change this attitude. I think it may be a very simple thing, but it's a very slow process. It is not something which easily happens. And see how much you can integrate in our own practice. Because a lot of these principles appears very well in theory, but when you practice, it has to be simple things what you can do as a clinician. Whatever we sit, whether it's the primary care, secondary care, or tertiary care, it is about being a good clinician and being somebody who can make a difference. So I told about the example of the lady who came, and I knew the person has dementia. It is very difficult. They will come for one follow-up. This person may not again come back. What I could do for that person, because I know the person was from my native place, and they don't have a pension. They are not even getting the pension from government. And I knew a philanthropist who was able to get, who was actually giving hundreds of people every month on his own pension. So fortunately, I could connect to that person, and that person is getting a pension. So I feel more than any other evaluation and anything done for that person, by providing a referral, I'm able to kind of help that person to sustain their basic livelihood. That is something, we can't change the dementia, we can't reverse the dementia, but we are able to address their needs. That is the most gratifying thing for me. And even today, that person calls up and reminds me, okay, you made a difference to me after having come so far. And I think that is the biggest award I can get. And all these things is something like, we can talk of many things. Vayamana Sanjuni, multiple things have been emphasized. I won't again bore you with that. And I think I will end with this Naman project, which is again an aspirational project for all of us. My friend Naveen is not here. He's attending another meeting of epidemiology in Geneva. I think this is something like a very, very aspirational project, which is supported by the Australia Health Trust, AHT, and NIMHANS and Uttarakhand. AIMS Rishikesh are partners in this. This is a, say, lifespan approach, womb to tomb approach, which talks from perinatal, antenatal to geriatric populations to dementia, from prevention to rehabilitation, a big philanthropic funding from a family trust. And the work is happening right now in Belur and Munsiari in Uttarakhand. We are aspiring, maybe 20 years later, this will be talked about as the Taluk mental health model, wherein what we are trying to do is to have basic health workers, mental health workers dedicated for every PHC. And from whatever we could do earlier in the district mental health model, Bellary model, I think if this is something, Naman model or a Belur model or a Munsiari model, if it gets translated, I think maybe 20 years down the lane, if something like that happens, there is a Taluk mental health program, there is more public health service, I think that will be the most gratifying thing for all of us. Thank you very much.
Thank you, Dr. P.T. Shivakumar. You can come. As an oration, there is no questions. Yes, but one thing I'd like to highlight the things between two people on the dais. There are people who are dedicated to community service. All of us can be clinicians, researchers, publishers of papers for some reason. But here we had one gentleman, Dr. Shivakumar, who has emphasized in his career to how to take the this concept of geriatric psychiatry or management of elderly people, seeking help to them, to the community. I think that's the greatest service you have done to the society, sir. I wish Vayomanasa Sanjeevani will grow further, and that can become an all-India thing, where every state can start such program to reach the unreached through the technology. That's congratulations. You did a wonderful job. And if I have no words to say, Dr. Shivakumar is an excellent clinician, researcher, a public health advocacy, and a good human being. Thanks. You did a wonderful job today. We have Dr. C.R. Chandrasekhar with us. Probably I'll hand over to him. He has dedicated his life for community service. He runs that Samadhana, all of you know. He has not, except his body, he has dedicated everything. Body also. So, all his wealth, property, everything he has contributed to NIMHANS. And if you want the name of where he works is called Samadhana. Anyone enters that premises will be calmed down, will have satisfaction. That is what is called as Samadhan. Thank you very much. I'll hand over to Dr. CRC.
So one more In addition to Vanaprastha concept, preparing ourselves for the old age, how to live with dignity, how not to become dependent on our own children, our own people. Other thing is, now everywhere senior citizen associations are there. In every locality, every profession. Just last month, I attended Retired Postmasters Association, Retired Bank Employees Association. Almost every profession, yeah. Many of these associations, I think we have to encourage self-help groups. There are many senior citizens who are fit enough, physically fit enough, mentally fit enough, not only to take care of themselves, but to take care of others who are not mentally fit, or physically fit, or socially fit. So if we can sell this idea to all over the country, all 28 states, that senior citizens associations should be involved in geriatric care, and it should not be a vertical program, it should be an integrated program. As you suggested, geriatric care should be an integrated program with all other health programs, financial programs, and the other developmental programs. Thank you.
Thank you, sir. Now, I take the honor to welcome Dr. Srikala Bharat, retired professor, Department of Psychiatry, NIMHANS, to felicitate the chairpersons and Dr. P.T. Shivkumar, sir. Ma'am, please. Okay. So, yes, sir, please. Please put your hands together. Thank you so much, Srikala ma'am and the chairpersons. So we have come to the end of this session. We'll start the next session in another 5 minutes.
Good afternoon once again. So we'll move on to the next session. This is a session on emerging therapeutic interventions for neurocognitive disorders here at Geron conference. And before we begin the session, I would like to introduce our esteemed chairpersons for this session. We are honored to have Dr. Venkat Subramaniam Ji, Professor of Psychiatry, NIMHANS, Bengaluru. So we welcome you, sir. And we have Dr. Janvi S. Kedare, Additional Professor of Psychiatry, TNMC, Mumbai, as our chairpersons. We welcome you, ma'am. Both Dr. Venkat Subramaniam and Dr. Janvi have made significant contributions to the field of geriatric psychiatry, and their expertise will guide us through today's presentations. Our first presentation is titled New Frontiers in the Treatment of Neurocognitive Disorders, Insights about the Role of Neuromodulation.
I'll invite Dr. Kalpana Padala to the stage as well.
She was here.
Right now, I'll take the honor to introduce Dr. Kalpana Padala. Dr. Padala is a professor at the Donald Reynolds Department of Geriatrics at UAC Little Rock, USA. She has served as Associate Director of Research, Geriatric Research Education and Clinical Center, Department of Veterans Affairs. They are also the co-chair of the Research and Development Committee. She is also the board certified in family medicine and geriatric medicine as well. So shall we take the next session? We'll take the next session. Next session, people are there. Next session. It's a symposium, sir. Yeah, the PPTs are ready. We can start the next session. Okay. The 4:30 session, right, sir?
They're not there.
They don't necessarily know what happened.
Okay. So you want to start with the... No, so you want to start with the next session?
Yes.
So you want to call those chairpersons?
You can share.
Okay, we'll continue. I'll tell them and then I'll just announce, okay? Now, what is the next session you tell me?
Next session is symposium.
It's a symposium on common mental health.
We'll change it.
Okay, so there seems to be some problem, and therefore Dr. Padalas are not there with us just now. They'll come a little later. So we are planning to start with the next session, which is a symposium on common mental health disorders in elderly. May I request organizers to start it?
It is 4:30, sir. 4:30 session. 3:30 to 4:30, sir. So this is at 4:30 session. Symposium. Previous session? Okay, this is previous session. We'll start this. Okay. So the first session, Dr. Gautam.
Yeah, I got Dr. Gautam. Everybody is there. Gautam is there.
Yeah.
Please start.
Yeah. So the first session is on depression and anxiety in elderly, scenario and the future direction. Will be delivered by Dr. Gautam Shah. Dr. Gautam, a consultant neuropsychiatrist from Kolkata, is an expert in neuropsychiatry with a special focus on elderly care. Has finished his MD in psychiatry from Calcutta University and one of the best psychiatrists in Kolkata. He is also the founder and director of Clinic Brain Neuropsychiatric Institute and Research Center, a research center focusing on a neuropsychiatric discipline in Kolkata.
No problem, no problem.
Please, ma'am, please. Sure. So now we'll move to the session, Pharmacotherapeutics for Neurocognitive Disorders due to Alzheimer's disease, insight from recent controlled trials by Dr. Kalpana Padala. So I would like to introduce the speaker for the day, ma'am, please. She is Associate Director of Research, Geriatric Research Education and Clinical Center, Department of Veterans Affairs. She's also the co-chair for the Research and Development Committee there as well. She's a board certified in family medicine and geriatric medicine. Also the lead for the Tele-Dementia Clinic, Geriatric E-Consultants, Gerofit Geriatric Working Clinic as well. Her research focuses on improving gait and balance in older adults and to improve exercise adherence. She is also the PI for a 4-year VA merit-funded studies that focus on the role of executive functions on exercise adherence. Also, a co-I in the open burn pit study that focus on the health effects of wetness exposed to open burn pits, and co-I on several studies focusing on dementia as well. Her research has mostly been funded by Department of Veterans Affairs at National Institute of Health, the Alzheimer's Association, and the Department of Dementia as well. She is credited with more than 60 peer-reviewed articles and made over 90 presentations at national and international conferences as well. Ma'am, it's a privilege to have you here. Over to you, ma'am.
Thank you. Thank you for the kind introduction. Can you all hear me okay? Okay, thank you. Just a little disclosure, I do research mainly. I've been funded with the Veterans Affairs grants, NIH, some pharmaceutical research grants. During COVID, we had the Janssen vaccine study grant, and also Department of Defense. Today's objectives for the talk are looking at effectiveness of methylphenidate for apathy, as we heard in the morning. Apathy is one of the main behavioral and psychological symptoms of dementia. And looking at adverse effects when we treat with medications for apathy. Are there any side effects like insomnia? Effects of methylphenidate on other neuropsychiatric symptoms of Alzheimer's dementia, and identify any predictors that may help determine which individuals may benefit from treatment. So most of my statistics here is from US, so bear with me. So Alzheimer's dementia is again common in US there as well. 60 to 80% of the types of dementia is mainly Alzheimer's. 6.9 million Americans have Alzheimer's at this stage, who are more than 65 years or older. Here 60 and older is considered as elderly, there 65 and older is considered as elderly. And 7th leading cause of death for currently, but that's because of COVID, because initially it was 6th leading cause of death. COVID has pushed it to the 7th, and I'm sure when COVID will subside, it'll go back to the 6th leading cause of death. More than 11 million Americans provide unpaid care for the family members who have dementia, and that contributes to about $350 billion in revenue that the nation has been paying for. And also the population for 65 years and older has been increasing, as you heard in the morning. 340 billion is expected in an Indian population by 2050. In the US, it's about 82 million is what we are expecting for 2050. And also about 1 million additional direct care workers will be needed between 2020 to 2030 for newer workers that could help support for Alzheimer's Association or Alzheimer's dementia cases. So talking about neuropsychiatric symptoms of dementia, let's not focus more on the numbers here, but as you all know, apathy is one of the most commonest neuropsychiatric symptoms of dementia. Depression, delusions, hallucinations, inappropriate sexual behavior, sleep disturbance, Those are again other common symptoms that we can see with neuropsychiatric symptoms of dementia. Why target the neuropsychiatric symptoms of dementia in older adults? Because the couple of them that come to mind are depression and apathy. Depression is 2 to 5-fold. People who have depression have 2 to 5-fold higher risk of dementia and compared to those who do not have depression. So depression itself is an independent risk factor for dementia. Apathy, on the other hand, has a 7-fold increase in those who have apathy for those who have dementia. So in one of the studies which was done by Palmer et al., they found out that those with amnestic MCI, they had a 7% increase, 7-fold increase for those who had amnestic MCI and apathy compared to those with amnestic MCI and no apathy. So apathy itself is again a risk factor for dementia. So some of you might say, isn't apathy and depression kind of the same? It kind of has similar constructs, but depression is its own entity and apathy again has its own entity. There is some overlap, but apathy is defined as diminished will, diminished persistence, diminished initiation, and they have limited affective response to both positive and negative feelings. And this should be lasting at least for 4 weeks in the past to have a diagnosis of apathy. We just talked about this. This again, most commonest prevalent neuropsychiatric symptom affects about 71% of people with dementia. And why should we even care what having apathy does? And so it increases caregiver burden, as we saw in the morning study that having higher prevalence of apathy increased caregiver burden. And it also increases service utilization. It increases institutionalization and also increases mortality. Those with apathy have a 3-year higher mortality compared to those without apathy. So the people with apathy have a higher mortality and also has a higher financial burden. So there are like 3 clinical trials that have been done in apathy so far. 2 of them were initially done, which were shorter duration trials and had a smaller sample size of 60 patients. And one of the study was done by us, and I'm going to go in detail about that. So this was a double-blind, randomized, placebo-controlled trial done in patients who were community dwellers and also had mild Alzheimer's disease. So this was one of our studies done by the other Dr. Padala here, who was the lead on this study. So what did we find? So we had 156 patients that we screened, but these were again mild Alzheimer's disease patients, so we had to exclude those who had higher or lower MMSE, and then who did not have apathy, we excluded those. So in the end, we randomized about 60 participants. Half of them got methylphenidate, half of them got placebo. And these people were followed for about 12 weeks. So it's a short duration trial, followed every 4 weeks for 3 times. And we found that in the end, 30 patients were completed the study in the methylphenidate arm and 29 in the apathy in the placebo arm. And what we found was there was a statistical significant difference between those that received methylphenidate compared to those that received placebo. And the initial separation started at 4 weeks. So the methylphenidate at 4 weeks was significant enough to show a difference between the 2 arms. And then that separation kept on improving to 12 weeks. So the dose in this particular trial was 10 milligrams BID dose was given, and was given for, and the placebo control, the placebo patients did not, it was a blinded trial, and they received a medication which was, they didn't know the dose, but it was similar pills, and so we were also blinded to the study. In this particular study, because they were mild Alzheimer's patients, there was significant improvement not only in apathy, but also in cognition. We found improvement in their mini-mental state exam. We did find improvement in their caregiver burden. We also found improvement in functional status between the 2 groups. So this was very promising study to begin with. There was another similar study done by Canadian group, which was again a 12-week duration study. So combining this study and the other study, we came up with a larger study, and we put forces. Hello. Hello. Yeah, sure. Thank you. So these two groups came together to do the larger trial, and this was called the ADMET2 study. This was a multi-center study. 10 sites participated in this study. It was again a double-blind, placebo-controlled trial. It was a phase 3 study, and the duration of the study here was 6 months. So instead of 12-week study, we wanted to see what happens if we include more patients in the study, and if the duration of the study was longer. So that was the main thing. The participants were enrolled for this study from May 2016 to December 2019. So we just completed the enrollment before the COVID hit, but then patients were still participating because it was a 6-month duration of the study. So they were still participating while the COVID was going on. And we are proud to tell that out of the 200 patients that we included in the study, 40 patients were from our site. So the main objective of the study was to see the clinical efficacy of methylphenidate for apathy, and again to see that with a larger, longer trial and with more robust measures. So this was published in the JAMA Neurology, and we included participants with possible or probable AD, and then mini-mental score for these participants was 10 to 28. They had clinically significant apathy on the NPI measure, with very frequently or frequently often with severity of moderate or marked apathy. And they needed to have caregivers because caregivers very well assessed, were asked questions about the patients themselves. Those that had major depression were excluded. Those that had severe agitation, aggression were excluded. Those that had stable medications for AD were included. So if they had any change in their medications for Alzheimer's, for AD were excluded from the trial. And also change in the use of antidepressants, except for trazodone or lorazepam that were used for helping with insomnia. All other antidepressants, if they had any change, then they were excluded from the study. And also benzos, if they had any change within the last 30 days, they were excluded. And if they had taken methylphenidate in the past, they were excluded. And if they had any drug-drug interaction, or if methylphenidate was not safe to use, they were excluded. Or if they had unintentional weight loss in the last 3 months, then they were excluded. So methylphenidate, as you all know, is a mild CNS stimulant. It blocks the reuptake of norepinephrine and dopamine into presynaptic neurons, and also stimulates the cerebral cortex and subcortical structures, which is similar to amphetamines. And it's a class 2 drug there in US, and so we have to write paper prescriptions every time we give the methylphenidate to patients, even now. And we can only give prescription for 30 days, so every 30 days they have to renew the prescriptions and come in person for that. It is FDA approved for ADHD and narcolepsy at this point, and has some off-label use, as you can see, for fatigue and severe cancer or palliative care settings. We use them. Dosing, it's available in intermediate acting dose and short acting immediate release dose. And we have to give it before meal, and then the second dose you want to make sure you don't give it too late at night, so then they can't sleep because of that. And the main contraindications for the medications are hypersensitivity. You can't give it when they have MAO inhibitor therapy simultaneously, and other drug-drug interactions, and so on and so forth. So for our particular study, what we did was methylphenidate was immediate release medication. It was randomized in 1:1 ratio in permitted health length block. And since we had 10 sites, each site had its own stratified randomization for each site. The pills that were given were 5 milligram dosage pills, and the placebo was, if we gave 3. Here the dose was 1 capsule twice a day, was given 3 days. In the initial study, when we did our study, The dose was increased only after 2 weeks, and so from that we had learned that it is safe to use in elderly population, and hence we were able to increase the dose to in 3 days in this particular study. And then followed by 2 capsules twice a day, so 20 milligram dosage was given, and we gave the same to the placebo. So it was given 2 capsules twice a day, even for placebo. And if they had any adverse event related to the medications, we kind of backed off on the medication. And the other different thing that the ADMET-2 study did was it provided standardized psychosocial intervention for the study. And this was given for about 30-minute counseling session at each visit. And we also provided educational material, and also we were available if they had any crisis management for the patients. Sorry. Okay. So this study had most of the visits were in person, like screening visit, baseline visit, and then all follow-up visits were monthly and for the first 6 months. Telephone visits are also incorporated in between just to make sure there are no adverse events going on with the patients. And once the COVID hit, some of the visits were converted into virtual visit or telephone visits. The main outcome measure that we used here was the neuropsychiatric inventory for apathy score was one of the main thing. We also looked at the dementia apathy interview rating scale, and then we did the ADCS CGIC was another change that we were looking at for apathy. For cognition, we looked at a mini mental state exam, Hopkins verbal learning scale. There are multiple things that we did, but cognition was mainly assessed only at 2, 4, and 6 months. We didn't do it every single time. Function was assessed with every visit, mainly the ADCS activities of daily living scale. Then we did the dependence scale, quality of life index, and resource utilization also was assessed. So in this particular study for the ADMET-2, we had 200 patients that participated that were finally randomized. 307 were actually screened and for various reasons excluded from the study. So out of the 200 randomized, 99 were assigned to the methylphenidate arm, 101 was assigned to the placebo arm. And every month they were followed and had visits. In the end, at 6 months, we had 89 that completed the 6-month visit and 92 that completed the visit for the placebo arm. So the characteristics, they were elderly, 76 mean age, 34% were women and 66 were men, probably more related to the population that we enrolled. We are situated at the Veterans Affairs Hospital, which serves mainly men in that age group. Again, mainly Caucasians. Most of them were married, 86%. Most of them had like good education. Like you can see, 20% had a high school education, 20% had college degree. Coming to the last point here, let's skip to the next page. Hypertension, diabetes, 59% had hypertension, 16% had diabetes of the population. And you can see in current medications, 38% were on memantine, 73% were cholinesterase inhibitors. So we had not excluded any of those that were on the dementia medications. They just had to be on stable dose of the medications, and they were still allowed to participate in the study. And they also were, 36% were on SSRIs and 7% was on SNRIs. The total neuropsychiatric inventory apathies, total score was 16.4, and you can see the apathy subscale was 7.8. And early in the day, we heard that any score of 4 or greater is significant apathy, so these patients had significant apathy. Mini mental score here was 18.8, which is pretty high. For mean score, it's pretty higher rate of dementia. So what did we find? So the NPI apathy score did significantly improve between the two arms, the methylphenidate arm and the placebo arm. There was 1.3 point increase in the methylphenidate arm compared to the placebo arm with a p-value of 0.002. And in the right side graph, you can see that at 3-month interval, there was a big separation between the placebo group and the methylphenidate group. So the most impact was seen at 3 months. And those were the 2 previous studies which are noted, which ended at 12 months, 12 weeks, I mean. And that's where that most treatment effect was seen at 12 weeks. Then we also looked at the CGIC, and the initial cut, when we looked at CGIC, there was odds of improvement of 1.9 with a p-value of 0.07. So what we did was we adjusted with the longitudinal model, and then we found that it was statistically significant after adjusting for the longitudinal model, so at a p-value of 0.08. We also found that for the first 100 days, the methylphenidate group had more than 2 times increase in remitted compared with the placebo group, with a hazard ratio of 2.2 and the p-value of 0.01. So then we went on and looked at what happened with the other measures that we were collecting aggressively. We found that there was no difference in the cognitive measures. So all the cognitive measures between the 2 groups, there was no difference. It did not improve in either arms. There was no statistical significant difference for the activities of daily living. There was no difference for the dependent scale, no difference for Euroqual. I think the main reason for this was because the previous studies were mild AD patients. This study did not have mild AD patients. These were all comers. So what are the adverse effects that we see in the elderly population with use of methylphenidate? So that was the other objective. So this study, again, rigorously checked for how much medication was used, how much patients took the medications. They had a retention rate for the study itself by 90.5%, and they looked at the adherence of the pill count, and they saw that methylphenidate, 78% were adherent to their medications, and in placebo group, 88% were adherent. So that was the adherence rate. And then for the adverse events, they found that there were no deaths in both arms. There were serious adverse events, 17% in the methylphenidate arm and 12% in the placebo arm. However, these were all unrelated to the study drug. So that was inspiring, actually. So these are all the adverse events listed. I will keep going. Weight loss was not affected by the baseline BMI for the patients. So that was another finding. And the methylphenidate arm did lose about 1.28 pounds in 6 months, compared to the placebo group gained 1.53 pounds. So there was a difference of 2.8 pounds between the 2 groups, and it was statistically significant. However, when you consider 100 patients getting methylphenidate and losing about 1.28 pounds, it's not much. It's like half a pound or a little more than that. Then they also looked at what happened with the systolic blood pressure, diastolic blood pressure, and pulse. And the mean difference between the 2 arms was not that much. And there was the mean change between the 2 groups was -0.4 for systolic and 0.22 for diastolic. Again, they looked at other outcomes, whether there was increased in hallucination, delusions, or agitation related to use of methylphenidate, and they did not find that. There was no significant differences in falls. There was no significant differences in insomnia. And also they looked at cardiac events, and 1 person had new onset atrial fibrillation in the methylphenidate group. Other than that, they did not find any difference in the cardiac outcomes either. Then they went on to look at if methylphenidate had any other changes to the other neuropsychiatric symptoms of dementia. And what they looked at was the 12 domains, and as we had heard in the morning, the NPI has frequency and severity that we look at, and then they found that there was no clinically meaningful improvement in any of the NPI domains other than apathy. So methylphenidate specifically is an intervention for apathy. And then the last objective of the study was to see what are the predictors that may help determine which individuals may particularly benefit from the treatment. So who is it that is getting benefit from the treatment? So they looked at 22 planned potential treatment predictors. They looked at demographics like age, gender and education, the blood pressures, the concomitant medication use, baseline apathy severity, NPS at baseline like agitation, anxiety, depression, and disinhibition, all the other neuropsychiatric symptoms. Total NPI score, they looked at baseline cognition and also baseline function. They looked at all these models. And in this particular analysis, they used 177 participants instead of 200 because they had missing data on some of these NPI parameters or other parameters that they were looking at. So they had to use 177 participants. And then in this, 89 were randomized and to the placebo group and 88 to the methylphenidate group. And then they looked at both the groups, and then they found that demographics and the baseline characteristics for these two groups are similar. And majority of participants were male, they were highly educated, displayed moderate levels of apathy, and were receiving cognitive enhancing medications. And NPI scores on agitation and depressive symptoms were relatively low, and no clinically meaningful improvement was observed in any NPI domain other than apathy again. And the 6 predictors that they thought they could tease out were the response of methylphenidate between the two arms differed on these following things. One is if they were younger, they responded better. If they did not have any baseline anxiety or agitation, they responded better. If they were prescribed and were on cholinesterase inhibitors, methylphenidate, there was a separation between the two arms. Having an optimal diastolic blood pressure and having more functional impairment. So if they were more impaired, then they saw a difference. So limitations, as you all know, it was a convenience sample done in academics, and so most of the participants were Caucasians. So we can't generalize it to all population. And you also can't generalize it to non-AD forms of dementia. Biomarker confirmation was not obtained for the AD diagnosis in the beginning, so that was another limitation. Again, the treatment was limited to 6 months, so we don't know what happens after that. And then again, there were a lot of patients that declined to participate or who failed the screening. We never followed those patients, so we don't know. We don't have data on those potential participants that could benefit from the study. So we kind of conclude that apathy is prevalent and clinically significant neuropsychiatric symptom of AD. And methylphenidate does have a modest improvement in those with apathy in AD, and then can help both patients and caregivers. And efficacy is relatively early in onset, like we see it at 12 weeks, and if its effects are sustainable for up to 6 months. And it's safe to use in older adults, does have a little bit of weight loss that we saw in our study, and then also otherwise was pretty safe. We didn't have any effect on the vital signs, didn't have any cardiovascular events, did not have any issues with insomnia, falls, or psychosis. So that was our team that participated, and I'll kind of stop here.
Thank you, Dr. Kalpana. Psychobehavioral symptoms of dementia are always puzzling to us, and apathy definitely. And considering the high occurrence of apathy in dementia, I think, yes, methylphenidate seems to be a promising treatment. Should we take questions for both the speakers in the end? I think that will be better. Why don't you?
Sure.
I invite Dr. Prasad Padala. Over to you.
Sorry for the delay. I'll try to make up some of the time, and I'll also try to make it interactive, interesting to some extent.
Padala, hello. Yeah, we will have a brief introduction of viewers. Yeah. Can we have the introductory slide summarizing? Yeah, can we put it in? Yes, yeah, thank you. So we welcome Dr. Prasad Padala, who's a professor of psychiatry and geriatrics in University of Arkansas, and he has several activities to his credit, being a program director of Baptist Health UAMS Psychiatry Residency Program, Associate Director for Clinical Innovation. So I think we need a lot of innovative thoughts and approaching the challenges in several components of psychiatry, more so in geriatric psychiatry. And he directs a multidisciplinary memory clinic, and his research interests include management of the behavioral and psychiatric symptoms of Alzheimer's dementia using both pharmacological and non-pharmacological treatments. And he has got several funded grants and from very reputed funding agencies, and his research work has been published widely and has contributed to several textbook chapters. So, yes, sir.
Thank you very much. All right, let's jump into it. All right. Okay, so we'll now switch from medications to non-pharmacological agents. So we'll focus on neuromodulation. Thank you for this opportunity. I do want to take a quick second to say that Dr. Sivakumar is a great ambassador for geriatric psychiatry in India. When he was in Atlanta for the AAGP meeting, he was networking with everybody, and he was really representing India quite well in the conference. Thank you for the invitation. As Kalpana pointed out, the methylphenidate is quite effective for treatment of apathy. Unfortunately, it's not for everybody. And she also pointed out that not everybody responds. So there are other treatments that are important. So non-pharmacological interventions are urgently needed, and RTMS, the repetitive transcranial magnetic stimulation, or TDCS, are quite attractive tools for this. Just a little history. So 1791, Galvani demonstrates artificial stimulation of frog sciatic nerve, and it all started there. In early 1900s, there are a lot of experiments with magnetic fields. You'll see different magnetic fields and different devices being used. In 1981, there was a first demonstration of peripheral nerve stimulation. And in 1985, they get the motor evoked potential. And there was a seminal paper by Sheffield team. And the motor evoked potential was by stimulating the motor cortex. So we knew that the brain can be stimulated and the muscles can respond to that reliably. So this is essentially how the RTMS works. So the electric current flows in a wire, and this generates a magnetic field around it. And if the magnetic field is variable, then another field, an electric field, is surrounding that. And this can then stimulate some tissue of interest. And in our case, it's the brain that we want to stimulate. So this enables the nerves right below that area to be stimulated. And when I say stimulated, I'm only talking about high frequency. There are more nuances to that. Different coils induce different shaped magnet fields. Like the single circular one, the more is near the wiring. In the center, there is no magnetic field, whereas the H shape is more reliable. Most people use the H shape. Dr. Prasad Rao uses actually a brains wave, which is a deep RTMS, which uses 3 different magnets that rotate in a plane. All right. RTMS can also be used as a diagnostic tool. If you do a paired pulse testing, you can look at the latency and look at the cortical integrity. It's FDA approved for major depressive disorder, but it's being used for anxiety, OCD, and other neuropsychiatric symptoms as well. So what are some of the contraindications? Epilepsy is a contraindication. There is a risk of increased seizures during the first treatment. I'll talk about that in a little bit. So you don't want to give to people with a history of epilepsy. Got to be cautious with drugs that lower seizure threshold, tricyclic antidepressants and others, and heavy consumption of alcohol, pregnancy in the treater, and increased intracranial pressure for whatever reasons. Any implanted devices, you got to be careful. The closer to the head and neck, the more of a problem. Cardiac pacemakers are contraindicated. And we use something called a TMS Adult Safety Scale, TAS, to screen out people that are high risk for these side effects. So when you do RTMS, there are two steps, the motor strip location, and then you go on the homunculus and try to find where the thumb is represented. This is the typical positioning where you look at nascent to inian and the preauricular, find the vertex, and go through the C3 position, and then you go to the CZ position by the EEG method, and that's where you start the stimulation or try to find the thumb. You start there. But these days, there are easier ways. There are caps available. You can slap on the clap, and then you can get the CZ very easily. And the most commonly used placement now is beam F3 method. So I'm interested in a golf ball size stimulation area. Most of us are interested in the dorsolateral prefrontal cortex, particularly on the left side for depression treatment, and that's where we are targeting apathy as well. I'll tell you why. The reasons why we like this is it's non-invasive. We don't need anesthesia. There is no memory problems with this, and can be used both for inhibition and stimulation. We'll talk about that, and has been used in wide variety of neuropsychiatric conditions. So low frequencies can reduce the cortical excitability. It can be used in patients with schizophrenia. One of my colleagues is looking at using this in the temporoparietal cortex to reduce auditory hallucinations in patients with schizophrenia. High frequency, anything greater than 1 hertz, typically 5 and 10 hertz are used, facilitates excitability. This also increases synaptic plasticity, and that's why there is some durability after the stimulation. We talk about 90 minutes after stimulation where the brain is primed. We have now studies we are looking at psychotherapy after RTMS in that 90-minute period to see if people take away more from CBT and other psychotherapy sessions. We also have a study where we're using immersive virtual reality during that golden period. There is also long-term potentiation or long-term depression, which account for the treatment of depression with multiple sessions of this. High-frequency RTMS can also modulate the NMDA receptors, and that's probably where we get some memory enhancement with this. This is also known to release dopamine, acetylcholine, norepinephrine, and serotonin, and increased blood flow could also be accounting for some of this. This is my schematic for my NIH grant that I submitted, got funded for this, and basically depicting what we talked about, increasing dopamine, increased cerebral blood flow. We are measuring BDNF after stimulation. Just a nutshell about what's happening with memory. Right DLPFC has been stimulated by a few people, finding improvement in recognition memory. In one study, people used 5 hertz RTMS in the right DLPFC, and they found improved learning of face name associations. Left parietal cortex has also been targeted. So recent meta-analysis basically says high frequency RTMS over left DLPFC, 10 to 15 sessions, is the most information we have about memory enhancement with RTMS. Okay. What are some of the caveats in RTMS treatment? Placing the sham coil has always been a problem. Earlier, people used to just turn the coil away from the head, then the patient would know what's happening. We have the NeuroStar Explore, which uses a very similar looking coil, and it uses an acoustic router so that the sound actually comes from a different source, so the patients cannot make out what's going on. In our studies, we use a sham validation by asking the patient about what they got, asking the raters what the patient is getting, and we found that it's quite reliable, the sham validity. All right. Neurostar is quite safe. I'll skip this data for time. Okay, why treat apathy? As Kalpana pointed out, it's the most common neuropsychiatric symptom associated with functional decline, caregiver burden, and perhaps hastens neurodegeneration. And although there are some positive results with Ritalin, it may not be for everybody. So this is a good option. Why focus the orbitofrontal cortex or the left dorsolateral prefrontal cortex? In apathy research, everything points to the frontal lobe. When we looked at the diffusion tensor imaging, there were some microstructural disruption found in the anterior cingulate. There is also smaller volume of the anterior cingulate. Apathetic patients typically have executive dysfunction, and treating apathy improves executive dysfunction. So perhaps frontal lobe is where you need to target. So we started there. So what are we doing in our lab? We have 3 studies. We took a amnestic MCI patients, and we did a crossover trial for apathy. We took 20 patients in Alzheimer's, early Alzheimer's, and a parallel arm. And we have a larger study that we just completed. I don't have results of that. It's the 4-year study, 125 patients in amnestic MCI with a goal of delaying the onset of dementia or postponing onset of dementia overall. Okay, this was the first study. This was the MCI study that was published in Psychiatry Research. And here we took patients over 55, took patients that met the MCI criteria with Peterson criteria. So essentially, subjective cognitive decline. Objectively, they score 1.5 standard deviation less than the norms, and they don't have functional decline. And we took patients with apathy evaluation scale greater than 30 and mini-mental greater than 23, and all of them passed the TAS adult safety screen that we talked about, and they were on stable dose of antidepressants. Apathy evaluation scale is a rating scale of 18 items where the caregiver usually rates the patient's initiative, persistence, and motivation. It goes from 18 to 72. Any score greater than 30 is considered as clinically significant apathy. In our patients, we had a mean age of 66. And after adjusting for baseline, active treatment was better in treating, improving apathy than the sham. And the bolded line is the active coil, and the dotted line is the sham coil. In our study, we found that every time we gave the active coil they received in the crossover style design, they improved in the apathy score, whereas the sham coil, some people deteriorated in apathy. We also found improvement in cognition using a rating scale called modified mini-mental. It's a 100-point scale, much better for subtle memory problems. We followed this with a 20-patient early Alzheimer's study in apathy. It was a double-blind sham-controlled arm, 2 parallel arms, all community-dwelling patients. And the reason why we are so particular about taking community-dwelling patients is the impact of apathy on caregivers can differ based on the setting, as we learned this morning. All right, everybody received 5 days of treatment per week, 4 weeks, so 20 treatments. And treatment was pretty standard dementia depression protocol, 10 hertz, 120% motor threshold, 3,000 pulses per treatment. And there were protocols to reduce the magnet strength if there were problems. So here we lost 1 patient of the 20, and we used an intent to treat analysis. And essentially jumping to the treatment. At baseline, the patients did not differ much except on exit 25, which is a bedside test for executive function. All right. So there was a significant between group differences in apathy evaluation scale. favoring the RTMS, the active coil over the sham treatment. And there was mean improvement of apathy score in the active coil was 10.1 points, which is a clinically meaningful improvement. Typically, a change of 4 points on apathy evaluation scale is seen as a clinically meaningful improvement. There was also significant improvement in 3MS, favoring the RTMS arm. And there was a significant between-group improvement in the IADL, instrumental activities of daily living. So we got enough signal to go to NIH for the bigger grant, and that's what we just completed. In either of these studies, we had no seizures. Only one subject dropped out of this study due to inability to tolerate the treatment. But interestingly enough, that patient was actually on the sham arm. And most adverse events were transient and resolved completely. The most common side effect were the application site discomfort. There was some facial twitching, but we were able to adjust the coil and went away. All right. There was a meta-analysis recently done for apathy in RTMS. They included 4 RCTs, 89 patients were involved, and there were significant improvement in apathy with the high-frequency RTMS. There was also global cognition improvement, so we will see if that pans out in my study. That study, we are taking 125 patients. We completed the recruitment. We have about 5 patients waiting to finish the study, and 50 got the sham-controlled RTMS treatment. We are also using a single session as a marker for response. So what we have done in the study is everybody gets a single session. And after single session, we are giving a 2-week break and bringing them back. And we want to see the difference in executive function after the single session. And we want to see if that difference can predict the 20 sessions change. So we are using that as a biomarker. We have followed these patients up to 4 years. The mean follow-up was about 2.1 years in the study to see the conversion to Alzheimer's. So this was the study design. Not everybody gets the RTMS treatment, but 50 patients get that. Others are followed for natural course observation. All right. In conclusion, urgent interventions, non-pharmacological interventions are needed to improve outcomes of apathy in Alzheimer's. RTMS is an attractive tool which has the potential to improve not only apathy, but also executive function, global cognition, memory, and motivation. All right. We'll stop there, but I do want to take a perspective of a caregiver of one of my patients. I don't know if this patient got the real treatment or sham treatment, but this was a 73-year-old veteran with multiple comorbidities, presenting with forgetfulness, repetitiousness, losing track of gardening tools, etc. Apathy score of 49, so pretty significant apathy. Zarit burden score of 42, so the patient's caregivers were quite burdened. He had lack of initiative, watching TV all day, not interested in going out with his friends. It used to be his routine thing to do, but he is not doing that anymore. He tolerated the single session well and completed the 20 treatments. And during that time, he brought a book to read. He's gone back to reading, started gardening again, doing more chores at home. So his wife is very happy with us, and more active in the 2 weeks prior to the 20 treatments. So this patient, at least initially, he's improving. We'll see if we receive the real one or not. After single session, the caregiver burden improved significantly from 42 to 31. But when we saw them back at the end of the 20 sessions, he back to 39. I don't know if he got the placebo. But there are some changes in caregiver burden, and that's what really motivates us to go back and start using this modality. I'll stop there, take any questions.
Thank you, Dr. Padala. Well, I think We can, no? Maybe we can take 2-3 questions and people can share their own experiences also. Yes, Dr. G. Prasad Rao.
Catch it. What was the placebo response in that trial, in both the trials?
So there was a difference of 1.3 points in the NPI score. So the placebo arm, did show a difference. Yeah.
The regarding the RTMS part, how regularly you give? You give it for 20 days consecutively after the initial thing? Because in India, I think a lot of centers, we do the hybrid model. What we do is within a 9 days, with a break of maybe Sunday, we do it 2 sessions per day with a gap of 4 hours. And we do the, as I told you, brain swave kind of a thing, deep RTMS.
Oh, very good question. For the research protocol, we had written 5 days a week for 4 weeks, but we now have the SAINT protocol, the Stanford Accelerated Protocol, where we are using, clinically, we are using theta burst, 3 to 4 minute stimulation over the 37 minutes with the traditional way, and we are using 5 treatments per day. And we are trying to condense the treatments course into 5 days, 1 week. But for this research protocol, it's pretty strict. So we are doing the traditional way. But I really like the way you're doing it.
Thank you so much for excellent presentation. And I'm talking about the RTMS itself. As sir said, there are different protocols. I used to give it in 5 days a week. But one presentation, I asked one of the presenter from abroad, must be from France, I think. So I asked, why you give it 5 days a week? He just replied me, because doctors need 2 days holidays for his own. So it can be given, I think, at a stage 20 also. But yes, you are right, in theta burst, daily you can reduce the dates of the total dates of the RTMS. My question is, what about the maintenance therapy? Because lots of patients need maintenance RTMS, because their relapse is very common after few months or thing. And if they are in maintenance therapy, like ECT, we used to give once in a month, and initially RTMS thrice in a week or twice in a week, and once in a month if I continue, then result is very good. Is there any study like this?
I'm not aware of any maintenance treatment studies in apathy, but in depression there are some maintenance treatment, but there is a lot of ambiguity in that. So going back to your previous question about why 5 days a week, so in US, this was popularized by a person, Alvaro Pascual-Leon. So he actually brought this at NIH, and he did a 5 days because there is a 2-day weekend. So you're absolutely right. But there is a lot of ambiguity about the maintenance treatment.
That was, I think both the presentations were quite excellent and very, very clinically relevant. I just wanted to know, apart from methylphenidate, is there anything else which has been used? For example, modafinil, and so is that also, has gone through any RCT? Because we use it clinically quite because it's easier to use modafinil rather than use methylphenidate in a clinical population, especially a rural population.
Absolutely. We had published a case report about modafinil. We had actually applied for a investigator-initiated grant. We did not get that, so we didn't do that study. I'm not aware of a RCT for modafinil, but there was a RCT for bupropion, Wellbutrin, because it has a dopamine component and seemed to be quite effective. There is an ongoing study looking at Wellbutrin. Currently, there is a RCT going on. Another.
Madam, what is the minimum dose of methylphenidate and maximum dose you have used? And with minimum dose, they have improved?
Oh, very good question. So when we started this line of treatment, we started with the case report, a case series, an open label trial, a RCT, and then this definitive study. In all of this, we had started with 5 milligrams twice a day, and then bumped it up to 10 milligrams twice a day. There is another unpublished study that we had done in patients with MCI and diabetes with apathy. In that study, we used 20 milligrams twice a day. So the maximum we have used is 40 milligrams per day. We have cases that we have continued for the treatment for up to 3 years, not research, but clinically, and we have found continued improvement in apathy with the treatment.
I think one last question Saqib has been wanted to ask.
So the ADMET-2 study was the longest study that we did with methylphenidate for 6 months. And that was not the initial outcome we were looking for, but we went back and looked at what other things did it affect, like other domains of neuropsychiatric symptoms. And we found that there was no improvement or no worsening of the symptoms that you mentioned, no agitation or anxiety that got worsened related to use of methylphenidate, either in the methylphenidate arm or the placebo arm. So there was no clinically meaningful difference in both arms. You may have more information.
I just wanted to underline something there. So Kalpana is talking about a randomized control trial which was carefully crafted and selected patients very carefully. You may remember that we excluded anybody that had clinically significant agitation in that study. Clinically, when we are treating patients with apathy in our clinic, we do see methylphenidate inducing more agitation and anxiety. In fact, in one of the slides, Kalpana had mentioned that the Canadian site has a contraindication for Ritalin use or methylphenidate use in patients with moderate anxiety. So we do see that routinely.
Thank you both of you. I think we will end the session here. That was really an interesting discussion also, a very interactive session. Clinical issues that we need to deal with in our everyday practice, and what all innovative methods we can use, and good sharing of experiences by the audience also. Thank you. I thank the organizers for giving both of us an opportunity to chair the session. Thank you.
Thank you, ma'am. Thank you so much. Now, I would like to invite Dr. T. Murali, Professor in Psychiatry, Oxford Medical College, and former Professor in Psychiatric Rehabilitation, NIMHANS, to felicitate the chairpersons. Sir, please. Please give a big round of applause. Thank you. Thank you so much. Now, I would like to invite Dr. Matthew Varghese, former Professor of Psychiatry in NIMHANS, to felicitate the speakers. Yeah, sir, please. Give a big round of applause. Thank you so much. Thank you, sir. We have come to the end of the session. Now we will disperse for a tea break. It will be for 15 minutes. And after that, we will be having parallel session, one in Hall B, where this is here, and one in Hall C as well. So please come back after 15 minutes of tea break. Thank you. Good evening, everyone. Please be seated. We will resume our next session. Once again, good evening and welcome to the Symposium on Common Mental Health Problems in the Elderly. Thank you for all joining for us in this important discussion where we will explore some of the most pressing mental health issues affecting the elderly population today. Before that, let me invite the chairpersons for the symposium to the dais. Dr. T. Murali, Professor of Psychiatry from Oxford Medical College, Bangalore, and former Professor of Psychiatric Rehabilitation, NIMHANS. He is an immediate past president of World Association of Psychosocial Rehabilitation and immediate past president in IPSKC, currently the chair of Scientific Committee, World Congress, WAPR. Next, we have Dr. Abdul Majid, professor and head of the Department of Psychiatry, SKIMS, Srinagar, India. He is a past president of IPS North Zone and General Secretary of Indian Association of Biological Psychiatry. We are privileged to have you both here on the dais, sir. Now, we'll move to the first session, Depression and Anxiety in Elderly, Scenario and Future Direction. And I would request Dr. Murali to give an introduction to Gautam.
The permission of my co-chair, I just want to say thank you very much for requesting me to chair this session. It's an honor to be associated with this wonderful conference. So, the first speaker We have 1 hour session, and our first speaker on common mental disorders is Dr. Gautam Saha, who actually do not require any introduction to the psychiatric crowd, but the other people know, because he has been very active with the Indian Psychiatric Society and various other associations, and with geriatric psychiatry. He is a director at the Clinical Brain Neuropsychiatric Institute and Research Center, Barasat in Kolkata. He was the immediate past president of Indian Association for Geriatric Mental Health. He is honorary member of World Psychiatric Association, and he was the immediate past president of SARC Psychiatric Federation, and he was past president of Indian Psychiatric Society. He is a distinguished fellow of the American Psychiatric Association. He is also the honorary member of Psychiatric Association of Nepal. Publications, published 43 research papers and reputed national. He is the author of 4 books. He has presented at numerous national and international conferences. Actually, he is a very, very busy person, as you know, and is a good friend of mine.
Thank you, sir.
For that, okay. So I may request Dr. Gautam Saha to deliver his lecture on common mental disorders. He's talking on depression. Yeah, right.
Thank you, Dr. Murli, for kind introduction, and Dr. Majid. Now my job is to talk on treatment of depression in elderly. You know that it is, first of thing, what is our aim overall whenever we are treating in this geriatric population? The John Kennedy is one of the nicest quotes. It is not enough for a great nation merely to have added new years to the life. Our objective must also be added a new life to those years. So it is a quality of life. We are thinking of so early diagnosis, treatment, and giving a quality life to this population is our target. You know that 2/3 of all people in the history of the world who have reached age 65 are alive today. And half of women who are 65 today will survive up to the age of 85. And 1980 to 1990 population over 85 increased by 40%, and centurions doubled. Average lifespan is now today overall, especially in the developed country, 75. In India, it is 69 plus. Considering the India, it is the second largest elderly population in the world. 80% lived in the rural area, 40% are below the poverty line, and over 73% are illiterate. You can find out the causes. About 90% of the old people have no official social security without PF, gratuity, and pension, etc. So healthy functioning older adults are at no greater risk for depression than the younger adult. And what are the risk factors? Mainly the multiple losses. There are lots of comorbidity, medical illnesses, and definitely with the age, the cognitive dysfunction. But the greatest risk for the depression in elderly is the history of previous depression. If they have a history of previous depression in a younger life, so they have a more chance to develop depression in the older life. You know that jobs, money, homes, friends, their abilities also decreased, health issues are there, hopes are also diminished, and the bereavement is more associated with these geriatric populations. If you consider the medications, if anybody takes anabolic steroid, antiarrhythmic medication, anticonvulsant medication, barbiturate, benzodiazepines if some have abused, or for medical purpose, carbidopa, levodopa, because you know that Parkinsonism also very common in this age group, and certain beta blocker also may cause depression in this age. And if you see the prevalence of depression with the medical illness, it is almost 1/4 to 60% in stroke, 80 to 40% cancer, and in myocardial infarction it is associated with 15 to 19%, in rheumatoid arthritis 13%, Parkinson's disease it is around 1/4 patients, and also in diabetes is very common, 5 to 11%. Whenever you see that the vice versa, that depression is also associated with some medical problem like circulatory, digestive, endocrine, and other also, genitourinary also common. So what are the secondary causes of depression in the elderly? You know that, as we discussed before also, Alzheimer's disease, very difficult to treat, I'll come later on. It may be the vascular or other dementia, sometimes associated with any infection like chest infection, pneumonia, or urinary tract infection, may be associated with substance abuse, and there are lots of cases if it is hypothyroidism or other endocrine disorders. There are lots of elderly patients are associated with electrolyte imbalance, especially who have the cerebral degeneration, and maybe some tumor or endocrine or medication induced, I already discussed. What are the laboratory tests? It is not directly diagnosis the depression, but the comorbidity is enumerates all the laboratory tests, which includes regular, from starting from the routine test to liver function test, kidney function test, to different drug levels, endocrinological, especially the thyroid and other. ECG is important not only for associated illness, but also whenever we prescribe drug, it is important whether there is any contraindication or not. And very oftenly it is associated with folic acid deficiency and other vitamin B12 and other deficiency. You know that the most important point is when depression occurred in a case of dementia. You know, it is 20 to 40% Alzheimer's cases, there is a history of, you can get a depression. And it is very difficult to treat. Initially, the diagnosis is very difficult, and sometimes it is very refractory to treatment, not responding usually with the usual antidepressant medications. Similar rates with other dementia like vascular Parkinson's, even in the Huntington choreas, if there is a brain injury in this age group, and as I mentioned before also, vitamin B12 deficiency. And sometimes initial presentation is depressive symptoms only. Whenever it's not responding to medications, clinically we are not satisfied with the medication, then we go for the other neuroimaging or other things, other investigation, and ultimately we landed a diagnosis of depression with dementia. So having mental disorder in left light increases mortality by 1.6 to 2.5 times. So diagnosis is important as well as the treatment. You know that as other myocardial infarction are 4.5 times greater in the patient with history of major depressions. So we should be careful, because in the younger age depression diagnosis, I think a bit easier than the older patients. Because what happened, especially in the family members, oh, इस उम्र में तो ऐसा होता ही है. You should not be like this. At least you should be careful. It may be an illness which can be treated and patient may be better. Suicide is also very common. 15% of severely depressed person commit suicide. Elderly white males are at greater risk. 80% consult physician in a month before the death, before committing suicide. So role of general physician is very important. And elderly are less likely to have had a previous attempt or to complain of suicidal thoughts, more likely to complete it. So in the younger generation, and if you see the suicide rate is most common in 15 to 39 years. younger generation, but in elderly people also, if they have a depression, suicidal rate is very high. So what is late life depression? We all know about what is depression according to diagnostic criteria. If it may be the ICD-11 or DSM-5, whatever it may be. But late life depression is a recurrence of depressive symptom and initially occur during the early adulthood. There is no known identifiable precipitating factor most of the cases, and patients usually have no family history of depression, and depressed mood is not required to meet the criteria for major depressive disorder. So, diagnosis of depression in elderly often missed. And the medical illnesses may be the same as depression. Sometimes patient only complaining of low energy, loss of interest, anorexia, fatigue. I told before also, we take it maybe all the symptoms of the old age. But don't take it so easy. Take care of our older people, because sometimes you can miss very big thing. Study of Duke University, assessment given elderly medical admits, of those meeting criteria of depression, only 40.5% received an antidepressants. It is in Duke University, not in any Indian university. If it is in India, maybe its percentage is much, much, much higher. What is the most commonly used and validated screening tools for the diagnosis of depression in an elderly patient? Sometimes in our busy clinical practice, we cannot use scales, but for the research purpose. And sometimes we can also, if you are interested, we can use these scales because it will definitely help. Most commonly the geriatric depression scales. I am not going into detail. Other is coronal scale for the depression and dementia. Center for Epidemiological Studies of Depression Scale, Patient Health Questionnaires, and the AMDA Clinical Practice Guideline. I am not going into detail, but another terminology is very important related to depression in elderly people, pseudo-dementia. You know that pseudo-dementia, sometimes they presented absolutely, they mimic the symptoms of dementia. Memory disturbance, forgetfulness. Basically, this is not a dementia, this is a part of the depression. It is very common in the elderly patients, and cognitive problem related to depression, not due to dementia, neurodegenerative changes of the brain. Higher incidence of development of dementia though, and there is a history of mood disorder sometimes, and depressive symptoms precede the cognitive symptoms. That is one of the differentiation. And acute onset generally, which is not common in dementia. Dementia is an insidious onset, and increase in dependency. Slow psychomotor response, slow motivation, social interaction, and improve with antidepressants always. But if it is with dementia, I told it is very difficult to respond with antidepressant, so you have to take care. And the better to risk overdiagnosis and treat for the depression, and use clinical judgment based on patient history and function. So, whenever you consider for treating a patient with depression, first you should consider what are the comorbid patients have. The comorbid conditions and etiology of the secondary depression. If it is a secondary, or if it is associated with comorbid, any physical illness, you have to find it out and treat accordingly. Choose appropriate level of care. Care is very important in this age group. And keep in the mind that suicide occurs more in elderly than any other age group. And choose therapies appropriate to the age and cognitive functioning, psychosocial intervention, and social intervention, and you have to watch for the malnutrition and dehydration at this age group, very common, especially the electrolyte imbalance. As I mentioned, there are so many cases we have seen only coming with depression, but after the investigation, they showed that hyponatremia is very common in these age groups. Bruises or fracture or burns, I'm coming if there is any neglect. I come to the next slides, I think. and mental abuse, neglected medical care, and sexually transmitted disease are there or not. So what are the goals? Goals of the therapy is to improve the mood, functioning, and the quality of life. Goals of the treatment of an acute depressive episode are to achieve recovery and prevent future episodes of depression. And intent, so it is not a 3 months treatment. So whenever you treat, it is like whether it is the first episode or second episode or third episode or more, treat like these only. Minimum duration, 9 months to 1 year, first episode. Like if it is second episode, 2 years minimum. And if it is third episode, so it may be 5 years or more. Whatever we follow the regimen, any guideline says. The intent of outcomes should be complete resolution of the symptom, not simply the reduction of the symptoms. Responsive and remission is different, so you should stress on remission of the treatment, and 3 phases of the treatment are generally required to achieve the goal. Should the elderly patient experience bereavement be treated for depression? If any bereavement, you started antidepressant? No. However, if the symptom persists more than 6 weeks or more than 2 months, then definitely you consider and diagnose it is a depression, and you can start for antidepressant. Okay. Treatment includes pharmacotherapy, psychotherapy, and electroconvulsive therapy. In pharmacology, you know that for the elder age group, start low, go slow. This is the main, and you have to consider the pharmacokinetics, pharmacodynamics, because whenever you consider the pharmacokinetics, you have to understand that older age group absorption is low, and also metabolism is also low, compromised liver kidney function. So doses should be like that only, and there is also cognitive decline, and you should avoid the polypharmacy, and compliance is very important, and live adversities, if there, you should address to those issues. So I'm not going into detail treatment. First line of treatment is definitely the SSRI. SHIAD is very common, not very common, but it is. And other antidepressant you can use like fluoxetine, in SSRI fluoxetine, paroxetine. Fluoxetine is not preferred because this elderly, due to its half-life is very prolonged. So side effect is happen, it's problematic, and paroxetine is not favored due to anticholinergic side effects. But in SSRIs, citalopram, escitalopram, and vortioxetine also you can use in this. SSNRI also used if SSRI is not responded. And you know that non-compliance in the elderly, because 40 to 70% are the non-compliance, 10% take the drugs prescribed for the others, 20% take the drugs not currently prescribed, older prescription they are following for a long time. And 40% stop drug too soon, not completed the course of the treatment what we address actually. So psychotherapy includes cognitive therapy, cognitive CBT, cognitive behavior therapy, interpersonal therapy, short-term psychodynamic, and other therapies like that. Sometimes after bereavement therapy and behavioral therapy, sometimes dialectical behavior therapy also important in this age group. Now lastly, neuromodulation. You know that ECT have a very great role when drug is not, it is a resistant cases. And ECT works very good in elderly group also. And the first line treatment for the patient which has serious side effect like suicide. And standing from psychotic depression in older adult, response rate almost 80%. So side effect, you know that anterograde amnesia, retrograde amnesia, there are but very less, even in older patients also. But what are the contraindication? Number one in all age groups, if it is ICT, increased intracranial tension, pressure, and also recent MI or cerebrovascular accident or cardiovascular attack, or continue pharmacotherapy following completion of the ECT. If you start ECT along with the pharmacotherapy, don't stop pharmacotherapy and may use maintenance ECT to prevent the relapse. Other therapy, repeated RTMS, as just my previous speaker told about RTMS regarding dementia, apathy is very responsive. Initial, in fact, in depression also, initial RTMS therapy outcome also not good, but right now there are few recent papers which showed that there is a clinical improvement with the RTMS. And deep brain stimulation and vagus nerve stimulation are the other alternatives. And you know that response rate to the initial pharmacotherapy is 40%. If you continue more, another 15 to 25%, and monotherapy actually fails 35 to 45%. Thank you. Thank you so much.
Thank you, Dr. Gautam Saha, for a very nice presentation. I'm afraid we are running short of time, and we request other two. You may sit down, sir, please. We'll take questions last of all, as we are running short of time. And we have another speaker, Dr. Nina Ray. I think she is very much here. She is a professor of psychiatry and KIST Medical College and Hospital, Nepal. Ma'am, if you can put your presentation to around 10 minutes, that would be great enough. That if you can make it in 10 to 11 minutes, we'll appreciate that.
Very good afternoon, chairpersons and everyone here. I would like to thank P.T. Shiva Kumar, Sir Professor from Department of Geriatrics, for giving me this opportunity to present on a very important topic. And I would like to say that it is an honor to share this platform with Gautam Saha sir on the same symposium. So today I'm going to talk about substance abuse in elderly population. So I'll be covering the demographic risk factors, physiology of aging in relation to substance use, different common substance abuse, barriers to treatment, and challenges. So we all know that the world population is in increasing trend. So does the elderly populations, because of decrease in death rate and increased longevity, leading to increase in elderly populations. So currently, 10% of the world population is above the age of 65 years. And we know that 21% of the world population are living in SAARC countries. And around 9.8% elderly populations are expected to increase to 13.7 by the year 2030. So we are going to have a huge number of geriatric population in the SAARC country. So by the year 2050, there will be more number of geriatric populations. The good news is that we will be surrounded by the wise people, we will be surrounded by the experienced people around us. But at the same time, we are also, different study has shown that there will be a more number of psychiatric illnesses among this group. And this is the topic of concern for us as a psychiatrist and as a geriatric psychiatrist. So let me take you back to my country, where I belong. So in our country, age over 60 is defined as the geriatric populations, and in my country also, geriatric population comprises around 10%. And even the trend of geriatric population increment is increased in our country, is increasing every year, and it is also expected to be around 18.6% by the year 2050. So talking about the current scenario, the prevalence rate of substance use disorder among the geriatric population are on rise. So basically, we all know that substance use disorder has different kinds of impact in terms of social, economic, health, well-being of communities, individuals, and the families. Therefore, the substance use disorder among the elderly population is the topic of concern, or it is being a hot topic for the discussion. The most common substances abused are alcohol, prescribed drug like opioids, benzodiazepines, and over-the-counter drugs. And it is believed that it is partially endorsed by the baby boomer generation, those who are born in the year of 1946 to 1965, who had an early exposure to the drug, that is right after the Second World War. So there are various risk factors for substance use disorder among the elderly population. Those are chronic pain syndrome, polypharmacy, physical disability, medical comorbidities, history of substance abuse, social isolation, loss of loved one, and the retirement or changes in the income. So these are the risk factors. So we need to take into consideration about these risk factors. So I will skip this because as my chairperson told me, I am given only 10 minutes. So I will skip the physiology part. It has some relation with fatty storage, liver function, immune function, neurological changes of the elderly population. So talking about the alcohol, it is the most commonly used substance by the elderly. According to the census, in 2019 National Survey on Drug Use and Health reported an estimated around 10.7% of the adults aged 65 years and older are engaged in past month of binge drinking. Around 2.8% had a heavy alcohol use, and binge drinking has significantly increased from 12.3% to 15.7% in the year 2014 to 2019. In Nepal, if I talk about the context of Nepal, we have a very patchy study. So one of the study that was conducted in the western part of the Nepal, the study was conducted in the hospital setting. The study shows that around 6% had the diagnosis of alcohol dependence syndrome. So what are the special considerations we need to take in the elderly who are abusing the alcohol? Our elderly are more vulnerable to the impact of alcohol because of various multifactorial etiologies like change in neurocircuitry, change in neurovascular, and hepatic and adiposity. So in elderly population, when alcohol is consumed, it will increase the blood-brain barrier, and it also decrease the liver metabolism, and it will increase the fat composition, so leading to vulnerable to the toxicity of alcohol. This is the reason why in elderly there is a high risk of intoxication, and there is a harm even at the lower intake of the alcohol. And we all know that binge drinking had led to different kind of injuries and negatively affect the comorbid conditions by worsening the disease itself and also complicating the disease management. Thus, it will lowering the quality of the life. And excessive alcohol consumption is also associated with increased risk of cognitive dysfunction and dementia. And one of the studies has mentioned that it also elevates the suicide risks. But it has also mentioned that maybe there are other factors that are associated with the elderly population, maybe because of depressions or other medical comorbidities or any lack of social support that may have led to the increased suicide among those groups. And another substance is cannabis. It is the most prevalent form of illicit substance used by the elderly population in the US. And the prevalence of past year cannabis use among the adults around 65 years and above has increased significantly from 3.3 to 6. It has increased by double. So what are the special considerations? The special considerations are chronic use in elderly is associated with high risks of fall, and use of cannabis with other substance use can lead to higher risks of impairment and also complications. And it is also, study has mentioned that it has some association with the cardiovascular events. And some studies has also shown that it has association between that stroke and the cannabis. Because of active form of cannabis, like cannabinoids, has a hemodynamic effect. And it also had an effect on endothelium. So these are the reason why, or there are some, these are the association between the cannabis stroke. So opioid, the prevalence of opioid prescription in elderly has, it is increasing trend, it is also, and because of increased indications of opioids like chronic pain. And so while prescribing this drug, we need to be very cautious. And recent study has also mentioned that baby boomers have an increased risk of death from the prescribed opioids and heroin overdose compared to the younger cohort group. And another substance that are commonly used are abused are benzodiazepines, which has significantly increased in the past few years, as high as 30%. The factors contributing are overprescription, polypharmacy, and misdiagnosis. Because benzodiazepine has been used in many forms, like it is used in many disorders, like in insomnia in elderly populations, in behavioral disturbance, in dementia, and various conditions. So these are the reason why they are more, there is a more misuse of these benzodiazepines in this group. So while prescribing benzodiazepine, we need to be very cautious, and long-term use of benzodiazepine is associated with dependence, withdrawal, induced delirium, seizure, and death. Cocaine. So it is also, the use of cocaine is also steadily increasing. So around 0.2% has been used cocaine in the past year, 2019, and in 0.3 in 2020, according to National Survey of Drug Unit and Health. So, but we have a limited data regarding the adverse effect, especially in the older populations. And it is also said it has some association with the cardiovascular, GI, cerebrovascular, and psychiatric complications. So what are the barriers to treatment? There are various barriers to treatment because as I mentioned earlier, these are the group elderly population has vulnerable to all the different kinds of substance abuse. So some of the barriers to treatment are like social isolation, limited mobility, and financial problems. So these are the barriers to treatment, despite of having so much of burden of substance abuse among the elderly populations. So we do have challenges. We do have a lot of challenges, like challenges in identification of substance use disorder in the geriatric population, because most often the substance use disorder are mistaken for all the symptoms of geriatric in other symptoms like symptoms of depressions, some medical illnesses, and other things as well. So identification of substance use disorder in geriatric population is very difficult. And we have a very limited substance use treatment programs. And there is also the lack of validated screening tools and diagnostic tools. And definitely we have a very less manpower. And in context of Nepal, there is only one geriatric psychiatrist. So with a heavy heart, I have to say this. So these are the challenges that we are facing. So what can be the way forward? The way forward could be, there are more research should be done. Basically, research should be done in the community setting, because if we do not focus in the community setting, then there is a chance of missing the substance use disorder in the elderly populations, because they have a lot of medical comorbidities. So it is less likely they will come to us for the treatment. So if you want to see the actual scenario if you want to see the actual prevalence of substance use disorder among the elderly population, then we can do the research in the community to see the prevalence of substance use, how they are procuring the drugs, and what is their level of motivations and other contextual factors. So, I believe that community-based research would be the best one. And definitely the awareness. We need to start the awareness from the grassroots level. That is the very much needed and mandatory one. And of course, the validated screening tools and diagnostic tool is much needed. If we can do this, then I think we can make a difference in geriatric populations. Thank you.
Thank you, Dr. Nina, for finishing well in time and saving time for the organizing committee as well. And we have Dr. Piyoti Dar, I think she is here, very much here, who's an assistant professor in pharmacology at Kolkata. Is going to speak about the challenge of choosing treatment in elderly population. Dr. Dar, please go ahead with your
sure, sir. Good afternoon, everyone. I'm very much thankful.
You have 10 to 12 minutes at your disposal,
sir.
sir.
I'll try to cover it. I understand your point.
Thank you. Thank you very much.
So, thank you, everyone. Good evening, and it's an honor to be present with you all off and on the dais. So I think they will take some time. Meanwhile, let me go ahead. Yeah. So actually, while you all are psychiatrists, I am not. I am primarily a cardiodiabetologist with some interest in pharmacology. Happen to be the General Secretary of Indian Pharmacological Society. And when Gautamda told me and Dr. SHIVA GOAM invited me, it was a little bit, came as a shock to me that I being here. So then this topic was given to me, and thank you for this opportunity. Well, I'll try to cover up the main points, and please bear with me. Challenges in prescribing and obtaining the psychopharmacological agents. For the elderly, we'll try to cover up the pain points. Why is it required? How is it required? I declare there is no conflict of interest. It is primarily in academic purpose and no financial aid is involved. So, what is psychopharmacology? It is actually the introduction of medication for the treatment in the elderly, and the requirement is increasing day by day, but the key points of pain relate pharmacokinetics, pharmacodynamics, polypharmacy, and many other points which Gautamda has initially touched, and I will elaborate a little bit. The objective of this discussion is to discuss the key challenges here. What is the prevalence? We see that in the developed countries, near about 20 to 40% are suffering from psychological diseases and having medications in at least declared format, which is increasing in the European countries, and little bit lesser data is present in our part of the world. But unfortunately, the rural areas are not yet covered, so I believe that in our part of the world also, the data will be higher. Is it that? No, it's not that only, because it leads to a huge economic burden, either from the direct issues due to hospitalization, emergency cares, medication cost, policy issues, insurance coverages, and very, very, very importantly, loss of productivity and quality of life. In US only, we lose near about $500 million US annually, and this is also a data of 2019. So you can assume what is happening here. So as I have said, that dependence is a very, very important part here. Why is it important? Because near about 25% increase in hospitalization happens in elderly population due to psychopharmacological drug use. There is a steady cognitive decline in many parts of the country, noted in our part also. There is, of course, some chance of increased mortality. The global aging trends show that not only the world is aging, the mind is also aging. By 2030, nearly 20% of the world's population will be aged over 65 or more. By 2050, people aged 60 plus, that is the older people will be higher in number than the younger ones. And this will also increase the number of dementia. It will go by tripling. The number of polypharmacy, it will increase by 14 times. The number of economic impact, we'll lose near about 10 times money we are losing right now. So it is a dire necessity, and we need to understand it. Why so? Let's come back to the basics. In the physiological changes in elderly, there is something called absorption. We know the pharmacokinetics, ADME, absorption. In absorption, there is delayed gut emptying, and transit time increases, decreases absorption. In distribution, there is change of fat, change of permeability, change of blood circulation, so the distribution pattern also gets changed. The functioning of liver goes down, phosphate metabolism goes down, enzymes go down. So metabolism also gets hampered. In excretion, primarily if we talk about kidney, renal disease is a very, very common and increasing in number in modern world, and also in India it's a very important killer. So you can understand it can change the half-life and also may increase the ADRs or adverse drug reactions. The pharmacodynamic activities, you see there are some proven data shows there is change in sensitivity of the receptors which lead to the expedited or aggravated effect of the drugs, be it benzodiazepine, be it SSRI, be it SNRI, be it venlafaxine. CNS vulnerability, we have seen that there is some increase in blood-brain barrier, and for example, benzodiazepine can precipitate delirium, cognitive impairment, and even paradoxical agitation in elderly patients. So if we look into the real world picture, when we talk about patient is not a psychiatric patient. A patient is a complete comprehensive concept. So there are comorbidities, primarily hypertension, diabetic disorder, other metabolic disorders, as Gautamda has already shown you the data of chance of their correlation increasing, which is nearly 1/5 increase every time. polypharmacy, leading to higher number of ADRs. Now, prevalence of polypharmacy is near about 40%. And in each polypharmacy, one ADR with one psychosomatic agent is happening in India in 1 hour. That's the data we have. So the time we have been discussing now, before this session ends, one case has already been registered in India, where the data is also scarce. The interaction risks, that is very important, be it QT prolongation, be it serotonin syndrome, be it heightened fallen risk, constipation, extrapyramidal side effects, these also affect the change in seizure threshold. The complex prescribing cascade has also important role in disturbances. Cognitive impairment and its effect, it's very well understandable that there is some cognitive decline, and once there is some cognitive decline, there is implication in decision making, and also it has ethical values, whether the person is fit enough to take the decision for the informed consent. Tendency of dependence on psychotropic agents in the elderly, it might be physical, might be psychological, might be both. It is not always necessarily due to chronic use of drug. It might be due to short-term use of inappropriate medication. So this second part is probably something we should know and highlight. Relevance in elderly, it will definitely have some long-term effects. The chronic mental health conditions, prolonged use of sedatives and hypnotics, and very importantly, insufficient monitoring are the pain points we are facing. Be it benzodiazepine, be it opioids, be it antidepressants, be it antipsychotics, the newer drugs, be it MAO-B inhibitor, be it serotonin, in everything we are finding something or the other. So psychopharmacovigilance is something which should come up, and already DCGI is probably planning, as far as my little knowledge is concerned, to come up with a new division of psychopharmacovigilance and instituting a body for that in every medical college and apex institutes in the world, in the country. Management of dependence, we all know that gradual tapering is required, but as Dada has mentioned, non-pharmacological alternatives are very, very important. Also, it's very important to have regular medication reviews. Sensitivity of side effects, sensitivity to side effects is usually increased. The data shows in elderly, the sensitivity to side effects usually increases. Antidepressants can lead to confusion and falls. Benzodiazepine may increase fall risk and cognitive impairment. You all know it better than me. Anticholinergic burden. Let me give you an example. A patient came to me, to my diabetic clinic few days back, and told about a psychiatrist that he's a very bad psychiatrist, useless one, blah, 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 blah. He was gazetted to an officer. I asked him what happened. He told me, the drug my doctor has given is giving me severe constipation and dry mouth. And that's how he stopped taking the medication altogether. So anticholinergic burden is a burden which even today leads to non-compliance and non-adherence of the patients. Increase in fall and fractures, near about 25% increase in data have been shown. The research insight shows that delirium may also be another leading cause of losing it. The drug selection challenges, this is our challenge. You know, we are talking about data, we are talking about research, but research in where? As ma'am has correctly pointed, research in community level, research in remote areas are really, really scarce. I would like to add one point more, that when we go into the research, we take the inclusion criteria in a way that the comorbid conditions are kept aside. But in real life, we see patients with more comorbid conditions elderly. So those kind of research is very, very important. Off-label use of drugs need to be corrected. Guidelines, stringent guidelines, and uniformity of guidelines from one point to another is another requirement here. Now the economic and access barriers, this is the patient's perspective. Cost of medication, we need to understand that in premier institutes, it might be easy to deliver medications to many persons, but it is not that the scenario in the primary healthcare setups. More so, in the primary healthcare setups, there are not even psychiatrists, you forget about geriatric psychiatrists. So this is a gap which needs to be attended. The geographic disparities I have already mentioned. The policy example. You know, when the policies are made, the drug procurement and everything is done, we prefer much more, it is a trend in our part of the country also, we prefer much more on the communicable disease than on the chronic diseases. So this disparity, we need to strike some balance somewhere. I feel that will be happening with so many of you working together. Insurance and cost issues. In India also, we are coming towards, be it Ayushman Bharat, be it state projects, whatever it is, we are also coming up into the universal insurance coverages. But there, the psychiatric illness is not well covered and well paid. This is one point which we need to put up to the policymakers and take care of that. Variable national health policies. When the essential drug list is created, you know the drug list differs from one point to another, and from one country to other, one state, in different parts, the essential drug lists are different. Even in different institutes, the essential drug lists are different. But the most important point is acceptance of the fact that I am ill. I have been doing very well throughout my 60 years of life. I have brought up my children well. I have taken care of everybody. I have been associated with so many organizations, but now I am ill. So this acceptance and awareness is very, very important. Prioritization of therapy. When the pocket is short, the sense of prioritization, comprehensive care is very important, that mental health matters. Care-seeking behavior and expenditure pattern are very important things. Medication adherence challenges include forgetfulness, complex regimens, adverse effects, ethical concerns with informed consent and others. I'm just fastening enough so that I can comply with the time I have been given. Over-medication versus under-medication. Some ethical issues are there, whether autonomy is more important than the sense of protection. Comprehensive assessment, minimizing polypharmacy and drug review, multidisciplinary care, and de-prescribing. These are the important areas which should be taken care of. Now, technology can help us with app and others, where geriatric pharmacovigilance at doorstep, not only in hospital, may lead to more information and give us some better opportunity. So old is gold, mental health matters. Geriatric psychopharmacology is multifaceted, and it should be a coordinated approach. I'll come to the last slide, the takeaway one. We propose a care plus concept. For C, it's communication, correct prescription, and coordination. For A, awareness and acceptance. In R, research, reconciliation of drug, regular review of medication. In E, education, empowerment, and very, very important, empathy. P, policy, personalization, and prioritize. Lower the cost, but not the number of the patient. Uniformity of guidelines, and very, very, very importantly, societal and community help to overcome barriers. Thank you for being with me. Thank you.
I think we have to really thank the speakers for maintaining the time. We have saved some time, otherwise you would have gone on for a long time for your other programs. Now, may I request Dr. Majid to handle the questions and answers?
We'll have, I think, couple of questions only, if there are any. Anybody? Yeah, please. Can somebody take mic in the back of the... Kindly introduce yourself.
I am Dr. Chandrasekhar from Bangalore. This question is, starting antidepressants or psychotropic medication is a problem when in the consultation license psychiatrist already relatives already has 10 medicines. How to convince? How you convince?
How to convince? Patient is already on 8 to 10 medicines for other comorbid illnesses, and you are adding a couple of...
Actually, yes, you are very good question, because they are taking lots of medications. But depression is such an illness, and the insight is there. Patient is really in problem and they suffer. They suffer. That is why it is easy to convince them that at least 1 or 2 drugs can be added for their peace of mind. Whatever they are suffering, it's an illness. So psychoeducation, as mentioned Dr. Dhar, is very important. You have to talk to them, you have to make them convinced, but it is not very difficult. But it is actually not headache. Headache is not from the side of the patient. It is from the doctor. Because when I'm writing patient with 10 other drugs, we have to think of the drug interaction. We have to think of the other side effects of that.
Any more? please.
I think what matters to the patient and caregivers is number of tablets and number of medications also. So we need to keep that in mind that when you are reviewing the medication chart of the patient, and please ensure that patient is getting minimum number of tablets. It does matter, that number of medication does matter, but the number of tablets can be again adjusted so that the patient does not feel too much of the burden of the medications.
Srikala.
Dividing the medication into two, many of the long-acting medication, especially antipsychotics, into twice a day, not using long-term, prolonged release medication, and using the same medication with different brands, which is something which I often see. Antipsychotics, two types of antipsychotics towards the same symptoms. So there are a lot of things which somebody can do, whether it is psychiatry or even, I think, other medical professions. If they can be ratified, I think many of the problems can be solved.
Any more questions, comments? If no more questions are there, on behalf of my co-chairperson, Dr. Majid, both of us really would like to place on record our thanks to the organizers for allowing us to chair the session. And thank you very much for our speakers for maintaining the time and excellent presentation. And we have also, if there is more time, we would have heard some more discussions. Thank you very much.
Thank you so much, sir. Now, I would like to invite Dr. Sridhar Vaiteshwaran, Assistant Director and Consultant Psychiatrist, Dementia Care and Scarf, to felicitate the chairpersons. So please. Thank you, Sridhar sir. Now I would like to invite Professor Krishna Prasad sir, Head of the Psychosocial Rehabilitation Department, NIMHANS, to felicitate the speakers. Thank you so much. So now we have come to the end of the session. We'll start the next session in another 5 minutes.
चेयरपर्सन एक तो
You can start. It's already late. Who is Professor of Neurology? We'll start. Start.
Good evening. Now we are moving to our next symposium on interface on neurology and geriatric psychiatry. I request all the participants to be seated. It's a pleasure to have such a distinguished group of experts with us today to delve into the complexities of managing neurological and psychiatric comorbidities in elderly population. So thus, now I'd like to invite the chairpersons for the symposium to the dais. Dr. Matthew Varghese, former Senior Professor of Psychiatry, NIMHANS, and Dr. Netravati M., Professor of Neurology at NIMHANS. I request both the dignitaries to be seated on the dais.
Where is it? First session.
A very good evening, everyone. Welcome to this session on the interface between the neurology and psychiatry. We have quite apt to discuss on most common disorders in elderly, Parkinsonism, and then followed by dementia, and finally from the psychiatric view. So for the first one, we have a little bit of change. The first speaker is going to be Dr. Suvarna Alladi. So she's going to talk on evaluation and management of rapidly progressive dementia. Madam is Professor and Head, Department of Neurology at NIMHANS. There are so many, this slide doesn't do any justice to the amount of work Madam has done. She has taken cognition to the next level, to the world. So she's been part of a lot of World Foundation series on cognition, and she's quite apt, especially when we are going to talk on rapidly progressive dementia, which is going to be treatable and untreatable. Over to you, Madam.
Thank you, Netravati. So first of all, I'd like to congratulate the Department of Geriatric Psychiatry for holding up the banner for elderly people with cognitive disorders so wonderfully for the last 25 years. It's so nice to see friends here, Professor Matthew Varghese, P.T. Shivakumar, then also friends from across the country who've come here. So welcome to NIMHANS. This is a welcome from the Department of Neurology that Netra and I work in. I know the previous speakers just took 10 minutes and they were very kind. So we could actually just tell you what is important. And I will try maybe to stay with that. I cannot promise though. Because this topic is very important, we are talking about people who progress rapidly. Now when you say rapid, there is really no cutoff. It's a clinical judgment. If we say 1 to 2 years, but it's just literally a clinical judgment, it's not an abrupt cutoff. If there are any students here, it's a disease that is progressing more rapidly. And why do we use the term? Because typically dementia, we think of a degenerative process which progresses slowly. And what is so unique about this rapidly progressive dementia is that a significant proportion are reversible or they are treatable. Treatable, we now know that even Alzheimer's disease is treatable, where at a time when US FDA has approved 3 drugs for Alzheimer's disease. So, but a significant proportion can actually come back to normal, or we can stop the progression of disease, or we can make sure that they can actually improve to a significant proportion. The other thing about rapidly progressive dementia is apart from the specific medical treatment that we give, we can also start cognitive intervention. Dr. Vaitishwaran is here. And we can actually do cognitive stimulation therapy. We can do so many things for these patients so that plasticity can kick in and they can actually get better. So this is a reason we really need to diagnose rapidly progressive dementia. They come to us with a myriad of symptoms which basically reflects different parts of the brain that are affected, whether it's memory or language or visuospatial or praxis or behavior. So depending on where the disease is actually manifesting or which connections it's affecting, patients come to us. So there is no one uniform clinical profile for people, especially with rapidly progressive dementia, because literally any neurological disease, whether it can present with a rapidly progressive dementia, and our job as clinicians will be to diagnose them as early as possible and to be as specific as possible. So some basic principles are that we should know what is so-called normal cognition, normal physiology, normal anatomy of the brain, and then we can actually say if there is some kind of a deviance, so then you can actually identify your enemy, that is a disease, and how it's manifesting. The thing about any neurological disease or any medical disorder is it's really expanded and there is so much information. So as human beings, it's difficult for us to collate all information so that we can come to the right diagnosis each time. There's so many variables. So a checklist is very, very important for rapidly progressive dementias. So we make patterns, we compare them, and then we have a kind of a working diagnosis and a list. So these are the common cognitive domains that we look for. The common cognitive tests that we do, they are the same, whether it's a rapidly progressive dementia or not. And then we map them to specific parts of the brain. And so what we try and see is what is the relationship between the brain area affected and the behavior. So if the person is forgetting recipes, is it lateral temporal lobe? They're not oriented to time, forgetting dates, is it medial temporal lobe? If it's a visuospatial problem, is it a parietal lobe? If somebody is smoking 3 packs of cigarettes or teasing his wife, which he was not doing before, it's orbitofrontal, and problems with recognition of emotion similarly. So you can see once you actually make a cognitive profiling of the patient and you know which areas are affected, then you try and see what is the underlying cause. And as you can see here, any neurological disease, vascular, autoimmune, neurodegeneration, malignancy, infection, toxic, metabolic, any systemic condition or malignancies can present with progressive dementia. So what I'll do is quickly run through some cases that we have seen. So this is a classical rapidly progressive dementia, which is cognitive impairment, myoclonus, increased CSF 14-3-3, diffusion MRI showing cortical ribboning, and periodic complexes. No marks for guessing. This is CJD. And it could be sporadic or it could be genetic. And now we know what we know newly is that the pathology is not just in the brain. We could actually pick up pathology in the tonsillar biopsy, in olfactory mucosa, in the muscles and lympholeticular tissue as well. Just not memory loss, depending on which part of the brain. If it's visual, it's Heidenheim. If it's gait problem and cerebellar involvement, if it's extrapyramidal, it's called the Stern and Garson variant. But they're just names. Basically, which part of the brain is affected first and which neurological system is affected. Variant CJD is something that happened maybe 20 years back. Now the cases have come down, what was called mad cow disease. And here you don't have the typical EEG and 14-3-3. Apart from CJD, there are many infections that can present as rapidly progressive dementia. Neurosyphilis, neurocysticercosis, HIV dementia, herpes simplex encephalitis, and Whipple's disease. So they all have very classical clinical features, classical imaging, and you can have an investigation that will actually be diagnostic. So targeted investigations are crucial for detecting these causes. It's not just a list that you do for every patient. It has to be what are the clinical features, what is the MRI showing, what is the EEG showing, and therefore which test is likely to yield a positive result. So this was a 65-year-old professor of surgery. He came with a 6-month history of inattention, forgetfulness, being disorganized, anger outbursts. He also had disinhibition and overfamiliarity. He was referred as a behavioral variant frontotemporal dementia. But when we went back to the history, he had frequent episodes of depression and there was some fluctuation in cognition and there were periods when he was progressing a little rapidly. He did not respond to memantine and fluoxetine. You can see when we did the memory test, he couldn't remember any of the 10 words that he learned. And the clock he has grossly perseverated. Most of the tests were normal, but his GAD antibody was positive. You have Dr. Netravati, please take the questions afterwards, Netra, I might leave. Autoimmune encephalitis. We are seeing very often autoimmune disorders presenting as cognitive impairment. We had hyperperfusion in the basal ganglia. So this is an autoimmune dementia which presented like a neurodegenerative disease, but there were some cues even in this patient. So we gave him methylprednisolone and then followed by mycophenolate. You can see how nicely he drew the clock. Perfect clock, 10 minutes past 5. And he also was able to remember many of the words he learned. So this was his clinical course. 2 episodes of depression, then some behavioral disturbance, then some memory disturbance, improved, and then he was non-compliant to treatment, he relapsed, and then again now he's beginning to improve. This was a 51-year-old homemaker with memory disturbances of 8 months, visuospatial disturbances. She had naming problems. So she had language disturbance at the onset of symptoms. This is another favorite disease that Netravati and we have to do this work because we've been planning to study cognition in autoimmune disorders. She brought it out that naming is impaired in this. This patient was diagnosed to have Alzheimer's disease because there was memory loss and all of that. But the atypical features were episodic fear and panic attacks and sleep disturbances. NMDA was positive. So this is NMDA encephalitis mimicking an Alzheimer's disease. Again, patient improved significantly with immunomodulatory treatment. Now I'll just quickly run through some cases because the more cases we see, the more good we are at picking up these diagnoses. Amnestic syndrome with ataxia, which was clear on cognitive testing. Patient had a tumor in the mediastinum and anti-recoverin antibody was positive. This is paraneoplastic encephalitis. Now we are seeing increasingly LGI1 encephalitis. They all have distinct other clinical features, but they may not always have them. Casper-2 encephalitis. We are seeing every other month, I think, our residents see Eglon-5 encephalitis, which I know Dr. Ravi Yadav has, your movement disorder group is seeing many of them. We are also seeing them. And these are causes of autoimmune encephalitis. While they typically present as encephalitis over few weeks, in our series, this is work done by Dr. Fahim and Saraswati, out of 306 consecutive patients diagnosed to have a dementia, 28, that's about 7 to 8% are having autoimmune dementias. That means chronic progressive course with some atypical features. Now I'll quickly run through the other autoimmune disorders. Neuropsychiatric lupus is something we should suspect in a young girl. This was a 21-year-old student who came with fatigue, fearfulness, delusions, anxiety, agitation. Some impairment of memory, attention, executive functioning. It's a very non-specific global kind of cognitive impairment. ANA was positive, and there you go. So here, that was vasculitis. So you can think of gliomas, carcinomatous meningitis. We even seen a dural AV fistula. So if you see this very non-specific white matter change on the MRI, which may not be picked up, it may actually be an AV fistula which can recover completely with treatment. This was a patient who came right during the COVID epidemic. With COVID, we thought COVID infection, hypoxia, encephalitis, seizures. But what happened? Is the mic working? Now it is. So those days we used to give remdesivir. She didn't improve very much. So while she was diagnosed to have COVID, she was in our ward. Since she did not improve and she developed dystonia,
One of our residents thought, could it be autoimmune encephalitis? And NMDA was positive. So we have seen these autoimmune processes being triggered by herpes simplex encephalitis and also COVID. This is another resident who picked up in a person with dementia. We did so many tests, everything was negative, with a history of genital oral ulcers, and it turned out to be neurobesets. This is a classical patient vegetarian with cognitive impairment and vitamin B12 deficiency, again completely improved with injections. You must never forget a vascular disorder, sudden onset cognitive impairment. It can be a strategically located infarct, but even after treating with aspirin, clopidogrel, risk factor control, patients can worsen. This person, in spite of treatment, gradually worsened, developed impairment of social cognition, irritability, anger, gradually worsened. And this is a typical subcortical vascular dementia. So this is something that is actually, can progress rapidly, can be slow. But I'll end with this slide, which is a future. So you can see in the first panel, there's a patient with subcortical vascular dementia. You can see white matter changes, but the amyloid PET is negative. So this patient won't progress so much. But if you see the panel below, very similar white matter change, subcortical vascular cognitive impairment, but amyloid PET is positive. Now this patient has mixed pathology. Over time, even though now it is a rapidly progressive dementia, he has a high chance of developing progressive cognitive impairment and Alzheimer's disease later. So we are just entering the era of biomarkers, and mixed pathologies are going to be quite common. So we have to be aware that even if you diagnose rapidly progressive dementia, we don't know later on if the disease is going to progress due to an underlying degeneration. To conclude, it's important to recognize them because they're potentially treatable. Manifestations, as you saw, are very diverse. So we should look for additional diagnostic clues. They can present in older ages, like a degenerative disease. Treatment is early and specific. As you can see, sometimes during COVID, it was not mentioned in the textbook, so you have to innovate. It's very important to support the caregiver. And this is one group of dementias where actually treating can be very rewarding. So with that, thank you very much.
Thank you, Suvarna. You'll sit with us? You have to leave right now? So you want to take questions right now before she leaves? Couple of quick questions.
Mentioned about some typical features when to suspect about autoimmune dementia. Can you mention some more symptoms and signs?
Panic attacks, fearfulness, anxiety, sometime during the course of disease, sleep disturbances. And the cognitive profile does not fit into a typical Alzheimer's disease or FTD. For Alzheimer's, you'll have episodic memory, then semantic memory, then visuospatial, frontal will be relatively preserved. If it's behavioral variant, you'll have typical disinhibition. But if it's autoimmune, it doesn't respect those, because these proteinopathies go in one particular way, either through one default mode network. But in autoimmune, it's not like that. So the cognitive profile will not be typical of a neurodegenerative cause. Of course, the duration is, if you ask, there'll be something in the past that might suggest they had an autoimmune process. Some depression or some acute memory loss or little disorientation. So this is a smoldering inflammation of the brain. So there might have been a time when there was some more inflammation, settled down. So a detailed history is, I think, going to, and then of course focal signs like dystonia, seizures, all of those as well, and a history of other autoimmune disorders. So these things, if you take, you might pick them up. Non-responsiveness to treatment.
I think Suvarna's basic 2 points are rapidly progressive in 1 or 2 years, because you don't expect Alzheimer's to progress so soon in 1 or 2 years. And an atypical nature is, I think, what makes you suspect something other than the primary dementias, AD, vascular, FTD, DLB, and so on. Those are pretty typical presentations. Can you give the mic there? Can you use the mic because you can.
How easily are the investigations can be done in a non-NIMHANS setup?
So that's such a good question, because all my colleagues outside NIMHANS, when they have a difficult case, I get a call, I get a video call, so we're talking to the patient. They tell me, don't ask. It's easier to do a PET scan than to do autoimmune profile. It is so expensive. So we do not recommend it, madam, at all.
Are you saying autoimmune profile?
Yeah, but all these autoimmune encephalitis profile.
But
no?
I thought it takes about 5,000 to 10,000 rupees.
Sir, outside it takes 55,000.
No, to send it here.
They don't.
Because I see my colleagues in St. John's sending them to NIMHANS and they get it done in NIMHANS. So I think it's possible to do it in NIMHANS.
No, but certain, I think, investigations are not done here also.
DPPX, Iglon, so many, they don't. I think, Netra, you are an expert, no? You want to tell?
The cost is more for private, and especially when they have to send from North India, it costs more. I think, no, it takes time, and I think they take nearly 4 to 6 weeks when it comes from outside. And the cost is 4 times what
It's
we are
not
doing it
practical,
here.
madam. I completely agree with you. So the good history, good examination, and a high index of suspicion is when you will do it. And if you keep the patient under follow-up, the disease will emerge in some form or the other.
We often have patients who come, who are brought by their children from the US. The history isn't clear, and the follow-up is going to be poor. In such patients, do we, by default, go ahead and do an autoimmune evaluation?
No. I don't think a bad history is an indication for autoimmune. A good clinical examination will help. If the person is young, as I said, if the profile is not typical of a degenerative cause. And see, we do it. I mean, we say one thing on the stage and we do one thing in practice, right? This is one of those. We do it.
In
NIMHANS, we do it. What to do? Every resident will tick it.
No,
but it is not right, is what Dr. Srikala Bharat is saying. And I think that is, I have heard this from my senior neurology colleagues also. We should not do it routinely.
Yeah,
So
no, I think what Suvarna is saying is right, in the sense that in NIMHANS you can afford to do it. And also good to pick up a bank of people where you do it, where you can see what it pans out to be. So I don't have any objections, or I don't have any quarrels with them doing it in NIMHANS for everybody. But in our case, if you're outside, it's just not possible, as Suvarna said. You have to really pick and choose.
I just want to add one thing, especially these autoimmune panels, some of them can be false positive, especially in serum. So we need to actually always have a clinical and correlation. So not all, few of them can be, especially in MDA.
Yeah, so I mean, there's a warning also. Yeah, I see sometimes psychiatrists who see typical psychiatric cases also asking for autoimmune panel in private practice. That's definitely not useful. Somebody had a question here.
Ma'am? Here. Ma'am, when is pharmacotherapy indicated for a patient who comes to us with dementia? How early pharmacotherapy helps the patient?
You mean degenerative dementia? Am I like mild cognitive
When we
impairment?
suspect dementia for a patient and the clinical examination is revealing that.
See, dementia, there is no doubt. If it's Alzheimer's disease, you have to start cholinesterase inhibitors. If it's mild cognitive impairment, there is MCI due to AD. If it's mild cognitive impairment due to Alzheimer's disease, it's still not in the recommendations. But I think we give it when we think that there is medial temporal atrophy, there is CSF biomarkers are positive. We explain to the patient and we give them. So when you are sure of your underlying etiology, that is one. Of course, when there are behavioral problems and you think medications will work, you have to, but always give medication with non-pharmacological therapy. You can't just prescribe. You have to talk to the caregiver. You have to see if there's something else you can correct.
What is the safest drug, ma'am? First line drug?
All three are as good as any other.
Head-to-head does not, there's no difference. They're all the same. But you can't do two together. Okay. We see sometimes prescriptions too. So give one, try for 3 months. There's no difference. There's no change in the patient. Then you try the other.
When do you exactly time the MRI, ma'am? investigation, imaging?
At the time of diagnosis, always. MRI, I think there's no controversy. We do an MRI.
MRI or CT scan is indicated right in the beginning.
Okay. Thank you.
Ma'am, actually, I have one doubt. Like, there was one patient who came with rapidly progressive dementia within 6 months. All the investigations came out to be normal. Even the autoimmune panel was negative. So, in that case, should we consider seronegative autoimmune panel, give a trial of steroids or immunomodulators?
Okay, so the most common cause of this so-called rapidly progressive 6 months history is still degenerative, because many of our patients, they don't give the family members notice only after they have really decompensated. They've lost a lot of money or they've forgotten how to cook. So the early memory symptoms may not be picked up. So if you're looking at a 6-month history, but it's otherwise looking like a typical AD, I still think we shouldn't think of seronegative at all. Seronegative is if the autoimmune encephalitis is typical of autoimmune encephalitis clinically, and then your antibodies are negative, we call it seronegative. We are not calling seronegative autoimmune dementia today. Having said that, if there are atypical features, you can still try.
But Suvarna, even with all that, even typical autoimmune encephalitis, even with pulse treatment, the prognosis and outcome is not very good in the majority of cases, no?
No, sir.
Would you say it's good in the majority of cases?
Yeah, we have followed up all these.
We have a series of.
Yeah, these 30 patients, again, Fahim and Saraswati have gone back, called them back, and they show significant. The ones that don't are the ones that never did from the very beginning. They kind of didn't respond. So in those patients, I think if we do biomarkers or they're false positive, yeah. So it could be just a false positive or it could be some underlying other pathologies. And sometimes chronic disease will not respond.
Just to add to what Madam said, so most of the time when you suspect it's an immune-mediated disorder, the faster you diagnose and start the treatment, almost complete is the improvement. As you delay, the degenerative process starts. That's the reason it's an interface between immune and degeneration. So the immune pathology it can start with, but when there is a delay, it goes to degenerative phase.
Yes, like in multiple sclerosis. Thank you.
Thank you. Thank you, ma'am.
Let's Suvarna go.
Now I will, ma'am.
Okay, we have to give you a moment to hang on.
I'm so sorry to disrupt my...
Yeah, now I'd like to invite Dr. Sandeep Grover, Professor at PGIMR Chandigarh, to felicitate the speaker. So please. Thank you, ma'am. Thank you, sir.
Suvarna is also one of the authors of the ICMR toolkit, so please have a look at that. It's available in many languages. It should be one of the things that is used for cognitive evaluation. Thanks, Suvarna. So this triumvirate of Suvarna, Netra, and Ravi Yadav are the people who we look to quite a lot from psychiatry. So I want to ask the next speaker, Ravi Yadav. Ravi Yadav is also, many people don't know that Ravi Yadav is one of the authors of Clinical Examination Neurology Bickerstaff. So I always say, read Bickerstaff. And I say Ravi Yadav. So I think all the stuff you can read. But I think Ravi is one of the people who's, together with Pramod and other colleagues, spearheaded the Parkinson's and movement disorder clinic. And I think this clinic has sort of grown immensely, right from the time Dr. Uday Mutane started it many years ago, and he's really the original guru. So take it away, Ravi. And there's, I know there are lots of interfaces between Parkinson's and psychiatry and dementia.
Thank you, Matthew sir, for the kind introduction. And this is one area which actually is very close to my heart, because the difficult patients are actually lie between this interface. So I would like to thank Dr. P.T. Shivkumar and the organizers for inviting me to give this talk. So what I have been asked to speak is on management of Parkinsonism in elderly with psychotic symptoms. So you can see the level of complexity in that topic itself. But what I will do is just to give a brief overview and broadly how we approach these patients who have psychosis in the setting of Parkinsonian syndromes. So these are the various headings under which I will cover my lecture. So when we talk about Parkinson's or Parkinsonism, these are the various spectrum of patients which we can see. So there is bradykinesia, there is a typical tremor, stooping forward posture, freezing of gait. So this is the classical manifestation of the idiopathic Parkinson's disease, which is, if you go by the pathology, it is alpha-synucleinopathy. But now we know that, so these are the cardinal 4 features: tremor, rigidity, bradykinesia, and postural instability, TRAP. But bradykinesia is the main, most important symptom out of all these. And if we look at what lies underneath, so we are seeing the clinical features of Parkinsonism, but you can see, although most commonly it is synucleinopathy, which is Parkinson's disease, Lewy body, MSA, familial Parkinsonisms, but other proteinopathies also can have similar features like TDP-43 proteinopathy, PSP, corticobasal degeneration, some of the FTLD syndromes, even Alzheimer's disease. So there can be significant overlap. And if we go by the etiology, again Parkinson's disease would be most common, but we can see secondary Parkinsonian syndromes with vascular Parkinsonism, post-infectious, post-encephalitic, drug-induced, tumor, trauma, normal pressure hydrocephalus, then hereditary Parkinsonian syndromes and atypical Parkinsonian syndromes. So when we get a referral about Parkinsonism, this is all actually we have to consider wide spectrum of disorders. And why is it important to know that the clinical difference between the different Parkinsonian syndromes? Because the prognosis varies. So if there is good response to levodopa, more than 30%, there is obviously survival is more likely, it is more likely Parkinson's disease, good response to DBS. While if there is poor response to levodopa, you can see that it could be MSA, PSP, CBS, which have recurrent falls, poor response, rapid progression. So that is very important for us to understand therapeutically. Now what are the red flags in Parkinsonism? Symmetricity. These are the clinical clues. Obviously you will have to look at a group of all these symptoms. Absence of tremor, myoclonus, limb apraxia, alien limb phenomena, impaired down gaze, facial dystonia, early falls, L-dopa-induced facial dyskinesia, ataxia, stridor, early dementia and early dysautonomia. So these are the red flags which point that this is a atypical Parkinsonism. So what are the common conditions which are misdiagnosed as Parkinson's disease? You have to look at on the left side, essential tremor. So in essential tremor there can be, spectrum is there in which early onset can occur in the young age, while late onset essential tremor may present, and people may get confused with essential tremor, vascular Parkinsonism, drug-induced dementia, DLB and atypical Parkinsonism. Then now coming on to, so you can understand based on this, we have to approach Parkinsonian syndromes. But if you look at classical Parkinson's disease psychosis, there is a clinical criteria where illusions and false sense of presence, hallucinations and delusions. So two most important things are illusions and false sense of presence. So these are very typically seen in Parkinson's disease psychosis along with the background of Parkinson's disease and exclusion of other causes which I have discussed earlier. So as the stage changes, you can see in the early stages or mild Parkinsonian features, minor illusions can be there like passage, like presence, and early diplopia can be there. And as the insight is lost, the severity goes on increasing and hallucinations without insight and higher stage of Parkinsonian syndrome or Parkinson's disease occurs. Now why it occurs basically is various studies have been done on this, basically underlying the cholinergic pathway dysfunction, dopaminergic pathway dysfunction, And as Dr. Suvarna had alluded earlier about the default mode network. So you can see over here there is a increase, the blue part is the connections in a normal person. So this goes, decreased functional coupling happens and increased functional coupling with the occipital and the parieto and temporal. So this happens leading to the almost disconnection from the frontal or dorsolateral prefrontal cortex where insights are located. So this is the basic. And again, we have to remember that current hypothesis is body first versus brain first. So Parkinson's disease starts in some people in gut. So this is the new hypothesis which is there. And then alpha-synuclein pathology rises up and goes to the dorsal motor nuclear of vagus and then to the cortex. The other group is where it starts in the brain, that is the unilateral olfactory. So they both behave differently, and the patients who have the body first type are more likely to have rapid progression, more of psychosis. So this is another aspect of Parkinson's disease. And then there is several phenotypes are there. So diffuse malignant type, which actually has rapid progression, REM sleep behavior disorder, as well as orthostatic hypotension, they are the ones who are more likely to have psychosis. And this is again to show that there are several neurotransmitter deficits are there, dopaminergic, cholinergic, even noradrenergic in the brainstem, which ultimately give rise to various phenotypes which I mentioned earlier. And there could be combination of symptoms. For example, alpha-synucleinopathy can also exist with the other tau tangles can be there, Levy bodies and cortical Levy bodies can be there, which also can be determinant of psychosis in these patients. So what determines early symptoms can be isolated diplopia, freezing of gait, spatial misjudgment. So these can be detected, and these are the patients who are likely to have psychosis. Then cognitive deficits like visual perception, object, face, spatial, dysfunction in Stroop test, go-no-go test, verbal fluency, and memory, visual and verbal can also be identified in these patients. So in one of our collaborative work with the Department of Psychiatry, there was a study done to look at prevalence and correlates of psychiatric comorbidity in Parkinson's disease and atypical Parkinsonian syndromes, and it was identified that depression and psychosis was seen in PD almost 21% and atypical around 25% of the patients, and predominantly in Parkinson's disease, and then various other disorders also were identified. Overall prevalence is around 22 to 37% and increases with the stage of the disease. So another of our student who had worked with in collaboration with psychiatry, 40 patients of Parkinson's disease with psychosis identified various type of hallucinations, pure visual hallucinations, auditory, tactile, and a combination was also seen in significant number of patients. And these patients were relatively younger. Another thing is that in our country, the relatively younger onset Parkinson's disease also is prevalent because of lot of consanguinity and genetic abnormalities. So these patients are again predisposed. In other studies also we found that presence of RBD, that is REM sleep behavior disorder, excessive daytime sleepiness, frontal lobe dysfunction, and freezing gait phenotype was also identified with increased chance of psychosis. And these patients had executive dysfunction, verbal learning and memory dysfunction also present in these patients. This was part of a PhD study by Dr. Abhishek Lanka. And also there were white matter abnormalities as a part of this study itself was found in certain areas which were clearly suggestive of abnormalities. But if you look at a large data set which has been published about what about all the degenerative diseases, what is the spectrum? So in this study it was found that almost significant number, around 22% in Alzheimer's, Levy body obviously we know will be very high, FTLD, PSP spectrum also. So these are again at the junction of interface of neurology and psychiatry, and we need to look at the other phenotypes in these patients. Now what happens between early psychosis and late psychosis? So very interesting data in this study. If we look at Levy body we know, but if we look at hallucinations within first 3 years or delusions in first 3 years, we can see even in FTLD, TDP43, PSP pathology, AD also was reported to be significant in this data set. And then if we look at in already, like we get referrals, already patient had schizophrenia and develops new onset of Parkinsonian features, tremors. So there also the odds of developing PD in this group is around 4 times as compared to the normal. So we have to watch out for alpha-synuclein pathology in these patients also. So again, we tried to look at 69 patients, and we again found with PD with psychosis, impaired frontal lobal functions were significantly present in these groups. Now, how do we treat these patients? That is another. So if it is a classical Parkinson's disease, we first diagnose it as per the diagnostic criteria. We exclude the unusual causes. We look at the red flags, which I showed earlier. And then if they are red flags, we consider them in the atypical Parkinsonian syndromes. And if this kind of phenomenology is there, there is an early stage, middle stage, and advanced stage, which over 10 years, dyskinesia presents, fluctuation presents, then this is typical Parkinson's disease. But if there is, and in this group we use immediate release, carbidopa, levodopa, control, several options are available in this age, in this group. So early therapy in typical Parkinson's will be levodopa preparations, dopa agonists, MAO-B inhibitors. Then subsequently, as per the stage increases, we go on increasing the dosages and also watch for wearing off phenomena, and advanced therapies like DBS also is available. However, and along with rehabilitative therapy. But what about only psychosis in the setting of Parkinson's disease? So this is the flowchart which you can see. Exclude the medical problems first, rule out infection, thyroid dysfunction, any medications, anticholinergics. Anticholinergics are the ones which are biggest culprit, and this should be stopped. Then any recent medication change which has been done in last few weeks since the onset of psychosis. And this is the order of medications. Anticholinergics stop first, then selegiline, amantadine, dopa agonist in that order, and last to stop is the regular levodopa. And if nothing works, then obviously it is de novo psychosis because of the pathology or the degenerative process itself. They have to be started on the quetiapine or clozapine as per the evidence. Along with general measures, re-establish the circadian rhythm. If there is sunlight exposure or melatonin is required to reset the circadian rhythm, re-establishment of the normal level sensory inputs, hearing and vision aids, familial environment. So these are the general measures that have to be applied in these patients. And the reduction of anti-Parkinsonian medication are in that order which I mentioned earlier. Now, how to do the imaging? Imaging in these is very important to diagnose whether they are having a baseline abnormality or degenerative process going on. So structural MRI is number one to look at any abnormality in a space occupying lesion, demyelination, traumatic, toxic, hydrocephalus, which can like NPH. And once that is ruled out, we can look at some of the features like dorsal nigral hyperintensity, etc., which are suggestive of Parkinson's disease. But what about the special imaging, that is the SPECT or PET scan? So SPECT or PET scan, we have to, if we have ruled out in structural MRI any typical vascular abnormality, space occupying lesion, and we are still not clear it is degenerative, then we go to the dopaminergic imaging, that is a presynaptic. So here we have fluorodopa PET which we do. If a DAT scan or SPECT is available, that can also be done. So if it shows clearly dopaminergic deficit, and there are no red flags for atypical Parkinsonian syndrome, then it is Parkinson's. Otherwise, if red flags are there, we go to FDG PET, which will show the space wise, is it fitting into PSP, MSA or CBD or following a particular pattern. And these are the various drugs which can be used, atypical antipsychotics, cholinesterase inhibitor. But evidence wise, if we look at the evidence, these are the two most commonly used drugs which actually, quetiapine is more used here. Clozapine and pimavanserin is also, the evidence is very robust. So the take-home message of this talk is individualized approach to the patient, rule out the medical conditions, rule out the newer autoimmune encephalitis which was discussed in the, because we have seen with the referral some of the cases like who actually presented with psychosis. So red flags which were discussed in the previous talk should be looked at, dysautonomia, some of the sleep attacks, hypersomnia, insomnia, all those are very important markers in such situations. And stick to the levodopa carbidopa basic combination and avoid the anticholinergics. DAT scan F-DOPA PET to exclude drug-induced Parkinsonism, and FDG PET to look at a particular etiology of the degenerative. So with that, I conclude my talk. These are my acknowledgements, and I sincerely thank all my team members and Department of Psychiatry who work together with us in this area.
Thanks, Ravi. That was a very comprehensive talk, though you had to go quite rapidly. Next, I call about Meena Chandra. Meena Chandra is a professor of psychiatry. She took over the Department of Psychiatry at the, what is it called now? It's got a new name, right? Atal Bihari Vajpayee Institute of Medical Sciences, the old Ramanohar Lohia Hospital. So she's got interest in geriatric psychiatry, and I think she's been a member of the Geriatric Mental Health Association for quite a few years. Meena.
Thank you, sir, for the kind introduction. Thank you, Dr. P.T. Shivakumar and Nimhans for the opportunity. My task is limited here. I'll be talking about managing neuropsychiatric comorbidity in older adults with CVA. So next. So this term is defined differently in different papers. So it is called neuropsychiatric comorbidity, neuropsychiatric disorders, also called neuropsychiatric disorders after stroke, NDS. So it's a common entity, it's quite common. Initially it was thought to be a reaction to the experience of stroke. Now we know that more biological aspects are involved. Why we should study this is, in addition to the cerebrovascular event, neuropsychiatric comorbidity is independently associated with poorer outcomes, a lower quality of life, increased caregiver burden, and an unfavorable functional status. And it may also increase the risk of mortality, because now larger parts of the brain are involved, and not just because of some psychosocial angle. And it is also an independent predictor of recurrence of stroke. So that's why it's very important that any case of stroke is seen by both neurologists, physicians, and also by psychiatrists. So the current management is not satisfactory. For functional disorders, we have so many options, but as we'll see, that when neuropsychiatric disorders develop after a stroke event, then we find that we are hitting a wall and we are not finding the desired therapeutic response, except in the case of antidepressants. Sometimes advanced medical interventions are also not given to patients with cerebrovascular events with neuropsychiatric disorders, because the doctors are unwilling. They think the patient is psychologically unstable. Should we offer? Should we not offer? The patient may also be unwilling. And the family support and social support is also less for another intervention, which might also be, high-risk consent might be taken. So as it is, the patient is fragile. He's just had a stroke. The family members are also fragile. And once psychological symptoms are seen, even the doctors become very tentative. Should we offer? Should we not offer? In case there's a poor outcome, would we be blamed? So that is why sometimes the outcomes are not so good. So broadly, the comorbidity after CVA can be divided as neurocognitive disorders. So we have the whole range of cognitive impairment and dementias, and the non-cognitive disorders. Of the non-cognitive disorders, there are four major. Depression, anxiety, we all know. There's a lot of PTSD also. And when we check for PTSD, we should be looking at the stroke event as the stressor. Sometimes we think only of psychological event as the stressor, but a biological event is also a stressor. And yes, we find enough cases of psychosis and mania. At the same time, there are obviously cases of catastrophic reaction. We had an excellent talk on apathy. Apathy is also common. Organic personality change, sometimes we see those cases as malingerers in court cases. But yes, personality change is known. Emotional lability, uncontrolled laughter, crying, and also chronic fatigue, which which causes patients to be shuttled from one doctor to the other. But these are, it's also a symptom of neuropsychiatric comorbidity. So what are the risk factors? There are demographic factors, social factors, clinical, treatment, as well as genetic factors. So younger patients are more likely to have neuropsychiatric comorbidity. We always believe extremes of age are more risky things, childhood and older people. But for neuropsychiatric comorbidity, the current evidence says younger patients. Female gender, if there is no social or family support. Surprisingly, for us psychiatrists, we feel marriage is a good prognostic factor in schizophrenia and other disorders. But marital status, as per the current research, is worse when there's neuropsychiatric comorbidity after stroke, mainly because person has responsibilities. Person might be attached and might be doing future planning with his own impaired status, and hence depression and anxiety can happen. And yes, people with poor educational status, with less cognitive reserve, they tend to have more neuropsychiatric comorbidity. If there is a past history of psychiatric illness, it's likely that they can have similar picture or a different picture. So I had a case of recurrent depressive disorder who always responded to treatment. He had poor compliance but always responded. And this is the first time he was not responding. And in between he had had a cerebral vascular event. So the same picture, if it is not responding, and when the patient was referred, we were thinking in terms of vascular depression or something. And then very, carelessly the son said, Papa had a stroke in between. So you can have a similar, because once you recover from stroke, the motor deficits are gone. Nobody is thinking that there could be an underlying neuropsychiatric morbidity. If the stroke is severe, if there's a lot of functional impairment or motor deficit or posterior circulation strokes, where there could be a lot of balancing issues, if there's functional impairment, and if there's chronic fatigue. So those are the clinical risk factors. We all know about the golden hour. There was talk earlier today that patients need to be treated well in time. And we know how diverse the country is. And most people, even in a metropolitan city, may not be able to reach in time. So at my hospital, we are having a stroke unit, and everybody, the medicine residents and the neurology residents are trained that they have to, intervene in that golden period. It's a combined program with AIMS New Delhi. But even in our sister hospital, some 2 kilometers away, this facility is not there, though it's also a medical college. And it's a renowned medical college from British times. So the stroke units are few and far in between, even in medical college center. So willingness to seek treatment. After a stroke appears to be a dead-end event. The family and the patients already accepted that, nothing can change. Why get treatment? Health insurance coverage is a challenge in India, though now we are having PMJ and Ayushman Bharat, and I think things will improve. And it's a very expensive disease to have. Fortunately, in our hospital where I'm working, everybody gets either central government insurance, or we have a lot of free resources. But that's not true for the entire country. And lastly, but most importantly, is not about treatment, but about rehabilitation. We focus so much on early treatment, but we never talk enough about rehabilitation services. A person with a stroke event must have rehabilitation from day one. He should have physiotherapy. He should have all kinds of rehab support to have better outcome. Though sometimes we think of rehabilitation 3 months down the line, 6 months down the line, we take our time to refer the patients, but ideally, the rehab professionals should see the patient from the onset of event and plan exercises and interventions for recovery. And they can easily use caregivers, because early in the course of illness, caregivers are very motivated. Once deficits set in, then caregivers are also not motivated for rehabilitation. Then there are certain genetic factors. One is the serotonin transporter gene. The homozygous short form is associated with depression, while the long variation is not associated. But the long variation is associated with a better antidepressant response. And if it's a heterozygous long and short form, then it's not related, either positively or negatively. Then BDNF, hypermethylation and polymorphism, greater risk not just for post-stroke dementia, post-stroke depression, I'm so sorry, but also for post-stroke anxiety. So serotonin transporter, though we are using SSRIs for anxiety in functional psychiatric disorders, but serotonin transporter gene is not associated with post-stroke anxiety. But BDNF, both hypermethylation and polymorphism, they are related. And the tryptophan hydroxylase 2, that is related only to anxiety, but not to depression. So certain genes and how they play out differently in CVA cases. So these are some references in case somebody is interested. How do we assess? We have to start with consciousness, alertness, cooperativeness. We might need to assess the patient frequently before we make up our mind or before we dismiss the patient in our busy, referral services. Determine if we have a reliable informant. If the informant is not reliable, one should be fine with it. One should go ahead with the assessment. But sometimes we start believing the informant, and the informant might be a son who has never stayed with the patient, or a daughter-in-law who is at work, but the patient is looked after by a servant or maid servant. So you have to get the reliable informant. And in case that is not available, we should document it. The entire history of current episode, as psychiatrists, we should understand. We should understand the epoch. We should not just be depending on the neurologist to do their bit and get, a superficial understanding of the case. And they have done it, so it's okay. No, we have to understand it for ourselves also. See whether there's a temporal correlation between the CVA and the onset of psychiatric disorder, or patient might be having pre-existing psychiatric disorder, it's just an exacerbation. In that case, prognosis is better. But if it is a de novo psychiatric disorder after a stroke event, prognosis is worse. Look into the biochemical investigations. As psychiatrists, we sometimes, don't pay enough attention. And a lot of things are reversible also. Like, especially in the north, there's a whole vegetarian kind of culture, and people who take non-vegetarian food may take it occasionally. So for all practical purposes, B12, folate might be deficient. And those are the deficit which can be corrected. Not everything can be corrected, but our job is to identify what can be corrected. Look into the neuroimaging, look into the EEG. Sometimes we ourselves order also. Look into the medication chart. Is something contributing to the presentation? It's possible. See the vitals monitoring. Look into intake output. Because when a person is in ICU, right, so the person is dependent only on the professional caregivers. And you may be surprised, even in the best of ICUs, people have been known to be dehydrated, right? Because the family is not there and there might be questionable care. We have to do a detailed CNS examination. Again, going back, one should not be looking at the physician or the neurologist to do. We have to do it for ourselves because we are treating the patient. MSc if possible, if not Kirby. We can use screening instrument for psychiatric disorders. I'll come to which are the ones which are evidence-based for post-stroke, post-CVA psychiatric disorders. And Ligen. You may have to Ligen every day. Like if there's an intracerebral hemorrhage, neurosurgeon might also be on board for the case. You have to continue to Ligen. Patient might be in delirium. One has to keep on Ligening. So if it is a depressive disorder, by definition, onset can be within 1 to 18 months post-stroke, right? And the pooled prevalence is pretty high, 34%. 34% means 1/3 of patients would have it. And the challenges for diagnosis is patient might be aphasic, might have, alexia, agnosia, might be having expressive or receptive dysfunction, might be cognitively impaired, pre-existing or following the stroke, may have ebulia, and these are all depression mimetics. And once we have a patient who is not communicative, it is a challenge. It is a challenge for us. And once we accept the challenge, then we can look into depression mimetics, and we are experts at behavioral observation. So we might use that hat and understand depression. In post-stroke anxiety, it is 20% within 1 month, and in 6 months it rises to 24%, right? And some symptoms of anxiety are also similar to some neurological symptoms, like if the muscles are tense, it could be because of anxiety, or it could also be because of the neurological illness. Or post-stroke, posterior circulation stroke might result in vertigo and dizziness, and anxiety also, we know it might be like that. And so we have to be mindful that the current picture might be a result of neurological disorder, but might also be a result of comorbid neuropsychiatric disorder. We have to be mindful. Then PTSD, I'm so sorry, I should say, this is the one which falls. While anxiety rises, but PTSD falls because over time people develop coping skills and might acquire some functional, might acquire increased functionality from nearly 30% at 3 months. At 1 year, this is less than 10%. Sometimes it gets subsumed under anxiety disorders, especially in literature, and catastrophic reactions. So PTSD, we know, is a spectrum of anxiety disorder. So individual papers are less, but sometimes in anxiety disorder it gets subsumed. Then post-stroke psychosis, actually it is less than 5%. Though this is the one which appears most florid and for which we get most of the calls. If the patient is crying, then they would say, patient's just emotional. What is the whole point of getting a psychiatrist? And in our hospital, we're a little further away. We are across the road. If the patient is anxious, there's no need for him to be anxious. He's just anxious. If the patient has PTSD, then the patient is reacting too much. But if the patient is psychotic, we get an instant call. We get a phone call. Please send somebody straight away, right? But at the same time, delirium might also present with a psychosis-like picture, fleeting delusions might be there, hallucinations might be there. So even though when we get calls or we don't get calls, if we get a call, we should follow the patient de novo. We should not wait for follow-up calls because we know patient's picture might change in the coming days. So the evidence-based assessments for post-stroke depression include the hospital anxiety and depression scale, the depression subscale, HAM-D, BDI, GDS, PHQ-9, and also Center for Epidemiological Studies depression scale. So there are lots. Anyone can be used. Even PHQ-9 can be used by a non-PG JR, by a medicine JR. We teach them. You please use this. Like for delirium, we train all our physician residents to do 480. Please do it. So for treatment, you can use SSRIs, you can use SNRIs, you can do CBT, you can also do IPT. You can do any neuromodulation as adjunct, both TDCS and RTMS and exercise. For post-stroke anxiety, HAM-A and HADS anxiety subscale, again similar kind of interventions can be done, both pharmacological and non-pharmacological. For post-stroke PTSD, use the PTSD checklist and use stroke as the stressor. Like we say, use assault as the stressor, or use, this kind of horrible, witnessing of an accident or a fire as a stressor. Just use stroke as the stressor and just keep on applying. You can also do a clinician administered PTSD scale, impact of event scale device, PTSD diagnostic scale is also there. And you can also use the structured clinical interview for DSM. Similar psychotherapeutic approaches. So psychotherapy is the first line of treatment for PTSD and not medication. You can use antidepressants, anxiolytics, sometimes antipsychotics, and anticonvulsants are also written in literature, though I personally believe I've never needed to use them. I mean, if one is needing antipsychotic and anticonvulsants in a PTSD patient, then somewhere the diagnosis is not right. Why should we need to use it? Obviously, for psychotic disorders, this is something very interesting. For all the disorders, there are a number of scales which have been validated. For psychotic disorders, only NPI, which is a scale for, neuropsychiatric comorbidity in dementia, that is the one which is validated, and none of our BPRS and PAN-SS, none of them have been validated. Though they have similar items, we should use antipsychotics, can use neuromodulation also. We had a talk on neuromodulation, psychosocial therapy, and interventions. A little bit about drug-drug interaction, because a lot of people with thrombotic or embolic kinds of events would need, medications like clopidogrel and warfarin, and they are drug-drug interaction with our psychiatric medication. So clopidogrel is metabolized into active products through cytochrome P450, and when we have CYP2C19 inhibiting SSRIs like fluoxetine and fluoxamine, then clopidogrel levels, it doesn't get metabolized into active metabolites, so it's not very effective, and the risk of developing an ischemic disease rises by 11%. So we have to be very careful which antidepressant we would want to use. Ideally, we should not be using fluoxetine, which is the government supply, especially in the north, or fluoxamine, as the fluoxamine has a lot of drug-drug interactions. Then even with aspirin, it is associated with bleeding, because SSRI, SNRI do not just reduce serotonin reuptake in the brain, but also in the platelet, and that is how it's associated with bleeding. Similar is the case with warfarin. These medications inhibit warfarin metabolism, and through cytochrome P450 system, and also by binding with the plasma proteins. So if there is warfarin or clopidogrel or aspirin, no fluoxetine, no fluoxamine. And with paroxetine, again, paroxetine also is associated with increased bleeding. Paroxetine may also be associated with increased risk for seizures in post-CVA patients. So be very careful of which SSRI you would want to give. The impaired outcomes associated with this is delayed recovery, impaired functional status. So there could be role deficits, social role, familial role, work-related persistent impairments, ADL deficits, IADL deficits, impaired quality of life, community reintegration, familial reintegration, and mainstreaming becomes difficult, and that also results in psychosocial stress and psychiatric morbidity, query increased mortality, and obviously increased caregiver burden. To conclude, despite the high prevalence and documented major consequences on recovery, prognosis, quality of life, this is vastly under-recognized and under-treated in clinical practice, not just in Asian countries, but also in more advanced countries. And if there is early detection and proper management, we would have better outcomes. Thank you so much.
Can you join us here, Meena? So I think we take very quick, maybe one or two questions, but I think all the speakers have underlined the very important reason of this interaction between psychiatrists and neurologists, because 30 to 50% of cases seen by any of these professions have the other professions, disorders. So I think psychiatrists and neurologists have to have a lot of liaison and a lot of dialogue. Any quick questions? Yes, please.
Okay, so yes, so there is something which is in the book, and there's something that we are doing. So we have been using mirtazapine, especially when there were sleep issues and circadian rhythm issues, but we closely monitored, right? Even our poor patients have received fluoxetine and clopidogrel together and not had an ischemic event, but that could be serendipity, because we have scientific evidence for that, right? So what we do in practice is sometimes not evidence-based.
This is for neurologists. Sir, this Parkinsonism with psychosis, we can just first line, we can use clozapine, and what is the dose you use?
So I would refer this question to our psychiatric colleagues, because evidence-wise, whatever I showed you, that is the latest one. So pimavanserin is number one, then clozapine. But ease of usage and monitoring, how many of our...
So with that, whatever our colleagues
We
do.
usually start with very 7.5 mg. That's
So
the
we don't have
lowest.
pimavanserin. Psychiatrists are loath to use clozapine because we are very worried about the side effects and monitoring. It's neurologists use it. We use more of quetiapine, and I was telling Ravi, we use aripiprazole quite a bit. And the drug that is, a lot of people have forgotten is amisulpiride. Again, very good, useful drug, hardly any side effects. You can use that, and there's sedation.
Thank you, sir.
So the drug will be 15 to 50 nanogram per deciliter. So I think it's mainly used in France and Europe. So they use clozapine for Parkinson's in psychosis. The dose is very small, like 20 to 50. You see more allergic reaction like cardiomyopathy or low white cell count, but no weight gain or no other problems.
We are using clozapine quite frequently in my hospital, even for Parkinson's associated with psychosis. 12.5, 25, 50, you just follow the patient in terms of his psychotic symptomology, and most patients respond also. They don't need very high dosages also. And Indians are tolerate clozapine very well, despite we do the assessment investigation protocol, but we have rarely found patients not to tolerate it.
Excuse me, madam. I am from Coimbatore. You are saying the stroke patient will have post-traumatic stress disorder, and if they are having severe that is panic attack at night, that is dreadful dreams, shall we use benzodiazepine, short-acting benzodiazepine on long-term basis?
See, with PTSD, therapy is the first line of treatment, right? Because it is a trauma that they have not been able to process. So therapy is the first line. When we do a good quality therapy, patient may not need sedatives for a long time. So long-term benz is not advisable. But short-term rescue,
But
it can be given.
SSRI antidepressant will not work on bad dreams. That every psychiatrist knew.
Yeah, see, as benzodiazepines, as REM suppressant can be used, trazodone can also be used. We have used metazapine also. I'm being very frank. But fluoxetine and fluoxamine, we try to avoid. But then they will not help in, nightmares, right?
Okay, I think we'll close with the last words from my co-chair.
Thank you. I think it's very apt to have a session on this, especially because of so many of the disorders having both neurological and psychiatric interfaces. More and more conferences are coming up with this, and I think I should thank the geriatric team, Dr. P.T. Shivkumar and Matthew Varghese, for bringing up this interface and having this interdisciplinary team, at least at NIMHANS. And this is a role model, at least for the other places. The speakers were wonderful. Actually, all the three of them did very good, especially about the interactions and how to read and when to do. So I think these were brought about very nicely by all the speakers. Thank all the speakers. And I thank the co-chair and the organizing team here. Thank you.
Thank you so much for the meaningful session. Now, I would like to invite Dr. T.S.S. Rao, consultant at JSS Hospital, to felicitate the chairpersons. Sir, please. Big round of applause. Thank you, sir. Now, I would like to invite Dr. Abdul Majid, consultant at SKMS Hospital, to felicitate the speakers. Sir, please. Thank you, sir. Thank you, chairpersons and the speakers. So, so we have come to an end of today's sessions. I hope you all have received really meaningful takeaways. Let's meet tomorrow for the further sessions. And before we disperse, let's have our delicious dinner. See you all tomorrow, and good night. One announcement. IGM members, please stay. IAGMH members, please stay back. IGMH fellows, please stay back. We'll be having a meeting here. Not all members.